Jojo is live. Please start. Jojo, you are on mute.
Sahil.
My apologies. Welcome again, everyone. Good morning. Happy vibes. Good morning. My apologies, I was on mute. Hi, everyone, again, good morning, and welcome to our second day of Asia Pacific Conference on Nursing Science and Healthcare, this December 2nd of 2021. Welcome back, everyone. And now, with no further ado, let's go ahead and invite our first keynote speaker for today, Dr. Jose Arnold Tariga, Nurse Education Coordinator, Amana Healthcare, United Arab Emirates, Dubai. Sir, good morning. And our Dr. Chidi Chiki Achibi, Chairman and CEO, IDE African Integrated Development Enterprise, United States. Welcome. Dr. Palladino Francisco Pio, Administrative and Legal Nurse in Health Management, Correct Application of the Health Safety Protocol, Italy. Welcome. Dr. Indrajit Bhattacharva, Director, National Accreditation Board for Education and Training, or NABET, Quality Council of India, QCI, former Additional Director, Center for Health Information, CHI, of National Health Portal, National Institute of Health and Family Welfare, former Professor, Indian Institute of Health Management Research, New Delhi, India. Welcome, sir. And now let us welcome our session chair, Dr. Vimala Ramu, Senior Lecturer, University of Malaya, Malaysia. Dr. Vasantha Kalyani, Principal, Department of Nursing, AIIMS, Jharkhand, India. Welcome. Dr. Sabanathul Misriya Jalal, Associate Professor, Department of Nursing, King Faisal University, Saudi Arabia. Welcome, doctor. Thank you so much, everyone, for imparting your time with us, even during this pandemic. And now let's go ahead and proceed with our technical. Our session chairs, hold on. All right, and yes, now let's invite our first keynote speaker for today, Dr. Jose Arnold Tariga, Nurse Education Coordinator, Amana Healthcare, United Arab Emirates. Doctor, good morning.
Good morning, Jojo, and thank you very much for having me today. Can you hear me?
I can't hear you.
Hello?
Oh, there, yeah.
Okay, so thank you so much, Jojo, for bringing the energy for this second day of the conference. And good morning, good afternoon, or good evening, wherever you are in the world today. And thank you so much for joining with us in this Asia Pacific Conference on Nursing Science and Healthcare. First and foremost, I would like to say a massive thank you to the organizing committee for having me here today and for giving me the opportunity to share some insights on how educators, particularly clinical educators, address the challenges that we have been encountering in the clinical area during the COVID-19 pandemic. So just a little background of myself. Um, I am a nurse by profession, but I am currently working as a nurse educator. I am currently based now in the United Arab Emirates, and I work in a long-term care ventilated unit. So I know that there has been a lot of changes in terms of um, healthcare education, nursing education, or medical education since the start of the COVID-19 pandemic. And even for those who have been working in the academia, can attest to the challenges that all of the educators have encountered. And for sure, it has also prompted us, or it has also given us a lot of challenges in the clinical area because of social distancing among many restrictions. So to start with, I just would like to declare that I don't have any financial disclosure or conflicts of interest with the presented materials. And for this session, we're going to look into exploring the challenges and transformations brought about by COVID-19 to the clinical education setting. We're going to try to discuss how clinical educators can effectively shift and adapt to the new normal, particularly in the way we deliver clinical education. And we're also going to look into the possible processes of rapidly bridging theory to practice gaps in the clinical settings during this pandemic. And I'm going to be introducing, for those who are not familiar, I'm going to be introducing you to the AD model of instruction, particularly for those who are doing clinical education. So before we start, let's look at first as to the challenges and transformations brought about by COVID-19. So there's definitely, and I think everyone would agree that there's definitely a lot of impact when COVID-19 started in 2020. And despite a lot of the progress in terms of managing COVID-19 has continuously ravaged our healthcare system. And the thing with COVID-19 is that it has highlighted the pre-existing issues being faced by us, by the healthcare professionals, and even with the healthcare settings that we have, or the healthcare organizations globally. Firstly, it has compounded the physical and mental exhaustion of our healthcare workers. So I think majority of you, especially for those who are working in the healthcare setting, has experienced having a surge of patients coming into your facilities. And even for the educators as well, because the task of, there has been an additional task of preparing modules, for example, and preparing your educational materials so that you can still continue delivering education, either you're in the academe or in the clinical setting. There has been compounded resource constraints. So in terms of resources, for example, we already know that not all hospitals or healthcare settings has enough resources in terms of the consumables or even the personal protective equipment. And with the advent of COVID-19, it has even increased those resource constraints. Staffing has always been an issue as well, even before COVID-19. And in fact, before COVID-19 started, there's already been reports from World Health Organization in terms of the staffing shortage, the worldwide staffing shortage. And of course, with COVID-19, because there was an influx of patients, then there has been an imbalance between the patient and staff ratio. And one of the affected area that maybe not everyone have realized is actually the clinical education and training. So one of the many challenges that we have really encountered with COVID-19 is the way we deliver clinical education and training. And among the challenges that we have encountered in the clinical education setting is there was a short notice on transition from face-to-face to e-learning. So with clinical education, the way we deliver training is mostly through a face-to-face approach, because most of the time when you are working as an educator in the clinical area, you go around, you do your rounds, and then you teach on the spot. You know, when there are nurses in the clinical area needing some training. So when COVID-19 happened, there has been a lot of social distancing restrictions. So because of that, we were forced to shift to another modality, which is e-learning. And honestly, majority of the clinical educators are sort of new to e-learning. Because unlike, and even I think even for the academic environments, the nursing educators working in academia, when COVID-19 hit, I don't think that majority of the schools or universities have been using e-learning. And I do understand that some have started using it, but not really to its full extent. So that's why there was sort of like a short and rapid transition from face-to-face to e-learning. And with that comes technological challenges. So majority, especially for the older generation of nurses, not all of them are actually well versed with the technology in terms of e-learning, and even for the educators as well, because the platforms were a bit new to us. It was also a bit of a challenge when we started utilizing platforms. So even Zoom before was a bit unfamiliar for us because we don't usually use Zoom when doing virtual meetings or communications. I think one of the most commonly used virtual platforms is your video calls in your Facebook Messenger, your Skype. So Zoom is sort of like new Teams and other platforms. And then there was restriction of activities with direct patient contact. So the thing that is a bit on the downside of this one is because of that restriction, many of the nurses, particularly the new ones, were not able to have that hands-on experience. Okay, there was lack of hands-on practice, and we all know that in healthcare, and I think everyone would agree that in healthcare, for us to become more skilled or for us to enhance our skills, it is very important for us to have that actual patient experience, the hands-on patient experience. There was suspension of clinical rotations as well for nursing students and even for medical interns. So, of course, because we tried to limit the number of staff or people in the healthcare units, there were time limitations in training delivery. So I think it was different, or it's a case-to-case basis depending on the locality or the restrictions imposed by the governments. But there was even a point wherein they really canceled all training activities, like face-to-face training activities, and they never allowed like even a minimal number of people to be cohorted or gathered together with the fear of spreading the infection. And of course, there was increased psychological distress that hinders the ability to learn. And majority, and I think you can attest as well, and you can observe now that most of the virtual trainings are mostly one-sided discussion. So like what's happening now, it's mostly me talking, and there's not that much interaction with the participants. But on the other side of it, it's not just mostly challenges. There's also transformations that were brought about by COVID-19. And as much as this was a challenge initially, in a way, I consider this as a transformation in terms of adoption of e-learning modalities, because it has somehow enhanced as well, and it has given as another perspective in the way we deliver education and training. And over the past year, since we started doing this virtual training, virtual lectures, we've actually realized as clinical educators that there are other, aside from the face-to-face way of doing the training, there are other ways or modalities of delivering training and at the same time ensuring that it is still effective. Of course, I'm not saying that we can utilize e-learning all the time, because as what I've said, in the clinical setting, when we are teaching nurses, registered nurses, we really need to do some face-to-face sessions as well, because you need to have the hands-on training. Virtual reality has also increased during this pandemic. So for those who are not familiar, and I think everyone might have heard already, sometimes we utilize our phones, and then you have some goggles that you can use your phones on, and then with virtual reality, we can simulate some scenarios, and then people can view it using your phone and that goggles. So that can also enhance additional or upskilling or provision of information in a different manner. And then there was also remote conduction of assessments and evaluation. So before, when we started doing trainings, we find it a bit challenging in terms of how can we assess the skills, because the usual practice is to do a demonstration from the trainer and then to do a return demonstration from the learner. But then of course, because we were not doing a face-to-face training, then we had to look for other ways. And then we found out that it's actually okay as well to conduct a remote conduction of evaluations. Of course, this will need for you to have the technology, the right technology. Like, for example, if you have a simulated room, then you might need to have more cameras so that you can really check as to how the learner is performing. And then there was an increase in telehealth and telemedicine. So most of the time, I mean, like before COVID, although there has been, I think there has the telehealth or telemedicine is not necessarily new, but I think there will, it has increased in terms of utilization. So majority of the healthcare organizations or healthcare facilities are conducting assessments via phone calls or via video calls, which in a way provides accessibility to services, particularly consultations. And then there was digitalization of healthcare. So as much as some parts of the world have been actively using electronic medical recording or has improved healthcare, I mean, like has adapted digitalization of healthcare, some parts of the world has not until COVID happened because they were forced to do it. So in a way, I considered all of these aspects as some of the transformations brought about by COVID-19. So how do we adapt as educators? How do we adapt to this new normal? How do we manage clinical education in this pandemic? So if we look at it with the current scenario, and I know that there has been improvements already. I think it depends on which country you are from. But majority, the current scenario is there's still restrictions of face-to-face trainings in clinical settings. And again, as what I've said, this has improved somehow over the past few months because of improvement in the vaccination rate, and there has been a decrease in the rate of morbidity or mortality caused about by COVID-19. But still, we are still not back to the old normal when we do the face-to-face trainings. So because of these restrictions that we currently have in terms of face-to-face trainings, as educators, we need to consider specific educational strategies that will address this problem. And among this will be the e-learning modules with virtual educator presence. And therefore, the key action plans for us should include or should involve module development using your learning management system if you do have, or if you don't have, maybe this is a good time for us to motivate our leadership or your organization to start looking at the possibility of having a learning management system. Educator training for virtual presence, because again, not everyone is used to talking or presenting virtually. So even for me, when I started doing these virtual sessions, I find it a bit challenging because I'm the type of educator who usually does the discussion and then asks questions or facilitates interaction. But like for this one, sometimes it's very difficult because I'm not even so sure if all of you are listening because I could not see all of you while I'm doing the presentation. So there really needs to be a training on how do we be virtually present so that we can still facilitate learning. And operations is another aspect because the educators needs to know how to conduct virtual trainings. There's a consideration in terms of knowing what platform are you going to use, even the knowledge of sharing your presentations or how to make your presentations engaging for the learners is an important aspect that we need to look into as educators. And if we look into the approach, there has been a massive shift in the way we deliver the education. So I think everyone is familiar with the pedagogic approach, wherein an education session is led by the instructor. And then eventually we have moved into an andragogic approach, wherein there is an equal responsibility between the learner and the instructor. But with COVID-19, there has been a shift again into a eutagogic approach, wherein there is more reliance on independent learning from the side of the learners. And there's only 20% reliance in terms of the educator presence. So in a way, we really need to motivate our learners to learn themselves. There needs to be an intrinsic motivation for them. And so that in a way, they will still continue learning and acquiring new knowledge and skills. So because of this shift and because of the utilization of e-learning platforms, educators, whether you're an academic educator or a clinical educator, must consider the different requirements in e-learning. So there are two main cohorts of requirements in e-learning, and we call those your technical approach and your technical approach, or your requirements. So for the technical requirements, this is for both your educators and learners. This will involve your device. Okay, so having the appropriate device is very important. That's one main thing, because most of the time, for example, when we do this session, and if you are just using your phone, sometimes it might be very difficult for you to see what is being presented, because if your phone screen is very small, then it's possible for you to really see the small fonts. Or if you're an educator and you're the one delivering the session, if you're using the phone, sometimes it might not be compatible with PowerPoint. So it makes sharing the presentation a bit challenging. Knowing or having the right operating system is also important. If you're using the very old operating system of your computers, it might not be compatible with your PowerPoint or whatever platform you're using. Even the computer speed and processor, as well as the internet speed. So I've encountered this a lot of times when we conduct trainings virtually, and sometimes people goes in and out of the session because of the poor internet connection, and that definitely can affect the way people learn and the way they absorb information. In terms of the technical requirement for educators, of course, educators are expected to be competent not just with the subject matter that they are teaching, but also with, again, the platforms that they are using, or the technology. And commitment is very important as well for us, for the educators, because as what I've said, it's not easy. And for those who have been doing virtual trainings, for example, you might have encountered a lot of challenges. So sometimes there can be technical difficulties, so you really need to be committed. And even preparing for your session can also take a lot of time. So in an actual session, for example, it's easier for you to bring notes, but then sometimes when you are doing a presentation in Zoom, if you're not very familiar as to how to make your presenter view or something like that, it will be very difficult for you to have your notes. And then communication and compassion, of course, is also very important. Communication in particular, because we as educators needs to have regular communication with our learners, because if you don't have, then you might lose the interest of your learners. And I can really attest, because even sometimes for me, when I attend, when I myself is an attendee of a virtual session or a virtual class, for example, sometimes it's very difficult if your educators or your teachers, for example, do not communicate on a very regular basis. Because sometimes you will just say that, okay, anyways, my educator is not communicating, and I will just forget about it. So communication is very important. It sort of reminds our learners that, okay, we are still having this education session. And of course, when you are designing the e-learning environment, you have to consider specific aspects as well. So first is you have to know your people, or you need to know your learners. What are their characteristics? What are their demographic profiles? Are they ready in terms of virtual training? And what is their literacy level? So if we really look into the characteristics, we all know that majority of the older learners might struggle with might struggle with virtual sessions. Not all millennials, as we call them. For the millennials, it will be very easy for them to maybe adopt, because they're very used to the virtual life, like having virtual sessions, using the internet to get new information. But for some, it might be a bit different. So that's why you need to consider as to how am I going to keep my learners engaged with due consideration of their characteristics, their level of preparation, or their literacy levels. And then you need to know your course. And I think this is a prerequisite for all of us educators anyway, that you need to know your course description, what is the purpose of doing your session, what is your focus, what are your expected learning outcomes. And you have to know your media or your process. So you need to consider, like when you're doing a training session, is it done in a synchronous or an asynchronous manner? So for example, what we are doing now is a synchronous manner. We're doing it live. We might have different timelines or time zones, but then we're doing it all together now, okay? But for asynchronous sessions, this can be recorded, for example, and then the recording can be viewed by other viewers or by other learners at their own pace, at their own time. Okay? And then another thing to consider in terms of media are your teaching and learning activities. So when we talk about virtual sessions, there needs to be, again, a consideration in terms of how are you going to engage. So teaching and learning activities, although I did not really include it here, but ideally I usually use gamification. I put some games in during my session, and then I put some interactive slides, where they use a Mentimeter or Kahoot or something like that to facilitate engagement. And in that way as well, I will know that, okay, my learners are still there, they're still listening, and they're still interacting. And that boils down to interaction as well. So as what I've said, interaction, particularly with this one, is very important, because sometimes, especially if we do not request everyone to turn on their cameras as well, as what I've said, we might not know what you're doing. Maybe some of you are just in your bed, sleeping, lounging, okay? And maybe you're not even listening, you're just turning this on, okay? And then know your resources as well. So again, consider the technology that you're using. What are the platforms that you have? So it's not just Zoom anyway that you can use as a platform. It depends maybe in your school. If you have a learning management system that you can use, some of those can also have this synchronous type of capabilities. Okay, so other than Zoom, you have Teams as well. You have Google Meet, Google Classroom, amongst many others. Okay, so these are some of the things that you have to consider when you're designing an e-learning environment. And if we look at the content of your presentation, again, we need to make sure, of course, that it is learner-centered. It needs to still be relevant with the curriculum that you are delivering, or the topic that you are delivering, but make sure that it is relevant to the roles as well of your learners. Interactiveness or interactivity of your presentation is very important, again, because if you do not have interaction, then it might not motivate your learner to do it. Engagement is another aspect that you have to consider. You need to make sure that you are using creative activities to develop and engage and motivate the learning experience. And of course, personalization. But I guess everyone, and I think this is what I like about e-learning modalities as well, because there is, in a way, personalization, particularly on how are you able to personalize it in accordance to the time or the pace that you are doing it. So to facilitate learner engagement, because I've been talking about learning engagement over and over again, we need to make sure that they are actively involved. So if you are using an e-learning platform, it helps as well to maybe put a discussion board and maybe put in some rewards for those people who post in the discussion board, like additional points, for example, because that is how you can actively involve them with your e-learning platform. And then you need to stimulate interest. Put in topics that might excite them, that are relevant to their role, or that are relevant to what they are doing. Otherwise, they will not be interested to participate in the discussion. Okay? Stimulate learning. So when you are putting in e-learning sessions as well, it's not just about putting in a very bland PowerPoint presentation or just a plain one, because you need to stimulate the senses. Okay? If at all there is a possibility for you to insert some videos, for example, to make your to make your presentation stimulating, then do it, okay? If it's relevant anyway to your presentation. And then be ready. Okay? Being ready with your presentation, being ready with the platform that you're using will definitely lead to learner engagement. Okay? So that is how we start preparing, or that is how we start addressing the shift from a face-to-face to a more e-learning side of clinical education. So another aspect that I would like to bring to everyone's attention, particularly in the clinical area, is there was a rapid surge of nurses. Aside from the shift of e-learning modalities, one of the main issues that we have encountered is that because of the staffing shortage, many of the new nurses who came in were actually not specifically trained to our service. So I think for those who are working in the hospital settings, they would agree that because of the staffing shortage, let's say, for example, if your unit is the ICU, sometimes you just bring in non-ICU trained nurses because you need more people to help out. And that is what happened to many organizations, and even to my organization as well. So in my organization, we are focused on providing long-term care for ventilated patients. So what happened was that because of the staffing shortage, we brought people in, and we realized that the staff were actually not trained to care for ventilated patients. So there was then a challenge as to how are we going to rapidly upskill them so that these nurses will be able to take care of these patients. So as a clinical educator, I adopted the ADI model of instruction. Okay, so in a way, it was helpful to understand what are the things that I might need to educate or train these new staff nurses with, so that I will be able to make sure that their skills, their knowledge, and competence are enhanced, so that they will be able to provide safe and quality care. So in terms of analysis, we started looking at their training needs. We started looking at the job description, amongst many other considerations. And then after the brainstorming sessions, we've started designing training sessions, such as modules and actual workshops that we deliver to this new staff. And then we developed the final materials. After designing it, we developed the final materials, we developed the assessment tools, and then we implemented them, conducted a training, and then we evaluated the effectiveness of those training materials. So I would like to show you an actual example, because I think I'm running out of time. I would like to show you an actual example of how we did, or how we used ADI model to address the staffing shortage brought about by COVID-19. So as what I've said earlier on in my discussion, there has been an increase in the staffing shortage, which is already identified by the World Health Organization. And this was not just, again, in my organization. I would presume that this was all over the world. And to address this resource constraint, many of the organizations, again, tried to bring in new nurses, majority of which are not experienced or trained to handle our specific patient population. So we've realized that there needs to be a way to bridge that theory to practice gaps, and that can be done through our transition modules. Okay, so what we did was, during the analysis phase, we conducted brainstorming sessions, and then we sent out training needs assessment survey to all the nurses, and we identified specific or core competencies. And then we came up with 3 transition modules. So the 3 transition modules was focused on how we manage ventilated patients, how we manage deterioration, and then how we manage mechanically ventilated patients. So after identifying those 3 modules, we then started designing the modules, and then we start looking at how are we going to deliver them. So what we did was we sort of did a flipped classroom, wherein we provide them with the reading materials, with the resources, and then we also meet, but with minimal numbers of individuals, of course, with due consideration of the social distancing restrictions. And then when we meet, we just then facilitate application of what they have read, okay? Because we've given them the resources or the pre-work before they come to our actual training sessions. Sorry. Just go there. Okay, and then we developed the training materials and assessment tools as well. So what we did in terms of the assessment tools is that we developed a checklist, sort of like an OSCE checklist, if you're familiar with the Observed Structured Clinical Evaluation, or OSCE, so that we can assess whether they are competent or not competent to perform it. Okay, so there was basically a rubric, a score of 1 to 5, and then we rate them depending on their performance. And then the expectation was, after the training, they should have a score of 3. Of course, before the training, we did do a pre-test so that we can have a baseline score. And then we did the implementation of the workshops that we have identified. And then we did actual trainings, bedside trainings, and then we conducted the assessment, the evaluation using the checklist. So the checklist were the basis in terms of how they perform at the bedside, and this was observed by preceptors and trained supervisors. Okay, so after we've done the training, so we have encountered, we have realized that there was actually really an improvement in terms of the competence and confidence of the staff nurses. So the competence level was assessed, as what I've said, by the competency checklist. And comparing the pre-test and post-test score, there has been an improvement. And then we've asked the nurses as well in terms of their personal perspective, and they said that the training has somehow really helped them to become more confident in terms of handling these patients, particularly for those nurses who were not familiar with handling ventilated patients. There was an improved performance as well based on the feedback from the multidisciplinary team. So what we did is that we also asked the other team members, such as the physicians, the allied health team members, to evaluate or to observe how these nurses have been performing from as compared to when they started. Okay, so a lot of them mentioned that there has been a massive improvement in terms of how they manage patients in terms of their clinical judgment. And of course, we also asked response or feedback from the patients and the family members. And there has been, based on the patient and family satisfaction survey, the results were also, has also shown that there was satisfaction and there was improvement in the quality of care. So in summary, COVID-19 has definitely created a paradigm shift in the delivery of clinical education. As you can see in the picture here, let's say that before COVID, the world was sort of like an island, and after COVID, I cannot really even say that this is post-COVID now because we are still experiencing COVID with this new Omicron variant, and who knows what will come in the future again. But there has been a massive change. And I think we might not be able to go back to the old normal, but we can still thrive in the new normal. So it's a matter of really adapting, looking at what are the possible opportunities or what are the possible modalities that you can use so that you can still thrive in the new normal. And I would like to end this presentation with a quote that there is no better educator than adversity. With the current scenario that we are in, it is very challenging. But then this is how we learn. We learn a lot of new things. Before we thought that it's impossible to use e-learning in the clinical setting, but then now we are using it, and so far we have proven that it can work. Of course, there needs to be some tweaks on how we do it, but it can definitely work. So these are my references. And if you would want to connect with me, I'm very active in LinkedIn. I will be sharing my email as well if you have some questions, or I think we still have time anyways for a quick Q&A. So feel free to ask questions as well. So thank you very much. That's the end of my session.
Thank you so much, Dr. Jose Arnold Tariga, for that speech, informative speech. Thank you so much. And now I would like to invite our next keynote speaker, Dr. Chidi Cheke Achebe, Chairman and CEO of IDE, African Integrated Development Enterprise, United States. Good morning, Doctor.
Can you hear me?
Yes, I can hear you. Good morning. Oh, good evening.
Oh,
My
good evening.
apologies.
It's actually,
yes, good evening.
it's 11 p.m. I'm trying to share my screen with you.
Thank you
Just a
so much.
second.
You are
All right.
still up? 11 p.m.
I am. Yeah, just one second. Let me just grab this. All right. All right. Can everyone see this?
Yeah, we do.
You can. Okay, let me do the slideshow.
Perfect.
Okay,
Thank you.
just a second. In the beginning. All right. How does this look? Can everybody hear me?
Yes, we can hear you
All right.
clearly.
Excellent. All right. Well, it's 11 p.m. here in Boston, so I believe it's morning. So good morning to everyone. My topic is going to focus on Africa, and it's going to be a nice, I believe, a seamless continuation from what Dr. Jose Tariga spoke about. And the topic is African healthcare in the age of COVID-19, the importance of nursing and nurse educators. So this is a busy slide, but it's essentially my bio. I've been a physician for 25 years. My background is in medicine, public health, and I have an MBA as well. All of this was garnered in the Northeast here in the States, so Dartmouth, Harvard, and Yale. And I've done a lot of administrative and clinical work. The outline of the presentation will have the following parts. So the background in Africa very briefly, Africa's healthcare challenges, which are many. We'll then delve into the impact of globalization and talk about the opportunity for nurses, the role of nurse educators, and then we'll also talk about how COVID-19 is transforming nursing and nursing education, but from an African perspective. And then I'll focus very briefly on telemedicine, which is one of my interests. So Africa is the world's second largest and second most populous continent. It has over 1.2 billion people as of 2016 and accounts for about 16% of the world's population. It's a rich and varied history and one of the most remarkable ethnic, religious, cultural, and I must say genetic diversity on the planet. Africa has 54 countries and territories. So the next time somebody tells you and refers to Africa as one country, please correct them. It has a fantastic and rich history. I'm going to give you a few examples here. Ethiopia, unfortunately, is engulfed in a civil war, but it's the home of several UNESCO World Heritage Sites. This is Lalibela. It's absolutely stunning from the 13th century. Of course, everybody knows the colossal statues of Ramses from the 1400s BC. And then this is from my home country, which is the mask of the Queen Mother from Benin in the 16th century. We're going to move from that beauty into some of the challenges before Africa. Sub-Saharan Africa continues to report poor health indicators with challenged healthcare systems due to the growing burden of diseases from everything from HIV to non-communicable diseases, as well as the COVID-19 onslaught and a severe shortage of healthcare workers. The shortage of healthcare workers threatens the sustainability of healthcare systems and negatively affects the achievement of newly launched sustainable development goals in many countries across the continent. Sub-Saharan Africa's worst hit region, with a shortfall of more than 600,000 nurses needed to scale up priority interventions. The UN estimates that Africa needs 11 million more doctors, nurses, and teachers by 2030, in 9 years. This is to prevent a social and economic disaster that could propel millions to migrate, according to the United Nations. The continent, as we know, is home to a booming population, with the number of children increasing by 170 million to 750 million just in the next 9 years. By the end of the century, 1 in 2 children worldwide will live in Africa. The UN's Children's Agency attributed the boom in births to high fertility rates, a rising number of women of reproductive age, and lower child mortality. Now, if we get things right, we could lift hundreds of millions out of extreme poverty. We could contribute to enhanced prosperity, stability, and peace, according to the head of the UNICEF's operations. But then, of course, if we get it wrong, we all know what that doomsday scenario could look like. Other challenges that Africa faces, investment in education and health are badly needed. Between 25 billion and 30 billion in new investment will be needed in healthcare across the region over the next 10 years. Investment also targeted at improving the sector's physical capacity, developing hospitals, clinics, and pharmaceutical distribution warehouses is critical. between 500,000 and almost 700,000 additional hospital beds must be added to Africa's existing base of just under 900,000 beds by just 2025, just to keep pace with this projected need and demand. In Nigeria, which is the most populous nation with 200 million people alone, an additional 100,000 beds must be added to keep pace with current demand. There's some trends in the healthcare arena in Africa that one needs to be aware of. Most of the action is focused around exponential private sector growth. My company, as an example, is raising international funds to build out healthcare systems, entire systems on the continent. Focusing on Nigerians alone, they spend about $1 billion on medical tourism annually. Now with some of this new development, we're expecting to see some of that reverse. One is to expect large investments in infrastructure, as I said, spurred by the private sector. There's a new hospital in Senegal that's just closed for $100 million. Michael Jordan's mother is building a pediatric hospital in Nairobi, Kenya, that's going to be over $200 million. And there are massive projects in South Africa, Nigeria, and other places. This trend will continue due to fundamentals that drive demand, population growth, increasing life expectancy, growing disease burdens, and patients' demand for treatment. It's important to kind of discuss the impact of globalization on all of this. Globally, the healthcare sector is industrializing. This is driven by connectivity to achieve greater efficiency and improved outcomes that satisfy demanding, informed consumers. This connectivity will reduce dependence on one segment of the hospitals and open opportunities for a myriad of service delivery models. This development will also give individuals greater control over their health and well-being. There's a high-tech and scientific component that provide great impacts. Healthcare is becoming a precision-based industry. It's produced by the genomic revolution that's pushing healthcare towards precision-based analysis and outcomes. The progress in genetic mapping and advances in both science and technology will make more personal, predictive, and preventative healthcare services the mainstay of a new generation of consumers. As health solutions become highly customized, we're going to find individuals will be segmented into ever smaller groups, requiring tailored treatment regimens. A new document and study that we completed just looking at the Nigerian healthcare sector identified 14 subsectors of consumers. So Africa is a complicated, it's not a monolithic, it's a complicated healthcare population. Now there are several opportunities for nurses, and I'm going to spend a few slides on this. Sub-Saharan Africa needs an effective and efficient nursing education system to build an adequate, competent, and relevant nursing workforce necessary for the achievement of Sustainable Development Goals set by the UN. The plan of action for scaling up quality nursing and midwifery education and practice for the African region provides a framework for this scaling up of nurses and midwives. Sub-Saharan Africa needs more reforms to increase capacity of the following: nursing educators and mentors, responsiveness of nursing curricula in nursing schools to universal advances and quality improvement strategies, transformation of regulatory ineffectual frameworks that have hindered improvements in the past. There's a need to provide improved and greater availability of infrastructure and resources from the government. Most governments spend less than 5% of their gross domestic product on healthcare, and that needs to change. There's a need to collaborate across the globe, and I'll talk a bit more about that soon, with nurse education bodies such as yourselves for the improvement of quality, quantity, and relevance of nursing education in sub-Saharan Africa. Now, there's a global consensus that nurses and midwives constitute the majority of the global healthcare workforce, and the largest healthcare expenditure for manpower development should therefore target this group. That's not currently what's happening. There's actually more money spent per physician than there is nurses. But if we're going to be serious about global health and strategies to combat everything, including COVID-19, we have to probably begin to rethink some of those priorities. Nurses form the universal access point for almost 90% of healthcare users. So this is so important that we begin to look at this. Considering the significance of nursing workforce within the healthcare systems, efficient production, successful deployment, and ongoing retention are key to ensuring improvements in the functioning and impact of healthcare systems, including ensuring universal healthcare coverage where those are available. And in the African continent, a number of countries have started that, and they're all in the infancy, but that's a good development. Now, there's a very important role for nurse educators. Efficient production of nurses with relevant competencies remains a critical role of nursing education. Now, these improvements in nursing and midwifery education are recognized as essential in increasing workforce numbers and enhancing the quality of healthcare and health systems. Traditionally, nursing and midwifery education has been offered at standalone training institutions with more emphasis on production of lower level cadre. Many countries on the continent, including Malawi, Zambia, Kenya, Zimbabwe, still have majority of their nurses at technician level rather than at registered nurse level. However, nursing and midwifery education in Africa has shown signs of development over the past 2 decades. And the World Health Organization reported that many countries have now included a master's or doctoral level studies in their programs. Nursing colleges in many countries on the continent are affiliating their programs to universities. And a number of UN bodies have particularly looked at Francophone countries, the former French colonies, asking them to introduce university education system for nursing education at particularly the undergraduate program level to improve quality. There is still a lack of necessary competencies among graduates due to lack of strategic leadership to drive transformation. A lot of the curricula are unresponsive to the world demands and demands of quality, etc. There's a shortage of nursing faculty. There's a shortage of teaching and learning resources, resulting into inadequate productive capacity of training institutions. Globally, nursing education continues to experience underinvestment, static and rigid curricula, lack of interprofessional preparation of nurses, and lack of coordinated collaboration and support from stakeholders. So how has COVID-19 transformed nursing and nurse education in Africa? We know that globally, COVID-19 has already killed more than 5 million people, stressed healthcare systems to the brink, and disrupted economies and societies. It's also created havoc in higher medical education. This has been particularly notable in global health, where travel restrictions have brought traditional clinical global health rotations to a halt. But these drastic changes in the learning environment offer an opportunity to rethink and improve global health education, particularly nursing and nurse education. The pandemic and forced travel pause may allow medical educators to refocus toward ensuring longitudinal and high quality programs rather than maximizing the number of trainees. They can also have a frank reckoning with finances, benefits, and sustainability of their programs. Educators should reconsider appropriate overarching learning objectives for global health. Can distance learning fulfill these requirements? Dr. Tariga mentioned this. In a large part of the West where I live here in Boston, this is already something that was highly developed even before COVID. And so it was a seamless transition. But in other parts of the developing world, they're in the infancy. And this is a great opportunity really to upscale and elevate standards. Is it truly a sufficient replacement for in-country rotations? Well, time will tell as we modify and adjust to this new dispensation. So medical and nurse educators need to re-examine the paradigm and assumptions and ground rules implicitly built into our belief systems of what constitutes effective global health training, and do away with the, if you like, condescension around online education once and for all. The pandemic has now forced academic global health partnerships to be locally driven in practice rather than often previously only in theory. This has also accelerated innovation in these partnerships, virtual collaborations, investment in mobile health applications, funding for local activities, and outstanding collaboration in global research. I want to shift a bit and focus a bit on telemedicine. Now, telemedicine presents a novel opportunity for the developing world. Opportunities abound in partnerships, collaborations with renowned global institutions. I'm working currently with a Chinese group that wants to partner with an American online medical education company to bring American style and standards in medical education to China. This is a roadmap for the rest of the developing world in how we can use an opportunity as dire as COVID-19 to elevate standards. It presents an outstanding opportunity for collaboration in global research and accelerating and enhancing quality of education, teaching, and practice. But local government should invest. They should invest in the mobile health applications. They should fund both hard and soft and the software needed for this global interaction to take place. The company that I have been working with is called onlinemeded.org. It's USA based. The curricula is used by over 300,000 people monthly, active users. They are working with 35 plus institutions, with several using it as their core curricula. And they're leveraging a hybrid model as well. They help institutions, faculty, and learners alike. Soon they'll be testing the ability of a medical school in a box from a knowledge vantage point in the coming year. This is particularly innovative and disruptive given how robust the curriculum is and how much data it generates to validate its utilization and outcomes. This technology can provide safe, patient-centered care. It can help improve health outcomes by providing quality, consistent preventative care across a variety of patient demographics and situations, and therefore in less affluent environments, this is particularly important. It poses an opportunity to lower costs by improving productivity and cost-effective care and creating a long-term and sustainable treatment model. And then finally, and very importantly, it extends healthcare in the community, particularly in places like Africa, by offering increased care, equality, and inclusion. Thank you very much.
Thanks so much for that presentation, Doctor. And also thanks so much for giving us this time even this evening. Again,
well, thank you so much. It's pretty late. I'm honored to have been invited. Thank you.
it's our honor. We really do appreciate it. And again, good night. Thank you so much.
Good night. Thank you so much. Bye-bye.
And now let's go ahead and proceed with our next keynote speaker, Dr. Palladino Francisco Pio, Saint Pio da Pietrelcina, Italy. Hi.
Hi.
Good morning. Good morning.
Good morning.
Good morning.
Cheers. Okay. Before starting the presentation, I would like to thank the organizers and all those who made possible the presentation of my report at the Asia Pacific Nursing. Good morning to everyone. I am Francesco Paradino, and I am advanced practice registered nurse and lead nurse in service at one of most important hospital of Southern Italy. And thanks to my study at the master's degree in law, I have deepened and developed attitudes towards the study of the laws, relating the deepened and developed attitudes towards the study relating to the professional responsibility of healthcare personnel. I state that in the report I will not deal with matters relating to law and the legal systems, as they are complex and different in each state, but I will illustrate the general line provided by the doctrine that the same systems dictate for the correct and appropriate performance of the role of the nurse within the healthcare landscape. In particular, I will report today relation topics focused on awareness and responsibility, which will lead us through a path that is not excessively articulated and complex. As certainly already discussed in our conference, it is very important to underline those aspects such as an ethics, professional autonomy, skills and responsibilities are aspects that nurse always faced in his daily life. So much so that in recent years, thanks and above all the evolutionary changes that taken place with important laws and improvement in professional didactic training, passing from what was defined and an auxiliary activity for nurses generated by the dominant position that the medical profession has exercised for years. We have witnessed the full legal and formal recognition of this figure, recognizing its validity on a legislative and social level. This professional figure and this legislative evolution of the various countries has led to a profound change regarding professional autonomy, which consequently raises new questions and the subject of responsibility. The nurse, from a simple executor, becomes an active professional by promoting projects and objectives, working in a team with a consequent responsibility. University have the duty to implement training courses dedicated to the safety and care, and in parallel, this path must necessarily be developed also by health organizations which, at the same time, should compatibly with their own organizational possibilities, establish the opening of so-called risk management units composed of medical professionals and nurses with particular aptitudes and inclination to the study of adverse events and safety of care through specific indicators, as well as favoring continuous specific of care through training course starting with the nursing leaders who have an important supervisory role over their collaborators. Moreover, the staff of these risk management units could also have the role of developing, with active involvement of other health professionals, operating procedures and protocols, in order to guarantee quality and, above all, safe care. All this would certainly favor an increase in the skills of the personnel concerned. A particular aspect to take into consideration as another side of the same coin is also that organizing of a new way of working which generates important incentives in the motivated health professional, placing him in the condition above all to carry out his work in security, but also to carry out in a complete safety way. It will result in a better quality of life for all and the psycho-emotional sphere, with a careful reduction in the risk of burnout. Not only, but above all ourselves. What would happen if we were to find ourselves being patient? Of course, we will demand to utmost in safety and competence from nurses. Nowadays, it is necessary to have a nurse aware of their role, but above all, they must reflect three very important factors: competence, autonomy of their actions, and responsibility. As regards the aspect of the competence, it is now clear to everyone that the care provided in the healthcare environment is very complex activities and involves a large margin of error. Therefore, it is absolutely necessary that the nurse is aware of his role, but he is competent and with particular professional aptitudes. Competence is a fundamental prerequisite for quality and safety care. Consequently, professional competence generates the professional autonomy of the nurse, but above all, makes it possible from him to take responsibility for his own actions or omissions. Here is the reasons why these three aspects are linked together. First of all, in carrying out his profession, the nurse's ethical has a particular obligation of solidarity towards the patients, combined with the obligation of guaranteeing the protection of the patient's health to whom the patient's most precious goods, which are health and the life itself. Therefore, in the guaranteed position, they can be divided into fundamental types. Position of protection, as the purpose of safeguarding certain legal assets from any form of danger that may threaten their integrity, or position of control. On the other hand, it has the purpose of eliminating the sources of dangers with the intent of guaranteeing the integrity of all legal assets. With the increase of the responsibility level correlated to the complexity of the level of care required by users and organization of work, the action of the nurse is inevitably projected towards greater autonomy with a high level of skills. This combination of autonomy and skills only increases, indeed further enriches, the care processes that require an ever more particular and different decision-making responsibility, with particular attention oriented towards the analysis of results and an outcome. For this purpose, in relation to this level of responsibility and competence, the nurse cannot fail to consider these two very important variables: the subject variables, and we have relational and communicative aspects, personal culture, and professional autonomy and skills, or objective variables, and we have organizational aspects. Autonomy is required, meaning the possibility of exercising assistance activities in the areas of one's competence and in relations to the protection of the patients, effectively and efficiently. Or juridical aspects. It requires responsibilities and is the set of consequences to which the individual is exposed on his own or on behalf of others is carrying out private as well as professional actions. The nurse, therefore, chooses in total autonomy and assumes responsibility for their actions and decisions. The professional responsibility of the healthcare professional arises from an inadequate performance that produces negative and or undesirable effects of the patient's health. Therefore, in the light of the legal evolution and with reference to a careful analysis of the persons responsible for his action, our profession has evolved. This is a fact. The training, the ontological and legal structure that outlines its peculiarities is extremely articulated and unequivocal. The impression is that if one do one, and the nurse has always demonstrated, in fact, his decisive role in the health system, his ability to bring a qualitative service to the user. On the other and above, all in some contexts are all in some, in reality, he is not yet quite ready to declare his professional status. Being aware of who we really are in the healthcare landscape means becoming aware of the responsibility is centrality of two key concepts of our professionals, autonomy and responsibility. Today, and more than ever, and unlike in the past, we need to be aware of our professional profile, as the set of law and the legal norms considerably evolved in recent years, in consideration of the numerous provisions issued as revealing the particular protection of the good health for the patient. Awareness is that process that implies being aware of something through the attention placed in observing, listening, and interpreting what one hears, sees, and above all feels. When it comes to awareness, we must start from the assumption that is based on a culture and direct personal experience. Responsibility is the ability to answer for one's choices, actions, or omissions, and the related consequences that derive from one's behavior. Over time, the professional skills of nurses have evolved to such an extent that they pass from heteronomy to professional autonomy by implementing management and planning skills of organizational methods. From the task as any end itself to the care results by implementing the ability to know how to choose an appropriate care program and to verify the results, also developing awareness in acting, and consequently, there will be no autonomy if the nurse does not feel responsible. Professional responsibility applied to nurse refers to the ethical and moral obligation that permeate the nursing profession. These standards cover patient care, collaboration with other medical professionals, integrity, morals, and responsibility to effect social change. Nurses must learn these rules through their school, whether they are becoming a registered nurse or certified nurse. Ethical violation could result in the state nursing board losing their license or discipline. But what determines the competence of a nurse? Competence, understood as the achievement of knowledge, intellectual abilities, competent practice, integrity, and professional and ethical values required for a safe practice, emerges from a series of closely related factors, such as interpersonal skills and abilities to relate, to ability to think critically, by the continuous and updating in one's professional field, and, last but not least, by the ability to know how to integrate within the team and work in collaboration with other health professionals. Competence develops and acquires over time. Through critical thinking, it must be re-evaluated and reconsidered in the face of a new practical situation, and the event that a delegated assignment is received, the nurse must evaluate whether he has the skills to carry out the task and if he has a skills deficit. He must refuse the assignment, motivating it to your nursing leader. Sorry. All this must also happen on the part of the lead nurse, that is, have the skill to delegate. Being a responsible nurse, it's also about maintaining your own level of competence. The basic training for the nurse must necessarily include, nowadays, particular insight related to the professional and the legal responsibility which he will face, with reference to one's own state and the related legal system. A different form of legislation emerges that governs the responsibility of healthcare professionals. Teaching through adequate training often does not take place adequately during studies, because in reality there are no teachers adequately training in legal subjects and who can adequately educate students. Having highlighted how the jurisprudence is now in agreement in tracing the various hypotheses of the responsibility of health professionals, it is necessary to examine and understand the constitutive elements of this responsibility. That is, first of all, the non-fulfillment of a professional health service. To better understand when a non-fulfillment in the field in questions can be envisaged, it is necessary, first of all, to reflect one of the notion of the health obligation. One of these is social contact responsibility. It is a particular form of contractual liability, which arises not from a contract, but from a legal obligation and from social contact. That is, from a relationship that is established between two subjects by virtue, but of a legal obligation or as a consequence of another contractual relationship established between subjects other than those of this social contact. In other words, it is a form of a contractual liability that arises not from a contract, but from another legal relationship. To understand the figure well, we must go back to the category to which social contact relationship belong, that is, de facto, contractual relationship without there having been the meeting of consent. In this regard, two opposing perspectives we have been considered for a long time by doctrine and jurisprudence. Result obligation, in according to which the healthcare professional would also always be obligated to achieve the results normally associated with the service object of the professional assignment, or obligation of means or behavior, according to which the healthcare professional would be required to lend his intellectual work to achieve a certain result, but without being burdened, whether the case may be with the duty to achieve it. The dominant opinion in the health sector, at least in jurisprudence, has always believed that the health service falls within the obligation of means or behavior and not, instead, in those of result, as the obligation that the professional assumes towards the user, as a result of the acceptance and assignment given. The performance of the necessary and useful professional activity in relation to the specific case and its view of the results that through the technical professional means the users hopes to achieve. The professional, therefore, has the duty to carry out the necessary and useful professional activity in relation to the specific case, and has the duty to carry it out with the necessary diligence. Among the typical duties that characterize the obligation of the healthcare professional, the duty of diligence is of central importance. In this regard, it should be noted that, since it is a professional obligation, the model of diligence to which the healthcare professional must comply is that of qualified diligence. Thus it was specified by the legal doctrine according to which, for the healthcare, the parameter of professional diligence is applied in place of the traditional criterion of diligence, a parameter to be commiserate according to the skills developed, to the nature of the activity carried out, and without overriding them in any way by exceeding in performance not within its competence. As already reiterated previously, the work of all healthcare professionals is a very complex and articulated job that requires particular experience, skills, and competence, and, with the passage of time, an exponential increase of malpractice litigation has been observed. As to the team activities, it is a very worrying fact for health professionals that configures the important aspects of team responsibility. In carrying out teamwork, leading legal scholars have observed these aspects for a long time by studying it in depth and arriving, through the behaviors or conduct of various health professionals, to develop important concepts of legal doctrine linked precisely to the responsibility of teamwork, outlining the behavioral guidelines of the so-called trust principle. The principle of entrustment emerges in situations in which there is a plurality of subjects to protect the same legal asset, the patient's life, on the basis of specific duties and roles divided between the various health professionals, as happens, for example, in an operating room team. Each co-participant should have the opportunity to concentrate on the tasks and roles entrusted to him, trusting in the personalism and of others, for whose negligent conduct he cannot, at least in general, be held accountable for responsibility. It is a principle of the acts as a limit of the duty of care imposed on each holder of the guarantee position. However, this principle does not operate in an absolute way, because we want to avoid that their mere application of the assignment entails that each operator of the team may be completely disinterested in the work of others, with the consequent risk associated with coordination defects between the various operators. The doctrine is oriented in the sense that, if the culpable conduct put in place but the single health worker occurs during a health service, the other health workers of the team will not answer for the negligent conduct, but, being mutually interested, all in the same team have the obligation to protect the health of the patient's safety, to intervene even promptly if they detect errors in practice or procedure by another members of their own team, observing, as described above, the principle of professional diligence according to which of all required based on their skills to provide safe and quality care to the patients. In this regard, which particular reference to the independent or interdependent conduct or behavior of the various health professionals, some aspects are outlined below. At the first one, the criteria for attributing the ability for negligence are related to the degree, specialization, and experience of the health worker. At the second one, a direction and control function is attributed to the team leader or lead nurse, who has a higher guarantee position than the other members of the group. The third one, teamwork is framed in the context of concurrent multi-person activities, so that any criminal liability of the operators falls within the scope of negligent cooperation, if no other healthcare workers intervene in correcting the error of preventing it from occurring. Frequently, I see conflict in most of my nurse colleagues. They desire to not take responsibility. This desire is associated with an almost a total lack of self-awareness and awareness. Unfortunately, these colleagues are not yet professional, ready to get out of the mental cage of their conditioning. They still want someone else to give them the answer as well as the right solution, and they are also looking for someone on want to take responsibility, good decisions, and things above all for them. They are not yet professionally ready to take full responsibility of their works. We nurses have long to make progress by creating such difficult knots, and it is up to us to untie them. In this regard, I would like to quote a thought of the philosopher Socrates, who lived in ancient Greece, and he made the most important contribution to the history of philosophical thought by applying it mainly to the examination of fundamental ethical and moral concepts. For this, Socrates is recognized as the founding father of ethical or moral philosophy. The secret of change is to focus all your desires not on fighting the old, but on building the new. Thank you very much.
Thank you so much. Thank you so much for that informative presentation.
Thank you.
Really do appreciate your time with us. Thank you so much. And now let's proceed with our next keynote speaker, Director, National Accreditation Board for Education and Training, Quality Council of India, former Additional Director, Center for Health Informatics of National Health Portal, National Institute of Health and Family Welfare, former Professor, Indian Institute of Health Management Research, from New Delhi, India. Let us welcome Dr. Indrajit Bhattacharya.
Thank you,
Dr.
Jojo.
Hi.
Thank you. Hi.
Welcome. Good morning.
Good morning and good afternoon, good evening for everybody in all parts of the world.
True.
I hope I'm audible to everybody.
Yes, you are.
So allow me to share my screen.
Please go ahead.
Is my screen visible?
Coming up. Yep, it is.
Okay, so I'm very happy to be the part of this Asia Pacific Conference on Nursing Science and Healthcare. As my topic is going to be the healthcare amelioration, challenges and threats. So as Jojo has background, I am an electronics engineer with a PhD in healthcare IT. Currently I'm the director in the Board for Education and Training, Quality Council of India. And earlier I was in this space of Telecom Sector Skill Council, where under the Ministry of Skills, wherein we promulgated a program on telehealth professional. It is so important because my whole talk is going to be driving data-driven healthcare. So I just wanted to emphasize on this, how from each and every statistics of human body and the healthcare indices can improve only once we follow the data-driven healthcare culture. So before that, as it is mentioned, this is profile. I was in the Center for Health Informatics, so that through the National Health Portal, so that the people of the country get knowledge about addressing the various healthcare challenges in the country. And I have been as a faculty, as the first faculty of healthcare IT in the country between 2008 to 2013. I was teaching health IT as a professor at IHMR Delhi. And before that, I was with the National Institute of Electronics and IT, wherein we promulgated, I was a member secretary of a course called bioinformatics. That is also one of the first of its kind. And another 10 years of my career, from the beginning of my career, I was a cath lab engineer, starting my career with both Siemens and GE, and then core, basically into the space of medical engineering. So with that, I move on to the first slide of, I'll just give a quick overview of what Quality Council of India is. It is an autonomous organization under the Ministry of Commerce, is the nodal point. And the national accreditation body has been established to lead the quality movement for undertaking the national quality campaign, with our chairman appointed by the Honorable Prime Minister of India, Mr. Adil Zainul Bhai, whose photograph is in the top right. And he has been in the McKinsey for over 34 years, an alumnus of IIT Bombay and Harvard, and has been nominated by the Prime Minister of India. And our Secretary General is Dr. R.P. Singh. He's been the alumnus of VHU and the Western University of Canada, and has been appointed by the Honorable Minister of Commerce and Industry. So we get nominated by various ministries in the government and state governments for various projects due to the role in quality and accreditation space. So this is this organizational structure where we have 4 bodies, which is in the accreditation space. The first body is in the accreditation of certification bodies, and I come from this accreditation board for education and training. Then we have a very important body of accreditation in hospitals and healthcare providers, NABH, which is parallel to JCI, which you all must be knowing. Then we have another body called a body for testing calibration laboratories, NABL, which is in the space of accreditation of labs. And other than that, we have a quality promotion body and special promotion project groups under project planning and implementation, project analysis and documentation, and zero defect and zero effect group in the space of industry, which I'll tell you later. So this is what the organization my board is looking at. We are looking at the formal education excellence division in the K-12 space. Then we have the environment division, which is looking at environment impact assessments, groundwaters, and mineral sector. Then we have the skill training sector, which I am looking at is the learning service providers, as well as the micro, small, and medium enterprise of lean manufacturing competitive scheme, which is in the space of manufacturing, and soon we'll get into the area of services, wherein you all are very much aware how lean is important. Lean approach is important in the hospital and healthcare space. So this is the framework of the higher education space, wherein we are looking at the educational organization governance, infrastructure, curriculum, inclusivity, sustainability. And you all know with this last 2 years of COVID, where most of the education sector has gone in on the online space, and my previous speaker also had mentioned, we are also started offering an online distance and blended learning modules, accreditation of that as well, which I'll show in the next slide, as well as special education, the B.Ed, sports nutrition, etc., and specialist institutions like industrial training institutions, polytechnics, and diploma courses. So this is a very important slide, which is which shows the what is happening in the country in the research space. So we have these 2 important schemes of the government of India, which is promulgated by the Ministry of Education. One is called as the Uchitar Avishkar Yojana, and second is the Imprint scheme, which is impacting research and innovation in technology. So if you see these domains, wherein healthcare, information communication technology, energy, sustainable habitat, nanotechnology and hardware, water resources and river systems, advanced materials, manufacturing, security and defense, and environmental science and climate change. So as you can see, these domains were bucketed in 10 domains, where in the proposals were invited from the STEM domain areas. But when we started doing the third-party evaluation of those, we saw that these are all multidisciplinary, because now it is not only in one area that the research is being conducted. It is in multidisciplinary, and now there is a new word which has come up, which is called as pluridisciplinary. So one cannot say that I will just stick to healthcare, and the healthcare is the only domain which I will stick to, because it is all cross-relational. So many areas together are now doing research together with many facilities and multidimensional. And as I said, it's pluridisciplinary now. So in the leading technology institutions of the country, such as the Indian Institute of Science and various IITs, which is Indian Institute of Technology, and NITs, National Institute of Technology, all these are being conducted. There are 450 projects which are going on. And now at IIT Kanpur, which is in the Kanpur, there is a school for medical research and technology, which is coming up in the campus of engineering campus. So you can very much see where we are moving. So this is another scheme of the Government of India's prestigious scheme under Indian Institute of Science, which is the STARS scheme, which is Scheme for Transformation and Advanced Research in Sciences. So there again, you have the thrust areas of physical science, chemical science, biological science, nanoscience, data science and mathematics, and earth science. Out of the 140 projects that we evaluated, we saw that 40 projects are in the biological science area, which proves to say which is the growth area amongst all this. So a huge, this century is the century of biology, as it says, and there has been an exponential growth in our understanding of complex biological process, evolution in human biology, and the application of conceptual understanding of genetics, evolution, biochemistry, and molecular biology. So you all must be aware of this TRL, which is technology research, technology readiness level, and wherein the technology which is researched can be put in a bucket of this, which is from idea to basic research to technology formulation to needs validation to a prototype where a large scale or a small scale prototype is conceived, a validation of the prototype with demonstration of the same, and with first level and full commercial application. So these are the indicators one has to look at if one has to check for the institutes. That is the training institute governance, the leadership and management, and learning centricity and alignment for the faculty, course, learning delivery, and the training development. And the training and support process indices would be at looking at the infrastructure, both digital and physical, the innovation impact, as well as the feedback mechanism. So now if we look at the blended learning mode, which I spoke of, we have developed, conceived of an accreditation scheme, which is in the lines of 21001, which is the Education Organization Management System, and 1702993, which is on learning service provider. This looks at the effectiveness of training online. The aspects which are looked at are trainer, infrastructure, program design and delivery, as well as the training management systems with 3 dimensions of hardware, software, and skinware. Now, going forward from here, we saw that there is a need for a maturity assessment model required for education edtech tools. As you know, the edtech tools are now so much of prevalent once we have gone on the lockdown situation and everything is delivered online. So various dimensions of the edtech tools today, which are available in the market, can be bucketed in these 5 areas, which is the intelligent tutoring system. We have put it at a weightage of 30%. The educational management information systems, we call it as EMIS, which we have given a weightage of 25%, which would encompass tools of CMIS, which is campus management information system. Then you all know that we have to move from the rote-based learning to research-based learning. And the same is also the thought process of the Government of India's NEP, which is the National Education Policy 2020. We have kept a weightage of 20% there. Then the degrees of automation. As we know that the faculty has to be at the center of the education, has to be a driver of the same. But we all know that when we go online, we have the AI tools which prods the students personalized learning. So this is a situation where we are heading towards the degree of automation in the similar lines of driverless cars, which is again prevalent, which is happening in the West, and which is a research topic, and which is also in practice in some countries across the world. So even in the teaching front also, we have a degrees of automation to scale, which with the faculty in the center, faculty as the driver, as well as autonomous teaching. We have kept a weightage of 15% there, and a very important sector element of IT security, ethics and standards, with the element of accountability, explainability, transparency and privacy when we go online and teach and learn online, which we have kept a weightage of 10%. So if you are listening to me across the whole world, I'd like you to just comment whether you agree or you disagree with this kind of a maturity assessment model. Please respond with your credentials, and I've given my email ID there as ib.dabet@qcin.org. Once again, my email is ib.nabet@qcin.org. So this is what the proposal is, to prepare a maturity assessment model for evaluation of EdTech tools in the institutions of learning that we have all across the country and all across the world. Moving on, we have the lean comparative scheme under the Ministry of MSME, which which you all know is a technique to help improve the quality, eliminate waste, reduce total cost. So this has been in implementation in the country since 2014, and we have observed that across over 2,500 MSMEs, that is small industries, which it has been implemented, the return on investment has gone over 7 times, and there has been a huge improvement in productivity and various other parameters. And the same is now conceived for start getting implemented in the service sector, starting the healthcare also, healthcare and the hospital sector as well, so that the lean approach could be implemented in the services sector. So this is the important element of Internet of Things, which is going to be a key driver in the healthcare space for measuring the vital statistics of human body. So we have a network of physical objects, if I can define the Internet of Things, so which is called as things that are embedded with sensors, software, and other technologies for the purpose of connecting and exchanging data and other devices and systems over the internet. This is an Oracle definition, and with the elements of Internet of Things, as you can see on the screen, are data, sensors, remote control, gateway, cloud, as well as appliance and device. So it has, the IoT has applications across all sectors, and if you see on the red colored illustration, which is in the area of healthcare. So I'll take you one example here. This is telemedicine, Internet of Things, with various areas of agriculture, everyday things, building management, vehicle asset and asset monitoring, smart homes, and in telemedicine and healthcare, it has a very strong role to play. This is one example which I wanted to share with you. Is there's an organization called Life Signals, which has come out with the IoT, which is the Internet of Things, with just smart monitoring of a small monitor, one wearable biosensor, which one can put on the right side, and it starts giving you all vital statistics which are FDA approved, and multi-parameter patch, which one is able to continuously acquire and transmit core biomedical data, both wirelessly as well as remotely. So this is just a $1 sensor which one can use, and it gives so much efficiently all the vital statistics of the human body, which can be of huge help both to the point of care, the nursing, as well as the doctors. This small device can be extremely beneficial. So the advantages of the wearable biosensor is innovative technology, disposable and affordable, a multi-parameter data, reliable and secure. That means it is HIPAA and GDPR compliant to the cloud and data transfer, the clinical grade accuracy. That means it is proven reliability, accuracy, and usability that meets the global and regulatory requirements. So to look at how the central government is doing is in the National Digital Healthcare mission, which the government of India has. On 15th of August, the Honorable Prime Minister announced this with a vision of having a national digital health ecosystem, a universal health coverage with having efficient, accessible, inclusive, affordable, timely, and safe manner delivery of data, delivery of services, and data with information and infrastructure services with leveraging open, interoperable, standards-based digital system which ensures security, confidentiality, privacy of health data related personal information. So what do we have in this space? We have the health ID, the healthcare ID, which is based on Aadhaar or our ID card of the country, which the country has issued, the mobile number of the patient, and more than 100,000 IDs have been issued with voluntary service to be availed by the citizens. The DigiDoctor, having the registry for healthcare force, more than 1,500 applications have been received currently, and the health facilities registry with the National Health Resource Repository leveraged with 400 facilities opted to be a part of the NDHM ecosystem, voluntary for hospitals. This is a very important element. The PHR is controlled by the patient himself, and that has to be interoperable with the EMR, electronic medical record. And the electronic medical record, over a period of time, a longitudinal control of the electronic medical record would lead to the electronic health record. And to make this happen, one has to have the interoperability standards in place and the health information exchange to be in place. So while this is going on in the government space, in the private space, we have the Innovator, which is one of a startup organization and has reached the unicorn status. You know, out of the 80 unicorns that has happened since 2011, this year, that is the 2021 in India, has been the year of unicorn with over 40 unicorns only in 1 year. This 2021 has been a year of the unicorns, where Innovator is one such organization which has been able to make a health information exchange where the data exchange is going to happen with the various providers which are there, the healthcare providers, as well as the healthcare payers, the various stakeholders in the healthcare system, the patient relational management solution, which is there. And it is being used by several governments and private institutions to maintain medical records of more than 3.8 million patients and generates a savings of 400 million patients for healthcare providers. So this is a solution which is there. And you know, this has been a research subject since quite long, because many of the leading countries have already put in place the health information exchange, but not able to check the costs which are going up day by day. But such a system here in India, since we are a clean slate in India, so these experiments are on to put in place so that the correct model is being implemented, and which brings down the healthcare costs and drives the healthcare costs down in India. Another role that we have here at QCI NABET, my organization, is in the space of cyber security management. So this certification of cyber security management of critical sector entity is going on, where my board is looking at consultant organizations in the cyber security management space and the accreditation of training providers who are going to be in this securities management space. So I come to my last slide. This is the Industry 5.0, which you are aware of, driven by Michael Rada, which talks about the sustainable industrialization, the first industrial revolution ever led by man or human. So the concept of what Michael Rada says is it is not as industrialization, it is an evolution. It is not an industrial revolution, but it is an evolution where the mindset of people and businesses should be from wasteful to wastelessness, delivering results with the need of capital investment based on principles of systematic waste prevention, of industrial upcycling, utilizing existing and the use of rich on-the-ground mines, and based on transparency and profit sharing and efficiency. So Industry 5.0 is not a sales tool or a product. So with that, I conclude that the IoTs has to be, the Internet of Things have to be secure by design, has to have privacy by design, has to have simplicity by design, and has to have trust by design. Thank you very much. Over to Jojo.
Thank you so much for that informative presentation. Thank you so much, Doctor.
Thank you.
And really do appreciate your time. Thank you so much
Thank you.
being with us today and for sharing that. Thank you.
Thank you.
And now, before we proceed with our technical sessions, of course, my favorite part of the conference, the group photo. Everyone, please, I would like to request to open their cameras so that I will be able to get my remembrance. Please smile and hold it. I have 7 pages, so I have to take 7 pictures, right? Please bear with me. Open cameras, please. And ready? 1, 2, 3. Smile. First one. Hold on. Second page. 1, 2, 3. Cheese. Let's do it again. All right. Are you ready, Maria? All right. 1, 2, 3. Say cheese. All right. Third page. 1, 2, 3. Smile. Fourth. Fifth. 1, 2, 3. Smile. Last 2. 6. And last one. I like it when I hold my smile for 10 seconds. All right, you can now relax. I'm done. Thank you so much, everyone, for your cooperation. Thank you so much. All right. And I will give you time to breathe and prepare all your presentations. I would like to remind all the presenters to please be mindful of our allotted time. So you are expected to present for 10 minutes, a total of 8 minutes for the full presentation, and allotted time 2 minutes for the question and answer together with our session chair. All right, please be mindful so that we could all be on schedule. All right, we'll go ahead and have a tea break, just 15 minutes. Yeah, I'll give you 15 minutes. Then when we get back exactly 15 minutes, we'll start with the technical sessions. You can go ahead and grab a drink, guys. All right, get 1 more minute. Let's be back. All right, everyone, welcome back. Welcome back. And now let's go ahead and proceed. I would like to welcome everyone to our technical session 1. So technical session 1 is about nursing education. And I would like to welcome our session chair, Vimala Ramu, Senior Lecturer, Department of Nursing, University of Malaya, Malaysia. She had more than 28 years of experience in teaching, published many papers in national and international indexed journals. Welcome. Welcome, Madam Chair. You're on mute. Again, welcome, Madam Chair. All right, then let's proceed with our first presenter. Let us welcome Miss Bishnupriya Lenka, KIIT, India. The topic is about the prevalence of gestational diabetes mellitus and associated risk factors among antenatal mother attending at a tertiary care hospital, Bhubaneswar, Odisha. You're on mute too. Can you unmute yourself, please? There. Bishnupriya?
Yes, ma'am. Good morning, ma'am. Yes, ma'am. On mute, ma'am. I'm sorry. Thank you, ma'am.
Go ahead, please. I would like to remind the remaining presenters, again, your allotted time is a total of 10 minutes. 8 minutes for the full presentation. So please manage your time, and 2 minutes for our session chair to ask questions. And also, please have your presentations ready so that once we call your name, you are ready to share your screen. Do you need more time? Um, Vishnupriya, do you need more time? All right, let's go ahead and proceed with our next presenter. I would like to invite Ms. Q Manjulio Abunmai, SGT University, India. The topic is about a study to assess the level of internet addiction and its association with depression and insomnia among students of SGT University. Miss? Hi, you're on mute. You're on mute. There you go. But we cannot hear you. I can't hear you. Can anybody hear her, or is it just me?
I can't do. I can't hear her too.
Please check if your mic volume is on or full, because you're not on mute already. And yeah, we still can't hear you. For the remaining presenters, so please do check your equipment prior to the conference, just to, you know. Are we good? How about if you remove your headset and use your laptop's mic? Maybe that will work. Yeah. No, unplug it from the laptop and see if that will work. Did you unplug it from your laptop, your headset?
Hello.
Yep. Then unmute yourself. All right. I'll give you time to fix that. I'll just call you back later. All right. Next
Hello.
present.
Hello. Myself Usha Shande. I will be ready, madam.
Oh. All right. Go ahead.
Can I start?
Yeah.
Hello. Am I audible, madam? Hello.
Yes, you are.
My screen is. Can you able to see screen?
No, it's not.
Now, madam.
No, it's not.
Okay, then I will also need time. Just a minute. Now it's, yeah. Hello.
Yep, it's there. Have it.
Yeah.
Go ahead and have it in presentation mode, and you have 8 minutes.
Yes, madam. So my topic is a descriptive study to assess the parents' perception regarding their involvement in learning activity of their school-going children in selected area. So myself, Usha Shende, lecturer working in Kasturbha Nursing College, Sevagram. Next. My co-guide is Dr. Jayant Wagh and Mrs. Archana Moria. And now the introduction of topic is research shows that when parents are involved in their children's education, so children are more engaged with their schoolwork. So stay in a school longer and achieve better learning outcomes. This also translates into longer term economic and social benefits. So parents' participation is defined as we have to identify the needs, questions about their children's homework, approach a teacher, and also observing every single move a student makes. So the furthermore, parent participation comprise parent-student communication, family rules with consequences, parental support of academics, parent-school communication initiated at a school level versus the teacher level, as well as the parent checking on homework also. The level of parental participation in education is a remarkable concern among instructor. So because there is a strong relation which is accepted between parental participation and the student success. So innumerable investigation studies which have shown a compatible association between parental participation overall and academic procurement. The objective of the study was to explore perception of parents of their involvement in children's learning activities in school, to understand the barriers of parental involvement in schooling activities. Research question: how do parents pursue about their learning activities in school? So methodology: research approach was descriptive exploratory design and setting in selected area, sample parents of school going children, total 120 samples was there. Sampling technique was purposive sampling technique, and material was I have prepared the demographic data sheet and perception scale. So include methods of selection of study subjects, that inclusion subjects present at the time of data collection, study subjects who are willing to participate in the study subjects who can read Marathi, read and write Marathi. Exclusion criteria was subjects who attended the educational programs regarding the child development and educational learning activities of the school. So in the sample distribution in analysis part, that the perception scale to evaluate the efficacy of parents' perception regarding the parents' involvement in learning activity. Here I have divided the average, good, excellent. So I found that the 3.4%, that 4 participants were in average, and good 18.3, and in excellent 78.3 participants were percentage participants were there. They are having the strong perception. So majority of 78.3% of subjects had excellent level of participation scale, perception or attitude related to the involving activity of the school learning. 18.3% had good level of attitudes, and 3% had average level of attitude. Mean knowledge score of the subjects was 51.30 plus minus 12.02, and minimum knowledge score was 0, maximum knowledge score was 68. Now, association of knowledge score in other relation to the occupation of father is found significant, that in father occupation, that number of 3 subjects who are having in business: farmer 23, labor work 39, private work 18, and service 19. So I found significant difference in the occupation of the father. The association of knowledge score with the occupation of father, tabulated value F value was 2.31, which was lower than the calculated F value. So level of significance I found. Research hypothesis is accepted over here. In other demographic variables such as the number of children as well as the occupation of the mother, age of the children, which was not found significant. The key areas of the discussion where similar studies I find that the Mr. Pinlop Odom, who did the study related to the parental involvement and parent perception and teacher perceptions. So finding, I observed that this study revealed that parents and teachers surveyed had some similar perceptions and some differing perceptions regarding effective parental involvement, but both groups identified communicating as the most important typology from the Epstein. So there are 6 major types of involvement we observed, that like communication, homework, etc. And next study was conducted by the Massa Dusick, parental involvement as an important factor for the successful education. He also had the recommendation that are important for the planning programs that are focused on the improvement in involvement of parents for successful education. And Mehmet Akif, he had also conducted same study, parents' perception of their involvement in schooling. So that study revealed that showed that the family income is the most significant factor on parental schooling in schooling. So in summary, in the level of knowledge score on perception of scale, our majority 78.3% of subjects had excellent level of perception that they should involve in the parental schooling of the learning activity of the child. 18.3% had a good level of perception and 3% had the average level of perception. Parental involvement in learning activity of the children good for the successful education, that I observed in this study. So in conclusion, most of the parents expressed that when I collected the data, that time they expressed that they are not having enough time to give for their children. Most of the parents expressed that they did not have enough knowledge regarding the syllabus of the children, so they spend time for learning and understanding it. They are spending time in pickup and dropping of their children from school to home and vice versa. So at last, I want to say that if parent-teacher good communication relation, and if parents are having the good perception
8 minutes.
related to that, so the successful education schooling activities can be conducted. So thank you very much, madam.
Thank you so much for that presentation. Yeah, Madam Chair, do you have any question?
Thank you, Ms. Usha, for the presentation. Can you hear me?
Yes, madam.
Yeah.
Yes, madam.
Okay. Thank you for the presentation again. Okay. May I ask you something? How
Yeah.
do you define perception?
Perception. Hello.
Yes.
Yes, madam.
Can you define perception in your study?
The ability to notice or understand something of the which their child are doing in the schooling activity.
Okay. So your questionnaire, you included a knowledge and attitude, yeah?
Knowledge, and I prepared the perception says that scale, attitude scale, and then I conducted the data.
Is in your definition perception inclusive of knowledge and attitude?
In the definition, yes, madam.
Yeah. Okay. Is there any tool assessing just perception only?
Yeah, just for perception only, I prepared that scale. In that, the related to that, I observed the what are the activities, schooling activities like homework. Just a minute. Like homework, communication with the teacher, attending the parent-teacher meeting, that, and whether they are interested in that. So these are the questions which, these are the points which I have included, madam.
All right. Okay, because it is a bit of what do you call it? Not clear when you say it's perception, but you assessed knowledge and attitude. Yeah, perhaps you should have defined it earlier. So what perception means? Yeah.
Yeah.
Okay. Another thing is
Thank you,
that
ma'am.
what is this implication of this study to nursing?
Yeah, this can be in nursing. We can have a good implication, madam. We can assess the parental attitude as well as perception related to that, so that we can help or educate the parents if they will going to involved in that. The stress level of the childhood will increase, will decrease with the help of that, and they will be more comfortable when they will going to involved in their schooling activity, so that child's anxiety as well as they feel comfortable while learning.
So perhaps you could include this in your recommendation or include in the conclusion. Yeah. Otherwise, it stands alone. We can't see the
Recommendation
implication.
in recommendations.
Yes. Okay. Thank you, Ms. Usha. That's all
Thank
from
you,
me.
madam. Thank you, ma'am.
Thank you so much for that presentation. My apologies. All right. Next, I would like to invite Ms. Suchanda Bhattacharya. The topic is about a descriptive study to assess the association of social media usage and family relationship among student nurses in selected College of Nursing in Delhi.
Good morning, madam. Good morning,
morning,
Miss
yes.
Jojo.
Have it on presentation mode and you have 8 minutes.
Yeah. Just a minute. Okay. So, good morning, one and all present here. I am Suchanda Bhattacharya.
Have it on presentation mode, please.
Presentation mode. Okay.
Slideshow, it's too small.
Slideshow, madam. My screen is visible now?
All right, go ahead.
Okay, so I am Suchanda Bhattacharya, tutor for the College of Nursing, Jamia Hamdard, deemed to be university. Today, my topic is a descriptive study to assess the association of social media users on our family relationship among student nurses in selected College of Nursing in Delhi. So according to that, the social media sites have become the most popular online destination in recent years to communicate with different people who share the same interests and likes. One of the many influence of social media in changes in family relationship resulting from decline in quality time spent with the family, especially amongst youth, including students. So the study objective of the present study objective is to assess the effect of social media uses on family relationship. A cross-sectional descriptive study was conducted to assess the social media sites used in family relationship to student nurses. A study population sampling, the student nurses studying in the first year undergraduate course like BSc Honors Nursing, Diploma in General Nursing and Midwifery, and the post-basic BSc Nursing were selected using purposive sampling technique. Methodology and data collection. Data was collected from the 124 student nurses who were willing to participate in the study through Google Form. Based on their objective of the study, a structured questionnaire was used to assess the demographic profile and social media uses of the student. Brief family relationship scale was used to assess the relationship within the family as expressed by the student nurses. Methodology and data collections, the social media uses was delivered in 3 categories. There is a low uses, medium uses, and excessive uses, according to the time spent in surfing social media sites by the student. The family relationship scale.
Excuse me, Ms. Anu.
Yeah.
Your slides are not moving.
Ma'am, is now is showing.
You are still in the front.
Miss, it is showing, but it's not moving. most probably because the screen that you choose is just the screen of the PowerPoint.
Just a minute.
Yes. Can
Just a-
you reshare and choose the entire screen?
Okay, just a minute. Reshare, no? So slide share mode, I think. Now is visible? Now is visible, ma'am?
Yes,
It is still
it's
not in
still
slideshow
visible.
yet.
Okay, just a minute. I will ask a technical help to my IT sector. Is it possible? Just give me 1 minute, please. Is it possible, madam?
Yep.
Yeah, just a minute, just a minute. I need slideshow mode.
Where are you?
This one. But they said the slide share mode.
Share for me to me. Stop video. Here. Yeah. Stop share. Share screen. Screen. Share. Can you see
Yep,
this?
that's done.
That done, no? Okay, okay,
Yes,
madam. Thank
it's
you,
on
thank you. Sorry. And there is a social media uses was delivered in 3 categories: low uses, medium uses, and excessive uses, according to the time spent in surfing social media sites by the student. The family relationship scale assesses 3 parameters of relationship. One is expressiveness, one is cohesiveness, and one is conflict within the family of the student. Descriptive analysis such as percentage, frequency, mean, standard deviation, linear correlation between the social media users and family relationship was calculated. Again, the technical support needed, because of that the slide is not showing.
Presentation.
Hello?
Yeah. Yeah, now is visible.
Yes, it is.
Yeah. So so the bar diagram depicting the study subject by their demographic characteristic. In this demographic characteristic, there is a 77% were females, and diploma in general nursing course are the is a high. There is a high. They are 44%. According to this bar diagram is depicting that the social media uses by the study subject in the study. So according to that, 88.7% have accessed the social media sites on personal devices. As per that, the social media users in 9%, they are surfing the excessive, 38% are the moderate, and 53% are the low. So, and in this family traits as expressed by the study subject in the present study, family relationship, there is a maximum expressiveness among families of the 61.29%. Maximum cohesion among the families is 92.74% students, and moderate conflicts among families in 58 in the 46.77 students. So there is a correlation between social media uses and expressiveness in the family. So in 3 lines are there. One is the blue line, one is the red line, one is the green line, and blue line shows the least expressiveness. Red line shows the moderate expressiveness, and green line shows the maximum expressiveness. So this is the expressiveness. And now I just explain the correlation between the social media uses with the cohesion of the family. So according to that, these are the same things: low cohesion, moderate cohesion, and high cohesion. In next slide, there is some part of the different in there is 3 lines are also there, but here moderate conflicts are depicting there is an inverse relationship. So according to that discussion, the result of the study reveals that majority of the students who are having low and medium social media uses regarding family relationship, majority of the students were very expressive and had maximum cohesion with their family. So in this slide, we will also show this one and this one. Then, but when talking about conflicts in the families, majority of the students have moderate and maximum conflicts, 46.8% and 27.4% respectively. The study shows that there is a correlation between expressiveness and cohesion within the family, and the social media uses by the student nurses are inverse relationship between conflicts within the family and the social media uses. So the present study reveals impact of the social media uses on the family ties. There is an inverse correlation within the family relationship and cohesiveness. Interestingly, there is also an inverse correlation between the family conflicts and social media uses. However, this needs to be interpreted the caution as lack of conflict could also mean a lack of communication in the interaction. There is also a question that if the students uses, this is not in my study, but there is a question, if the student uses more, surfing the internet, then there is also a conflict is excessive, because if they use social media again, then they have a conflict, like their parents is telling that no, you are not use so much of internet and so much of surfing the internet. So there is also a conflict. This is the another side of the study. I am not researching this parameter also. So the conclusion, the social media uses has become very common among students and has affected their daily life. The study is conducted to examine the impacts of the student uses of social media sites on their family relationship. The study reveals that the students are using social media sites variably, which has impact on their family relationship. The utilization of the social media among students should be watchful and should be an aid to family relationship and other such relationship, not their alternatives. It can use to instructive purpose. For example, securing the sharing data, looking for help from companions, colleagues, and educators to get their questions explained, and not just to the enjoyment purpose and just to the waste their time. Thank you. If there is any question, please.
Madam Chair.
Yeah, thank you, Suchandra, for the presentation. It's a very interesting study, but unfortunately, we couldn't see most of your slides. Your slides just stayed at the methodology. We couldn't see any of your results.
Yes, madam, is it because I also take this technical help from my technical support committee, but I don't know what's the problem. Is there is any internet issues or anything? I think so. This is the social media user study, so I think that internet issue was also a factor.
Okay, what do you call that? What is your conclusion based on this?
Because just like I when I will collected the data, then I say that there is a, I think that there is a difference between the relationship, and there is a difference between the uses, but there is a inverse relationship. The result is coming in inverse relationship. If the students is low social media uses, then there is also a cohesion and expressiveness is inverse, and sideways also the conflicts, also the inverse moderate conflicts are there. This is only the conclusion in my study.
Okay, so in that sense that you as an educator, how do you overcome this problem?
I think that, ma'am, I also told you ki, regarding that ki, there is a if I given the time like that, our Indian schools is given 4 hours time or 6 hours time for the student to taking the classes and all these things. After that, 1 or 2 hours, because I when I prepared the data, I think that 8 hours, more than 8 hours they use, then it's a excessive use. But before that, I say that there is a 4 to 6 hours they use for the study purpose, for the surfing, the Google searching and everything, so research purpose. So this is also okay for that.
Okay, so I think that there's a need to look into how student uses social media, right? And the utilization time.
It's also needed, but it also needed for the study purpose, for the blended learning is also a methods in during this lockdown and during this COVID situation. It's needed, very much needed, but more than the hours is not as also the related to health issues, and also the their study times and their affect their things. So this is entire things I before I research, I think that.
Okay, is social media usage and the internet usage for education or academic purpose is the same?
In my study, I have 3 to 4 hours, 4 to 8 hours, and more than 8 hours. So according to that, if they have, there is a Facebook, WhatsApp, Twitter, everything I also incorporate in this questionnaire. But in study purpose, this is I exclude these things I exclude.
Okay, thank you for the explanation. Thank you very much, Sujatra.
Okay, ma'am. Thanks once again. Thank you.
Thank you.
Thank you so much. Yeah, I agree with Madam Chair that this presentation is timely, and yeah, it's unfortunately that the slide we're not moving. So for the remaining presenters, please make sure that your internet connection is stable, because we are interested in what you are presenting, and also our viewers, and we are actually live on YouTube, and we do share the link to our social media so everyone can see. So please make sure that everything is ready. All right. And next, I would like to invite our next presenter, Helmi Jamil Abu, Dalal University of Malaya. The topic is about the work commitment and organizational communication satisfaction among healthcare professionals, the mediating role of work satisfaction. Helmi?
Yes, thank you very much.
Hi.
Good morning.
Morning.
I'm audible, okay?
Yes, you are.
My slide is visible also?
Yes, it's up. Have it on presentation mode, and yeah, you have 8 minutes.
Thank you very much for organizing this conference, and would like to thank all people who exert their effort to let this conference to become real. Thank you very much. First, I'm going to present my topic today, work commitment and organizational communication satisfaction among healthcare professionals, the mediating role of work satisfaction. Introduction. Organizational communication is an integral part of healthcare professional work during performing their daily activity, defined as the process of exchanging information and ideas within an organization. Healthcare professionals are engaged in interpersonal communication on a regular and daily basis in planning their care and make decisions. Thus, really describe the communication between nurses and healthcare professionals as a heart of care, and it's a crucial factor in returning of the nurses. Work commitment is a mindset or psychological state concerning the employee relation with an organization, has implications for decision to continue or discontinue membership in the organization. Work satisfaction is a pleasurable or positive emotion state resulting from appraisal of one's job or job experience. Work satisfaction among healthcare professionals seems to be a critical element in the provision of safe and effective health service. Communication satisfaction and work satisfaction were found to be at the top of the factors that impact work commitment. A highly satisfied nurse in communication is highly committed and thought to be more satisfied and productive. Objective: to assess the mediating role of work satisfaction in relation between organizational communication satisfaction and work commitment of healthcare professionals. Hypothesis: work satisfaction mediates the relationship between organizational communication satisfaction and work commitment. Methodology: a cross-sectional survey was carried out within 235 healthcare professionals working in Palestinian Red Crescent Society in Gaza Strip, Palestine, using a validated self-administered questionnaire comprising 3 sections: organizational communication satisfaction questionnaire, organizational commitment questionnaire, Minnesota satisfaction questionnaire. The consecutive sample method was used to select the participant. Ethical clearance from the Institutional Review Board of the University and local health research council in Palestine called Helsinki Committee, and also written permission from PRCS and from the participant. Partial least square structure equation modeling was used to analyze the collected data. Our methodology, the structure model, here we can see there is organizational communication satisfaction as independent variable, work commitment as dependent variable, and work satisfaction as a mediator, as our hypothesis emphasized on the mediating effect of work satisfaction. Our result: the impact of organizational communication satisfaction on work commitment was positive and statistically significant. The mediating effect, indirect effect of work satisfaction on the relation between organizational communication satisfaction and work commitment was positive with both coefficient of 0.197, and it was statistically significant. Here the result is our PLS algorithm, which describes the relation. Here the structure equation model is a multivariate statistical approach used to test the structural relation between the variable. Here we have the outer model, which concern of the relationship between the items and its domains, the relation between the item and domains. And here we have the structural model. Here the outer model, here the structural model. We have first to test our outer model, make evaluation of the outer model before we are going to test the structural relation between our variable. So there are two steps: evaluate the outer model using convergent validity and discriminant validity and cross-loading. all was okay, and then we tested the relationship between the variable, the structural relation between the variable. The structural model analysis, we using the coefficient of determination, the R square, emphasizing on the relationship between our variables, and the effect size, using also Q value to predict the relevance, the relationship between the variables, if any variables can predict others. This is the Q value, the predictive relevance. Summary of our path coefficient hypothesis testing, the mediating result. As we know, the mediating effect or in such complex model, we have three types of relation. First, direct effect, indirect effect, and total relation. We have to test the mediation effect. The path coefficient, organizational communication satisfaction with work commitment, was statistical significant. Indirect effect was also statistical significant. Total effect of the organizational communication. If we can do simple mathematics, we can exclude that the direct effect and indirect effect is equal to the total effect. The summation of direct effect and indirect effect is equal to the total effect. Discussion. This result proposed a hierarchical multi-component research model to test research hypothesis. Work satisfaction partially mediates the relation between organizational communication satisfaction and work commitment. Applying effective organizational communication will promote organizational commitment and enhance work satisfaction. Conclusion, work satisfaction has a positive partial mediation effect between organizational communication satisfaction and work commitment. Improving healthcare professionals' satisfaction with organizational communication is vital in enhancing their work commitment and ultimately sustaining healthcare manpower. Recommendations. The contribution of organizational communication and work satisfaction in improving work commitment must be addressed. Investment of substantial resources should be considered to consolidate work commitment and consequently maintains and sustain highly expert healthcare professionals. This in return will contribute to better job performance and positive work values, high level of employee motivation, and lower rates of absenteeism, turnover, and burnout. Thank you very much.
Thank you so much for that very concise and informative, at the same time, informative presentation. Madam Chair, do you have any questions?
Yes. Thank you, Helmi, for those very precise presentation.
Yeah.
My question is that when you say about healthcare workers, could you explain who are the members involved in the healthcare workers? And is there any difference in results comparing between the healthcare workers?
Yes, healthcare professionals exclusive for persons who deliver care to the direct care to the patient. For example, physician, nurses, and paramedics. But when we are talking about a healthcare worker or healthcare provider, maybe this definition gives us that some person from the family, it's not formal tone. It's not have a formal tone. Maybe some person in the family give care to his father, his mother, his child. So this not healthcare professionals. He is a healthcare provider. According to the WHO also, we are concerned with these definitions.
In terms of differences in result, do you find any differences between the healthcare workers in terms of satisfaction or commitment?
Differences between health care professionals, yes, in this research, in deep details in this research, we use statistical Also, we carry out ANOVA test to understand if there are significant statistical differences in work commitment and work organizational communication satisfaction and work commitment related to their job. For example, is there differences between nurses, physician, or paramedic? There is no differences. There is no differences according to the ANOVA test.
Okay, thank you, Helmi. That's all from me.
Thank you, Doctor. Any other question?
Seems none. Thank you so much and good job.
Thank you.
All right,
Thank
let's
you.
move on to our next presenter. I would like to call back again Miss Vishnupriya, Lenka KIIT. The topic is about the prevalence of the gestational diabetes mellitus and associated risk factors among antenatal mother attending at a tertiary care hospital, Bhubaneswar. Vishnupriya?
Thank you so much, ma'am.
Well, yeah, I can hear you clearly. Oh, hold on. All right, please share your screen.
Ma'am, it is visible, ma'am?
Yes, it is. Have it on presentation mode and you have 8 minutes.
Thank you, ma'am. Good morning to all the dignitaries present over here. I am Vishnupriya from KIIT University, Bhubaneswar, Odisha. And my presentation. My guide, Professor Ms. Kalyan Rath, ma'am, Obstetric and Gynecological Nursing, Keynes, KDMTV University. My co-guide, Nehar ma'am, tutor of Obstetric and Gynecological Nursing, Keynes, KDMTV University. My problem statement, prevalence of gestational diabetes mellitus and associated risk factor among the antenatal mother attending a tertiary care hospital, Bhubaneswar, Odisha. Introduction. The gestational diabetes mellitus is known as any degree of glucose intolerance with onset and the fast recognition during pregnancy. GDM causes the highest glucose level. Sorry, ma'am.
I'm sorry.
Yes, ma'am. GDM, gestational diabetes mellitus is known as any degree of glucose intolerance with the onset and the fast recognition during pregnancy. GDM causes the highest blood glucose sugar that may be affected the pregnancy and its outcome. Uncontrolled diabetic in early pregnancy leads to the higher incidence of the congenital malabnormality of the fetus, such as the ventricular septal defect and the neutral tube defect. In the late pregnancy, the uncontrolled diabetic lead to the overweight of the fetus. Gestational diabetes mellitus is defined as the impaired glucose tolerance with the onset of the fast recognition during pregnancy. Worldwide, 1 in 10 pregnancy is associated with the diabetic. 90% of which are the GDM. Then complication of a fetus extended to the fetal microsomia, neonatal mortality and mobility, excessive fetal growth, and respiratory distress syndrome, neonatal hypoxemia. Need of the study, the prevalence of GDM is increasing the worldwide. Yearly 21 million of the world is reported. It is the more common in developing countries, South Asian country, and the Indian women having the highest frequency of a GDM. The prevalence of a GDM varies from 3.8% to 21% in different part of the country. In India, the MMR has been declined from 130 per 1 live birth in 2014 to 16 and 122 for 1 live birth in 2015 to 17. In Odisha, it is 2014 to 18. It is 180 for 1 live birth complication in pregnancy. Many studies reported the maternal and the fetal complications with GDM due to the number of unfolding factors such as obesity, older maternal age, BMI, and various of the other comorbidity factors. Then objective of the study to find out the prevalence of a GDM, to identify the risk factor of a GDM and to determining the association between the risk factor of a GDM and the selected demographic variables. In conceptual framework, according to the vendor's health promotion model, the characteristic and the experience under this the personal factor, under this the age, education level, religion, monthly family income, occupation, BMI, lifestyle, then physical activities, then cognitive factors, under this the previously benefit of the actions, then the previous barrier of the action, antenatal mother with any chronic disease, twins pregnancy, then previously self-efficacy, such as the self-care and the conscience about the GDM, then activity related to affective sense of a maternal peace and the positive perception association with the information received about the prevalence of a GDM. Then IPR, under this the supportive support from the healthcare professional and the family member of the antenatal mother. Then situation influence, activity, work pattern, environment, then associated risk factors. Under the behavior outcome, immediately compliant of the reference. Under this the lifestyle, behavior, then work and occupation, identify any hormonal related problem. Then previous risk factor and the IPR, it is including the commitment of the plan and the action. Under this, the self-structure questionnaire will be used to find out the association risk factor of the GDM. The health promotion behavior, the prevalence and identify the risk factor of the GDM. Review of the literature. Review of the literature has been organized according to the following headlines: study related to the prevalence of a GDM, and the study related to the GDM and its risk factors. Lokakudin S. and al. in 2014 conducted a cross-sectional study to assess the prevalence among 745 antenatal mothers. The study found with the prevalence of about 27.9%. The GDM risk factor were the higher in women aged with the 35 years and above with the maternal obesity. The GDM women has been higher risk and risk of having non-spontaneously vaginal delivery compared to the non-GDM women. The prevalence of a postnatal diabetic mellitus among the gestational diabetes mellitus mother with a 12.1% working in GDM mother were at the higher risk of developing postnatal gestational DM. Then methodology. Research approach, the quantitative research approach. Research designing is cross-sectional research designing. Then research setting, OPD of the obstetric and gynecological department, Padunawali Memorial Hospital, Bhubaneswar. Sample antenatal mothers, sample size 289. Then sample technique, it was conjugative sample technique. Method of the data collection, it was intermic method. Then data collection tool is self-structure questionnaire. Variable, under this the demographic variable and the research variable. Then analysis is descriptive analysis result. To the section 1, the socio-demographic variable. Under this, the age, education, occupation, family income, religion, maternal age, and gestational age. Then section 2, the habit and the physical health, that including the diet, meal per day during pregnancy, BMI, height, physical activity, and family history. Pilot study, a written formation was obtaining from the HOD of obstetric and gynecological department. The pilot study was conducted in KIMS Padunawali Memorial Hospital, Bhubaneswar. The written consent was obtaining from the participant purpose for the study. The tool was feasibility and the participable. The data analysis was done by the descriptive and inferential statistic. No further changes were made in the tool after the pilot study or the investigation proceed for the main study. Data collection procedure. Permission was taken from the HOD of obstetric and gynecological department. Then information consent was taken from the participant. The researcher data collection by using the conjugative sample technique of the method. Then after the data collection, the sample separated into the GDM present and absent categories. Analysis and interpretation of the data based on the objective. The prevalence rate of the gestational diabetes mellitus, total sample is 289. Under this, the GDM present is 86 and absent is 203. And the total percentage 29.7%, the prevalence percentage. Then identify the risk factor of a GDM. Under this, the diet, meal per day during pregnancy, BMI, height, physical activity, family history, and then USG finding, then amniotic fluid. Under this, the statistical significant, the diet, meal per day, BMI, physical activity, family history, and amniotic fluid. Number 3, the association between the gestational diabetes mellitus and a selected demographic variable. The demographic variable is, it is a statistical significant. Occupation, it is not significant. Then education is also statistical significant. Family history is not significant. Religion is also significant. Under habit of the physical health, under this, the diet, meal per day during pregnancy, diet is not significant. Meal per day during pregnancy is statistical significant. And BMI also significant. Then height is also significant. Physical activity and family history. Physical activity is also statistical significant. Then family history is not significant. USC finding also significant. Amniotic fluid is here, it is not significant in observational variable. A major finding related to the demographic characteristic of the participant. And then out of the 289 samples, the majority of the antenatal mother belong to the age group of 25 to 30 years, in which 62.79% are GDM present and 35.96% are GDM absent. Most of the antenatal mother were the home are in which 79.07% are GDM present and 80.79 are GDM absent. The maximum of antenatal mother were the graduation, in which 32.56% are GDM present and 33.50 are negative absent. Sorry, GDM absent. Then family history, family income, highest in 20,001 and 25,000, in which 43.02% are the GDM present and 41.38% are GDM absent. Majority of the antenatal mothers under the religion in Hindu, where it's 87.21% GDM present and 91.13% is absent. Under the marital year in 21 to 25 year of the age group, where 55.881% are GDM present and 50.74% GDM absent. And among the 289 sample, maximum of the antenatal mother are the under 29 to 34 of the gestational week and 37. It is the 37.21% present and 37.93% is GDM absent. Then the finding related to the factor of a GDM. Then GDM positive mother, it is the 84.88% of antenatal mother where non-vegetarian taking the non-vegetarian diet. Then 90.70% antenatal mother were taking the 4 to 5 times my meal per day, and 98.84% antenatal mother were under the BMI is 25 to 29.9. Then 52.33% of antenatal mother were the moderate worker, and the diabetic mellitus were present 34.88% and 65.12% absent in family history. Then antenatal amniotic fluid in 1,000 to 15,000 ml were present in 56.98% in antenatal mothers. On the discussion based on the finding obtaining from the statistical analysis and the related of the objective of the study. First finding, it is prevalence rate of a GDM mother. Then prevalence of a GDM we are finding with 29.7% and percentage out of the 289 antenatal mother. The present study is supported by the another study, Lukaguin S. et al. In 2014, to assess the prevalence of among 744 antenatal mother. The study finding with the prevalence of 27.9%. And second is finding related to the risk factor of a GDM positive mother. Out of the 86 GDM diagnostic mother, risk factor present percentage are 84.88% in non-vegetarian and 90.70% is 4 to 5 days taking the meals during pregnancy. Then 98.84% is in BMI. Then 52.33% in physical activity, 34.88% in family history, 56.98% mothers in amniotic fluid amount 1,000 to 15,000. Then the present study is supported by the another study, Sahad Abdullah et al. In 2016. The prevalence of GDM was 12.75%. in 637 by 37 by 5,000 sample, and the GDM was significantly higher in the 50.5% multi-gravity association of the GDM, and the founding in 68.8% working status, and 37.9% in hypertension, and 42.7% in family history of a DM, and 58.35 in BMI. The finding related to the association between the risk factor of a GDM and the selected demographic variable. The association between the risk factor of a GDM and the selected demographic variables, the statistical significant with the age, education, religion, BMI, height, physical activity, gestational age, milk per day, then USC finding. P-value is less than 0.005. The present study is supported by the another study. Osman Abdullah is the prevalence of the gestational diabetic among the present women in Japan in estimated at 8.2%. The GDM prevalence was significantly higher among the obese women compared with the women with the normal weight and the BMI and the family history. Nursing implication. The nursing practice, nursing care is the required more to prevent the complication in GDM. The nurse should educate the mother about many behavioral modification in on the diet, physical activity, and the following the antenatal visits. The nursing education, continuously education among the staff nurse will help to promote and update their knowledge on the GDM. The nursing administration, GDM awareness program started in hospital sector. The staff education from program developed on the GDM. The nursing research, the study will survive as the variable reference material for the future investigator. Then the finding of the study can be disseminated to the point of the journal as well as the e-journal. The limitation of the study during the time of data collection, some other are not cooperate. Then recommendation of the study, the women awareness about the GDM and promoting the healthy lifestyle. Then intervention for the prevention of a GDM and improving the pregnant mother the quality of the life. The similar study can be conducted to find out the association between the risk factor of a GDM and the selected demographic variable. Conclusion. In this study, the the GDM prevalence rate is 29.7%. It is a medical association disorder during the pregnancy. The GDM has the determination of affecting the mother as well as the fetus. Hence, the screening and the early detection is a highly recommendation close to the monitoring of the blood glucose level has been showing the significantly reduce the fetal mortality and mortality rate. This is my reference. Thank you, ma'am. Thank you all.
Thank you so much. Madam Chair, do you have any questions?
Yes, thank you for the presentation. Vishnu Priya.
Yes, ma'am.
Okay, that's an interesting study. But my question is that there's many studies already been done on this topic internationally. What do you think your study is different from others in terms of the findings?
Yes, ma'am. A lot of studies there, but I found out my study how the risk factor is affected in the diabetic mother.
Yeah, there is other studies also done. How do you see the difference, your results compared to others?
Yes, ma'am. In our state, means the Odisha, there is no any type of this type of studies. So I'm interested to find out how it is. How it is know about how much percentage of diabetic mother present in our state according to the international and national level. That's why I'm interested to find out this type of study.
So how do you conclude the differences in terms of factors? Do your study different than other studies, other international studies, the findings?
Yes, ma'am. Ma'am, in our state, the mother are properly not knowing about the what are the causes and how they control themselves and how they handle in this situation. So it has helped me to giving the education and providing the knowledge or idea how the mother is handling or how the mother is take care of the baby after the delivery. So it is little bit different, not much more different in between the risk factor between the international and national level in our state level also. Not it's most not different between the risk factors.
Okay, correct me if I'm wrong, but in your presentation just now, I noted that those people with lower BMI had higher prevalence. Is that true?
Yes, ma'am.
Those with low BMI had higher incidence of gestational diabetes in your study?
Yes, ma'am.
So in international study, if I'm not mistaken, is obesity people is the one who has higher risk to get gestational diabetic. So is your study shows is lower BMI with higher gestational diabetic.
Yes, ma'am. Low BMI, ma'am, this mother is not taken diet properly. If the mother is low BMI, means the mother is not adequate much of a diet, and the hormonal. If the mother is the family history, previously the family history is also so, ma'am, it is related.
Okay, do you intend to do any intensive analysis to find out which are the most important factors? Because what you presented is a very basic analysis, right? In terms to identify which are the most important factors, do you intend to do any intensive analysis?
Yes, ma'am. In this factor, first the diet and the lifestyle and the physical activities, ma'am. This factor is more affected because the now the modern lifestyle is more affected. So this three factor is more affected, and so.
Okay, my suggestion about Vishnupriya, maybe you can run some regression analysis that will give you a better results to show which are the highest or which are the most prominent factor, yeah, which you could focus on. Yeah.
Yes, ma'am.
Okay. Okay, with that, thank you for the presentation. Thank you.
Thank you so much, ma'am.
Right, thank you so much for that presentation. Now, let's proceed. I would like to invite again Miss Huma Julio Abunmai, SGT University, India.
Yes. Can you hear me now, ma'am? Hello, ma'am. Can you hear me now, ma'am?
Yeah,
Hello.
but yes.
Ma'am, can you hear me now, ma'am?
Yes. The
Okay.
question is, can you hear me?
Sorry, ma'am. Sorry for the problem, ma'am, that I created. Ma'am, actually my network, I have some network issue.
Go ahead.
Hello, can I start the presentation, ma'am?
Yes, please. Have it in
Thank you.
presentation mode and you have 8 minutes.
Thank you so much for the time. Thank you, ma'am. Today, I'm Huma Julio Abunmai from SGT University. Today, I'm going to present on a statement, a study to assess the level of internet addiction and its association with depression and insomnia among students of SGT University. Introduction. The term internet addiction was proposed by Dr. Ivan Goldberg in 1995 for pathological convulsive internet use. As the term states, its concentration is on compulsive with the internet. As other areas of media addiction can be seen in television addiction, radio addiction, and other types of media addiction. It's hard to live these days by getting rid of the internet. Internet addiction, just like other addiction, disrupts school, studies, and other aspects in daily life of individual adolescent. So the need for the study, why I need to study on this topic is that in India, so many studies have been conducted regarding internet addiction. Nevertheless, not much has been studied in Haryana state in this regard. Hence, the study was planned to investigate the level of internet uses or addiction in young adults and its association with insomnia and depression and college going students. Objective: to assess the level of internet addiction, depression, and insomnia among the student, to find out the association between internet addiction and depression, to find out the association between internet addiction and insomnia. Hypothesis. My hypothesis was tested at the level of 0.05 level of significance. Hypothesis 1, there will be significant association between internet addiction and depression among students. Hypothesis 2, there will be a significant association between internet addiction and insomnia among the student. Methodology. Research approach is quantitative research approach. Research design, cross-sectional one-time test design. Research variable, demographic variable include age, gender, religion, type of family, education of mother, father, area of resident, source of information, enroll course and year of course. Research setting, the study was conducted among students of SFNP University, Gurugram, Haryana. Sample and sampling technique, use it combining convenient sampling technique. Tools and technique is based on the objectives of the study. Standardized questionnaire was used in order to assess the level of internet addiction, depression, and insomnia among students. All the standardized tools were incorporated in the study after prior permission from the tool developer. Technique, self-report, sample size 842, population of the study, SFNP University student. Assumption. Study may have different level of internet addiction. Students may have some association of depression and insomnia. And tool, young internet addiction test, patient health questionnaire, that is PHQ-9, insomnia severity index can be appropriate to assess the level of internet addiction, depression, and insomnia. And also student will give free and frank response to the questionnaire. The elimination of the study is student are selected only from the selected institution, one-time assessment of the internet addiction, depression, and insomnia. Development and description of tool, it is categorized into 4 sections, A, B, and C and D. Demographic, section A include demographic variables, which has 11 items such as age, gender, religion, type of family, education of father, mother, area of residence, source of information, enroll course and years of course. Section B comprise of young internet addiction, test questionnaire to assess the level of internet addiction. It consists of 21 multiple choice question. Section C, it comprises of PHQ-9 rating scale to assess the level of depression. Section D, it comprises of insomnia inventory index, severity index, scale to assess the level of insomnia. It consists of 7 items. Procedure of data collection, it is first taken permission and then taken consent from the student, and I introduce to the students of by promising maintaining confidentiality, and also explain the purpose, need of the study, and procedure of the study. And the demographic variables were collected from the student. One-time test was done to assess the level of internet addiction, association, depression, and insomnia. And then data was collected and then tabulated and analyzed. Now, organization and presentation of the data selection. Section 1, demographic variables. A majority of the participant, that is 51%, were in the age group of 18 to 20 years, and the few of them were in the age group above 26 years, that is only 4%. In the gender demographic, Majority of the participants were female, that is 507 out of 842. And majority of the religion is 90.60, that is Hindu, and minimum participants were from Muslim and other, that is 1.40%. And in types of family, majority of the participants were belong to nuclear family, that is 53.60%, and few of the participants were from a single parent family, that is 1.20%. And the area of residence, majority of them were belong to urban area, that is 62.80%, and 37.20 were from rural area. Knowledge regarding the internet addiction, 85.20 were having knowledge regarding internet addiction. And in source of information, majority of them, they get information from the internet itself, that is 51%. And few of them, they are getting information from health personnel, that is only 4%. And in section 2, distribution and of frequency and percentage of level of internet addiction, it is categorized into 4 categories. So here in level of internet addiction, after the analysis, it is shown that 63.10 were having normal, that means they did not have internet addiction, and mild have 30.40 having mild internet addiction, 5.30 having moderate internet addiction, and 1.20 having severe internet addiction. And level of depression, 34.30 having mild depression, minimal depression were 31.80, and 21.70 having moderate depression, 9.40 having moderately severe depression, and 2.80 having severe depression. And level of insomnia, majority of the participant having no clinically significant insomnia, that is 63.40, and 30.10 having subthreshold insomnia, 5.30 having moderately severity in clinical insomnia, and 1.20 having severe clinical insomnia. And in section 3, association with internet addiction.
8 minutes already.
Yes, ma'am. Sorry, ma'am. I'll run it up.
Yep, wrap it up.
Okay, association with internet addiction and insomnia and depression. The finding revealed that the computed app value between internet addiction and depression, that is F4.51, p-value 0.01. It infers internet addiction was associated with depression, which was found significant at 0.05 level of significant. Hence, research hypothesis 1 was accepted and null hypothesis were rejected. And association with internet addiction and insomnia, the finding revealed that insomnia 6.20, and that means it infers that there is also some associated with insomnia, which was found significant at 0.05 level of significance. Conclusion, the study revealed that majority of the students, that is 63.10, were not addicted to internet, 1.0 having severe internet addiction, 34.30 were mild depression, 2.080 were having severe depression, 63.40 were having no clinically significant insomnia, 1.20 were having clinical insomnia, that is severe. So the internet addiction is associated with depression and insomnia. The study also revealed that promoting awareness of the problematic internet use and educating regarding healthy internet use among students is a precautionary measure. Recommendation, precautionary measures can be adopted by every student, such as reducing the time spent on mobile and laptop. Each student should have proper knowledge regarding internet addiction in order to take prevention timely. Educational curriculum should be updated to include comprehensive information about regarding internet addiction to improve the awareness. A similar study can also be conducted to assessing the level of knowledge regarding internet addiction among pre-university students. These are my reference. Thank you. Thank you, ma'am.
Oh, thank you so much. And yeah, Madam Chair.
Yeah, thank you very much for the presentation, Primati. My question is that how do you determine the sample size for this study?
Yes, ma'am. Actually, during the pandemic time, I was collected this sample, and it is pen paper method, ma'am. And actually, there were so many university students, like maybe around 4,000 students, but I could not collect absent at the time of collecting sample, ma'am.
Okay, so there is no sample size to calculation prior to determine the sample that you needed, is it?
Yes, ma'am.
Okay. Another question is that you noted that there is a 2.8% of students with severe depression.
Yes, ma'am.
So what you did with this student? Did you
Ma'am,
need any further action?
Yes, ma'am, actually, I didn't do, ma'am. Actually, right now, I haven't done anything, ma'am. Actually, this is done on a scholar research project and on that project, ma'am. So actually, we are putting for competition type, ma'am. So in that, ma'am, actually, if I win the presentation, then I can give another chance to organize like some health education from my end, ma'am. But as I don't select for that particular competition, I could not organize till now. But I was approaching to my teacher so that I can organize some health talk, ma'am, regarding internet addiction.
Okay, it's good. But as a researcher, when we collect some data, if you see there is something that is a concern, so for example, you saw
Yes,
there's
ma'am.
some severe depression,
Yes,
so you
ma'am.
have to have some backup plans, what you're supposed to do with this sample, yeah?
Yes, ma'am. Yes, ma'am.
Okay.
I'll plan it, ma'am.
Okay, thank you so much for the presentation.
Thank you,
Very
ma'am.
clear and nice presentation.
Thank you so much, ma'am.
Thank you so much. And now I would like to welcome everyone to our next session, our technical session 2. And thank you. I would like to take this opportunity to, of course, thank our Madam Chair from session 1. Thank you so much, Madam Chair, for your time. Thank you so much. All right, and now let's proceed to our technical session 2. It's about the adult health nursing. And I would like to invite Dr. Vasanta Kalyani, Principal, Department of Nursing, AIIMS, Jharkhand, India. She completed her PhD, had a teaching experience more than 30 years, editorial board member in indexed journals, and more than 46 publication in indexed journals. Let us welcome Dr. Vasanta Kalyani. Dr. Chair, would you like to say some welcome words? All right, let's start with our first presenter. Let us welcome S. Abhirami, Rajalakshmi College of Nursing, Chennai, a descriptive study to assess the level of knowledge on reproductive health among multi-gravida mothers in selected primary health center. Abhirami? Next, I would like to welcome Barka Rani.
Yes, ma'am. Good afternoon to all. I am here. सेक्शन मेरा आ गया ना, अब बताओ क्या करूं? स्क्रीन शेयर हो गया। अब इधर आओ ना। करो स्क्रीन शेयर। एब्स्ट्रैक्ट प्रेजेंटेशन करो। यहाँ पे करना है तो मुझे कुछ नहीं मुझे Hello, am I audible? Hello.
Yes, you
Hello,
are
Juju.
very audible.
Hello. Oh, well, thank you. Yeah, let me start now. May I start now, ma'am? Hello.
Ma'am, please start, ma'am.
Hello. May I start now, ma'am?
Yeah, you can start,
Yes,
please.
please.
Okay, very good afternoon to all. I'm Barkha Rani. I'm from Amity University, and my today's presentation title is Assessment of Knowledge, Attitude and Practice Towards Bidirectional TB COVID Screenings, a Preventive and Control Measures among Delhi NCR residents of India during syndemic of tuberculosis and COVID-19. It's basically an online knowledge, attitude and practice questionnaire based on cross-sectional study. So, under the introduction, the period 2020 and 25 and 2030 is very crucial to revitalize and sustain TB control efforts for achieving the TB elimination targets during this ongoing COVID-19 pandemic, where whole TB care cascade is evidently affected by globally and nationally, including India. So, to effectively mitigate the ongoing COVID-19 pandemic effect upon TB and manage dual disease burden effectively with the same focus, a rapid response plan bidirectional TB COVID screenings was proposed by Ministry of Health and Family Welfare of India in September 2020. In this regard, to assess the knowledge, attitude, and practice, an awareness analysis was conducted by me to identify the crucial knowledge, attitude, and practice gap towards bidirectional TB COVID screening among people of India. In this regard, I had used a prospective web-based cross-sectional survey that was conducted among Indian residents during April 2021 by using a Google Forms based on knowledge, attitude, practice questionnaire, and data were analyzed by using sparse at level of significance, 0.05 level of significance by using a two-tail test. So, under the result in this study, I have found that majority of respondents were adults, females, married, urban dwell, well-educated, government-employed healthcare professionals dedicated for COVID-19 care than for TB care, without any TB COVID flu-like symptoms and in contact of TB COVID cases. Overall, by getting 83% of total adequate knowledge scores, the majority of participants had shown adequate knowledge. That is also reflected in their attitude, as shown by getting an overall 97% agreement rate of total positive attitude scores, but optimistically not shown in their behavior with an overall 12.7 of total satisfactory practice score. When I had done analysis where I have found a association in between adequate knowledge scores and marital status, highest educational status, occupation, healthcare professionals, and current health status. In addition, total knowledge score was also found significantly differed across occupation and healthcare professionals among demographic variables. In case of multivariate logistic analysis showed that only healthcare professionals, non-COVID and non-TB care dedicated healthcare professionals were significantly associated with average knowledge as compared to poor knowledge, whereas none of the demographic parameters was found significantly associated with good knowledge as compared to poor knowledge. There was also found a strong evidence of a statistically significant association between positive attitude and occupation. Although in other demographic parameters, it was not found. In case of F statistics, showed a significant difference between knowledge level, poor, average, and good on total attitude scores. There was also found a statistically significant likelihood of association between adequate practice scores and healthcare professionals and area of residence. Additionally, no significant difference was detected of demographic variables, knowledge scores, attitude scores on total practice scores towards bidirectional screening of the study participants while conducting F statistics. The calculated effect size for attitude indicated that the extent of attitude that the respondent experienced accounted for an outsized portion, 42% of the variability in knowledge level, also indicated that attitude level explains more of the variability in knowledge level than does practice during this study. Although another correlation analysis found a positive but weak statistically significant correlation between adequate knowledge and positive attitude level. And between adequate knowledge and satisfactory practice level at 0.05 level of significance indicates that increasing adequate knowledge level also increases the positive attitude level and appropriate practice behavior among respondents. But once more, no significant correlation was found in between positive attitude and satisfactory practice level among the respondents. So all these facts, all above mentioned analysis indicate that despite of adequate knowledge and positive attitude, respondents still not practicing well at satisfactory level bidirectional TB COVID screening. Even though most of them were healthcare professionals, might be peers, some other factors would exist that resist them to practice well. Should be explored by conducting another study with large sample size. So, in conclusion, I conclude my presentation as most of the respondents were healthcare professionals. A nationwide awareness campaign should be planned and conducted in both structured and unstructured way. In service education program for healthcare professionals and social media based propaganda program for general public, and an implementation situation analysis should be conducted to explore practice deficit related factors towards bidirectional TB COVID screening in India. So it's all about my presentation. Thank you to all. Hello.
Thank you so much for that presentation. Any other questions? Let's go ahead and proceed with our next presenter. Mr. Divian Shu Tiwari, KIIT. The effectiveness of kneading technique on joint pain among old age. Oh. I would like to invite the next presenter, Dr.
It's a request to you. Can you stop
Zafar.
sharing the previous slide?
Yes, sure.
Dr. Zafar Ijaz Khan. The topic is about the assessment of knowledge regarding hospital-acquired infections, nosocomial.
Ma'am, I am going to present Divyanshi theory. Is it visible? Hello? Hello?
Yes, it is. You have 8
Is
minutes.
it visual? Good afternoon to one and all. Myself Divyanshu Tiwari from KIT University, Odisha. My guide is Professor Mrs. Amrita Lanka, Kalinga Institute of Nursing Science, and my co-guide is Mr. Ashokan R and Mrs. Minati Dash. My problem statement is a study to assess the effectiveness of kneading technique on joint pain among old age people with osteoarthritis in selected old age homes at Bhubaneswar. Introduction. Osteoarthritis affects commonly joints such as hands and spine, and well-being of joints such as hips and knee joints. The symptoms of osteoarthritis include pain in the joint and stiffness of the joint. Osteoarthritis affects people of all races and both sexes. Most commonly, it occurs age of 60 years and above. The objective of the study, the first objective is to assess the level of joint pain among old age people with osteoarthritis before and after the kneading technique. The second one is to evaluate the effectiveness of kneading technique on level of joint pain among old age people with osteoarthritis. Hypothesis is as zero. There will be no significant difference in the level of joint pain before and after the kneading technique among old age people with osteoarthritis. Methodology. The research approach is quantitative approach. Design is quasi-experimental, pre-test, post-test control group design. Sample size, old age people with osteoarthritis, and sampling technique is purpose sampling technique. The size of total sample is 40. The study setting is Krishna and Ananda Ashram old age homes at Bhubaneswar. The data collection method is structure, interview, and observation. The data collection tool is structure, demographic, proforma, and vision analog scale. This first tool is socio-demographic data. It consists of age, sex, marital status, source of income, educational qualification, nature of previous occupation, religion, and preferred diet. The second tool is vision analog scale. There is 4 criteria as from 0 is no pain, 1 to 3 is mild pain, 4 to 6 moderate pain, 7 to 9 severe pain, and 10 is worst pain. Procedure of data collection is after getting the permission and informed consent. The pre-test was done by using visual analog scale to assess the level of joint pain among old age people. Staging technique was given daily once with each training session lasting 20 minutes among experimental group for the time period of 10 days, and control group received routine intervention. Post-test was conducted within the same tool among old age people for the both group. After post-test, data was analyzed. The analysis of the data is divided into 3 sections. First one is assessment of pre-test and post-test level of joint pain. Second one is evaluation of effectiveness of kneading technique on level of joint pain. And the third one is association between pre-test level of joint pain among old age people with osteoarthritis. The first one is assessment of pre-test level of joint pain among old age people of experimental and control group. There will be, although value is put in the experimental group and control group, then no pain, there is 0% is no pain, mild pain is 40%, moderate pain is 50%, and severe pain is 10%. In control group, there was 20% mild pain, 80% is moderate pain, and 0% severe pain, with the level of significance is less than 0.05, and size of the sample is 40. P value is less than 0.001, is statistically significant. Then section come to evaluation of the kneading technique on the level of joint pain. There will be a mean plus minus standard deviation level 4.35 plus minus 1.927, and the post test was 2.65 plus minus 1.814. The mean difference was 1.70 plus minus 0.801, and the t value is 9.488, and p value is less than 0.001, which has been statistically significant. In the control group, the mean plus standard deviation level 4.35 plus minus 1.75, 785. Mean difference was 1.10 plus minus 2.47. The t value is 1.993. Then come to the section 4, association between pre-test level of joint pain among old age people with osteoarthritis and their socio-demographic variable. There is p value of the age is 0.011, is statistically significant, and the education is statistically significant, less than 0.001. Source of income 0.001, and religion 1 is statistically significant. The major findings of the study: in aspect of assessment of maximum of the study, participant at 24 reached 60% of the 40 participants belong to the old age group 70 to 80 years. In aspect of assessment, majority of the study population, 65% out of 40, were the female in the both group. In aspect of assessment, marital status by distribution of the study population, maximum of the study population were married, 20 out of 40, so 50%. Many of the study population had primary education, like 16 out of 40, and according to the source of income, majority of the study population, 30, like 75%, had nil income in the both the group. As regards to nature of previous occupation, there will be 67.5% were unemployed and 32.5% were employed in the both the group. And among the cases, maximum of the study population, like 72.5%, were non-vegetarian in the both the group. Majority of the study population were Hindu, like 45%. It was found statistically significant the effectiveness of kneading technique in decreasing the pain among the old age people with osteoarthritis in the interventional group as compared to the routine care in the control group. Its p value is equal to 0.001. It was found that there was an association between old age people with osteoarthritis and their socio-demographic variables like age, education status, source of income, religion, and preferred diet. There are findings related to assessment of pretest level of pain. It was observed that mean score of experimental group pretest was 4.35 plus minus 1.927, and in the post-test was reduced to 2.65 plus minus 1.814. The difference between the pretest and post-test mean score was found to be statistically significant. In the control group, the mean score pretest was 4.35 plus minus 1.785, and the post-test is reduced to 3.25 plus minus 1.209. The pair test t-test statistics were used to calculate the statistical significance in control and experimental group. There will be no significant difference in that level of joint pain before and after kneading technique among the old age people with osteoarthritis. Statistically significant difference found in the experimental group. It shows that kneading technique is effective in old age people. The null hypothesis is rejected because of the reduction in the joint pain. Fourth one is association. A statistically significant association was found in the category of age, education, and pretest score. Statistically significant association was noted in the education status, source of income, religion, and preferred diet. Was also significant associated with the pretest pain score. Come to the nursing implication. The nursing practice. The finding of the study enlightened the fact of the kneading technique to be used to decrease the knee joint pain among older people with osteoarthritis. The second one is the study facilitated to educate the regarding kneading technique of joint pain among old age people with osteoarthritis. The third one is nursing personnel are the best position to create the awareness regarding kneading technique and its effect in the knee joint pain reduction among old age people with osteoarthritis. What are the implication in nursing education? The educator can take initiative to include the topic effectiveness regarding kneading technique on reduction of knee joint among old age people with osteoarthritis. The nurse education can educate the nurses for the management of the knee joint regarding this kneading technique. Come to the nursing research. The study findings can be utilized for the literature of review of the researcher, and this study can use for the guidance of the researcher.
Please wrap it up. 8 minutes already.
Okay. The nurse administration should announce the importance of the kneading technique through media, posters, and pamphlets, and the handouts. The recommendation of the study is based on the finding of the study. The investigator proposed the following recommendation for the further study. The study can be conducted with a large number of the sample for the better generalization, and the study can be done by using other teaching strategies. Come to the conclusion. The following conclusion drawn from the study: kneading technique was effective in reducing knee joint pain among old age people with osteoarthritis, and there was a significant association between pretest score and selected demographic variable. Thank you.
Thank you so much for that presentation. And let's go ahead and proceed with our next presenter. I would like to invite lovely Josel, SMT Rukmani Ben, Deep Chand Bai, Gardi Nurses Training Center at Indore MP. The topic is about a quasi-experimental study to evaluate the effectiveness of self-instructional module regarding domestic violence among women of diverse socioeconomic background from selected communities at Indore. Lovely.
Yes, ma'am.
Yep, I can see your screen. Have it on presentation mode, and you have 8 minutes.
Thank you, ma'am. Good afternoon, one and all. Am I audible?
Yes, you are. Proceed.
The domestic violence was quite positively. The research was under Dr. Vidhi Sharma, PhD supervisor from Maharaja Vinayak Global University, Jaipur. Introduction. Domestic violence is a major global health issue. According to the World Health Organization, up to 71% of the women aged between 18 to 60 have ever been in a relationship, have experienced physical, sexual, or emotional abuse. This study was aimed to evaluate the effectiveness of self-instructional module regarding the domestic violence among women. The statement of the problem. A quasi-experimental study to evaluate the effectiveness of self-instructional module regarding domestic violence among women of diverse socioeconomic backgrounds from selected communities at Indo. My objectives are to assess the prevalence of domestic violence, to assess the degree of domestic violence among women, to assess the quality of life among women, to assess the self-esteem of women who have undergone domestic violence, to assess the coping strategies regarding domestic violence, to evaluate the effectiveness of self-instructional module on the degree of domestic violence, quality of life, self-esteem, and the strategies, coping strategies regarding domestic violence. Next, to correlate the level of degree of domestic violence with quality of life, self-esteem, and the coping strategies, to associate the pretest level of degree of domestic violence with quality of life, self-esteem, and the coping strategies. Hypothesis are, research hypothesis, there will be a significant difference between the degree of domestic violence, quality of life, self-esteem, and the coping strategies regarding domestic violence in pre-test and post-test. Second one is there will be a significant correlation between the quality of life, self-esteem, and coping strategies regarding domestic violence. There will be third one, there will be a significant association of degree of domestic violence with the level of quality of life, self-esteem, coping strategies regarding domestic violence with selected socio-demographic variables. Assumptions. The self-instructional module may be improve the level of quality of life, self-esteem, coping strategies regarding domestic violence. The women need guidance and assistance to protect their rights. Some support system are already available to the females in the community. Improved educational and economic status of the community has a caring environment for their women. Gender inequality and cultural unorthodoxy creates lives of women folk more vulnerable. Research methodology. Conceptual framework which was based on emerging King goal attainment theory. An evaluatory approach of research approach used. Research design was one group pre-test post-test design. 330 married women between the age of 19 to 45 were selected as sample and sample size. Sampling technique was used is non-probability convenient sampling technique. Domestic violence prevalence questionnaire, degree of domestic violence questionnaire, quality of life by WHO, Rosenberg self-esteem scale, and grief curve were used as tools. Pilot study was conducted to check the feasibility. The main study was conducted from 3rd January 2020 to February 2021. Written consent was obtained from the samples. Data collection was done by using structured interview questionnaire. After pre-test, intervention with self-instructional module on face domestic violence positively done with the samples. After that, posters was done to analyze whether the self-instruction module was effective or not. And the collected data were computerized and analyzed by using SPSS version 25 and with using percentage frequency, pair t-test, person correlation R test, and type test. The results were divided in 6 categories. First one is demographic variables, then assessment of prevalence of domestic violence, assessment of pretest and post-test of degree of domestic violence, quality of life, self-esteem, and the coping strategies, then effectiveness of self-instructional module, the correlation between the pretest and post-test level of degree of domestic violence, quality of life, self-esteem, and the coping strategies, then association between pretest level of degree of domestic violence, quality of life, self-esteem, and coping strategies with the social demographic variables. The major findings of the result were majority of the samples were in the group of 19 to 25 age. Almost all participants were in the having secondary education or the higher secondary education. Or age at marriage, most of them married at above 18 years. The duration for marriage for majority of the participants with 5 to 10 years. Majority of the participants were living in nuclear family, or majority of the samples have 1 or 2 children. Occupation for the samples and their spouse were private employee. The income, majority of the samples have an income of 10,000 to 20,000, and majority of the samples agreed that their spouse were smoker. In the level of prevalence of domestic violence, all the women have undergone domestic violence, and majority have moderate level experienced moderate level of domestic violence. The pretest and post-test level of degree of domestic violence, the comparison, here we can see that at the in pretest, majority of the samples have a high level of degree of domestic violence, but in the post-test, it's reducing lower level of degree of domestic violence. If we come to look into the domains of physical different domestic abuse, physical abuse, verbal abuse, financial abuse, and emotional abuses were data collected in everywhere we can see that some kind of abuses were there, and emotional abuse and verbal abuse were in higher among the people. Where in the post-test, all these categories are reduced to some extent. In pretest and post-test level of quality of life regarding the domestic violence, in the pretest, all the quality of life were very poor or poor. Later, in post-test, it were very few in good category, but still there is little change from the very poor or poor category. This is the main test. The physical health, psychological, and social relationship and environmental means family environment. Of course, all these areas are affected by the domestic violence. That later in the post-test, the quality of life also improved. Pre-test and post-level comparison of self-esteem. Here also we can see in pre-test, lower level of self-esteem were there. Later it changed to moderate level or high level of self-esteem. In the coping strategies with the domestic violence, a low level of self-esteem was there in the pre-test. Later it changed into moderate level of self-esteem or high level of self-esteem. The effectiveness of self-instructional module on the degree of domestic violence. The mean difference is with the pretest and posters 14.37, which is highly significant at the p-value of 0.001. Again, we can see the same for the quality of life, self-esteem, and the level of coping. Thus, the study was effective. It was seen that the self-instructional module was effective to reduce the not reduce the level of degree of domestic violence, but it improved the quality of women, life of the women, and the coping strategies and the self-esteem. The correlation between the pretest and posters level of degree of domestic violence with
Can you please wrap it up?
Okay. Let's say in degree of domestic violence and quality of life, there's a strong negative correlation, and whether it is quality of life and self-esteem and self-esteem and coping, it's a positive correlation, strong positive correlation. And again, with the quality of life and self-esteem, there is a negative correlation. Nursing implication. Nursing practice. The findings of the study point out the self-instructional module is effective in improving the role of recognition and emotional competence to face the domestic violence positively. Nursing practice. Nursing students can be educated on domestic violence and its ill effect on women and children. The nursing students should be emphasized to apply their knowledge in clinical and community areas. Nursing administration and nursing research. Recommendation: need to bring about changes in the policies, procedures, and practices of the entire socio-legal system. The basic objective of this study is to impact needed services for the women victim of the domestic violence. Complaints of sexual assaults should be provided with legal representation. The victim's advocate should be only assist her in filling the complaint, but also guide her in getting other kinds of assistance like psychiatric, medical, and financial too. Limitation. Negative thinking of the people still is a barrier for communication. Only married women included, children, adolescents, elderly, unmarried women, even male also facing domestic violence nowadays. These are not included in the present study. Impact of domestic violence over children also not studied. Actually, it actually has physical, psychological, financial, social, and political importance at individual, family, and community, even globally. Conclusion: present study to evaluate the effectiveness of self-instructional model regarding domestic violence among women of diverse socio-economic backgrounds from selected communities and all. The level of domestic violence prevalence, degree of domestic violence, quality of life, self-esteem, and the coping strategies regarding domestic violence among women assessed with the questionnaire. The study concluded that the level of degree of domestic violence, quality of life, self-esteem, and the coping strategies regarding domestic violence is more effective by self-instructional module regarding the role of recognition and emotional competence to face the domestic violence positively. Thank you. Sorry for being late.
Now I would like to invite Ms. Kiumajuliu Abunmai, SGT University, a study to assess the effectiveness of video-assisted teaching in terms of knowledge and self-expressed stigma regarding COVID-19 and its preventive measures among housekeeping staff at selected hospital in Gurugram, Haryana. Yep, I can see your screen, but I cannot hear you. Have it on presentation mode. All right, perfect. Thank you. Go ahead. You have 8 minutes.
Am I audible, ma'am?
Yes.
Okay, ma'am. Thank you, ma'am. I'll start away, ma'am. Today, I'm Kiumajuliu Abunmai from SFNP University. I'm going to present a statement on the topic, a study to assess the effectiveness of video-assisted teaching, VAT in terms of knowledge and self-expressed stigma regarding COVID-19 and its preventive measures among housekeeping staff at selected hospital, Gurugram, Haryana. As we know, the COVID-19, it is an infectious disease which is caused by a newly discovered coronavirus, a seventh non-coronavirus to infect human and also known as acute respiratory syndrome coronavirus 2, also known as SARS-CoV-2. In December 2019, the first case of coronavirus disease was identified in Wuhan, China, as the disease has spread worldwide, leading to ongoing pandemic. On January 2020, WHO declared the outbreak to be a public health emergency of international concern and recognized it as a pandemic on 11 March 2020. So the need of the study here is the one is that I'm interested in this topic. And the second is that when I saw those incidents which has been spread in social media, many people are suffering from the wrong infection in a perception regarding COVID-19 disease. This has happened due to people have a lack of insufficient information regarding COVID-19 disease. Through this study, I can assess the knowledge regarding COVID-19 and also self-expressed stigma regarding COVID-19 and its preventive measures among housekeeping staff. So the main aim of the study is to provide knowledge and awareness regarding COVID-19 to the housekeeping staff. Objective: to assess the knowledge and self-expressed stigma regarding COVID-19 among housekeeping staff at selected hospital, Gurugram, Haryana, to assess the effectiveness of video-assisted teaching in terms of knowledge and self-expressed stigma regarding COVID-19 among housekeeping staff, to find out the association between pre-test knowledge with the selected demographic variables, to find out the association between pre-test self-expressed stigma with the selected demographic variable. Hypothesis: the hypothesis was tested at a significance level of 0.05. Hypothesis 1, there is a significant difference in mean pre-test knowledge and self-expressed stigma regarding COVID-19 and its preventive measures among housekeeping staff at selected hospital, Gurugram, Haryana. Hypothesis 2, there is significant difference in mean post-test knowledge and self-expressed stigma regarding COVID-19 and its preventive measures. Hypothesis 3, there is no significant association of pre-test knowledge score regarding COVID-19 and its preventive measures with selected demographic variables. Hypothesis 4, there is no significant association of post-test self-expressed stigma regarding COVID-19 and its preventive measures. Assumption: housekeeping staff of Medanta Hospital might have knowledge regarding COVID-19 pandemic. Video-assisted teaching, that is VAT, might enhance the knowledge regarding COVID-19 pandemic among housekeeping staff of Medanta Hospital, Gurugram, Haryana. The limitation is housekeeping staff of Medanta Hospital. Methodology: research approaches, quantitative research approach, research design, pre-experimental one group, pre-test post-test designed. Setting is Medanta Hospital, Gurugram, NCR. Population is housekeeping staff of Medanta Hospital. Sample size 100. Sample technique is convenient sampling technique. Tools of data is categorized into 4 again. That is A, demographic variable. Section B, structured knowledge questionnaire. Section C, self-expressed stigma scale, and section D, video assisted teaching. Analysis is analyze using descriptive and inferential statistic. Criteria for selection of sample: inclusion criteria, housekeeping staff who are present or available at the time of data collection. Housekeeping staff, those who want to participate in the study. Exclusion criteria is housekeeping staff who are unwilling to participate in the study, and housekeeping staff who are sick or absent at the time of the study. Development and description of tool. It consists of demographic variable, which has 10 items, self-structured knowledge questionnaire, which consists of 25 questions, self-structured Likert stigma scale consists of 10 points, and video assisted, which consists of 9 minutes. The procedure for data collection is prior permission has taken from higher authority, and then consent from participant has taken, that is from housekeeping staff. And I introduced to the participant with the promising for maintaining confidentiality. And also I explained the purpose, need, and procedure of the study. And then demographic variables were collected, which is followed by video-assisted teaching, and post-test was done to the group, and then data was collected and then tabulated and analysis. In the part of analysis and interpretation, in first one, demographic characteristic of the respondent. So this is the table. I will not read all it, but I'm just showing in this table. And some particular point that we need to see from this chart is that here in the religion, majority of the religion belongs to Hindu, that is 93%, and only 1% from a Christian religion. And demographic variables for monthly income, 10,000, those who are getting 10,000 and above were having 88%, and few of them, that is 1% for getting their salary from 5,000 to 6,000 and 6,001 to 7,000. Demographic variable for previous knowledge, 91.7 having previous knowledge and 8.3 having no knowledge regarding COVID-19. And when I check to the data, 8.3 were belong to those who are newly joined in the hospital. And in section 2, distribution of frequency and percentage of knowledge score and self-expressed stigma score of respondent on COVID-19 and its preventive measures, on the criterion basis, it is categorized into 3 groups. And inadequate in pre-test, 84% having inadequate knowledge, moderate 16% having moderate knowledge regarding COVID-19 and its preventive measures, and 0% having adequate knowledge. And in post-test for knowledge regarding COVID-19, they have 0% having inadequate knowledge, 7% having moderate knowledge, 93% having adequate knowledge. And in criterion measures for the stigma also, in pre-test, 0% having favorable regarding stigma related to COVID-19, and 86% having moderate stigma, and unfavorable 14% were there. And after the stigma scale, and then after the video assisted teaching, 0% having unfavorable, and 58% having moderate stigma, and 42 having favorable. And section 3, effectiveness of video assisted teaching regarding COVID-19 and its preventive measures among the housekeeping staff. In knowledge for pre-test, mean is 10.53, SD is 2.355, and for post-test,
8 minutes, please wrap it up.
Okay, ma'am. And post-test, mean 22.45, SD 1.855, and the mean difference is 11.92. DF is 99, but T value is 58.57, and P value is 0.001. Self-expressed stigma in the mean value is 28.15, SD is 3.328, and in mean in post stigma Likert scale is that 20.87 were in mean, and SD is 2.820. Mean difference is 7.28, and T value is 15.156 at 0.001. Association of knowledge score with selected demographic variables on COVID-19 and its preventive measures. The pre-test data of knowledge regarding COVID-19 and its preventive measures was not associated with the demographic variables. And association for a self-expressed stigma score with selected demographic variables on COVID-19 and its preventive measures. The pre-test data of self-expressed stigma regarding COVID-19 and its preventive measures was not associated with the selected demographic variable. Conclusion. The study concluded that there was a significant difference in knowledge and self-expressed stigma before and after the administration of video-assisted teaching regarding COVID-19 and its preventive measures among the housekeeping staff in selected hospital, Gurugram, Haryana. There is no association of pre-test knowledge score and self-expressing mass score with selected demographic variables. It was proven that VAT was effective for the housekeeping staff who are working in selected hospital in Gurugram, Haryana regarding COVID-19 and its preventive measures. Implication of the study is that nursing practice, nurse educator have responsibility to update and know more about the COVID-19 and its preventive measures. And in nursing administration, nurse administrator may use the finding to improve quality services in the hospital. Nursing research, nurse researcher updates the knowledge with the finding and study. And these are my references. I conclude here my presentation. Thank you so much, ma'am. Thank you so much, everyone. Ma'am,
Right.
is there any question?
Let's go ahead and proceed with the next presenter, Lekka Beast, PhD scholar, Swami Rama Himalayan University. Go ahead.
Hello everyone. My today's presentation is a descriptive study to assess childbirth preparedness, childbirth fear, and childbirth expectation among primary gravida mothers in selected health centers of selected community health centers of Noida, Uttar Pradesh. This study that I'm going to present is a part of my PhD thesis. So one section of the thesis I am presenting. As we all know that pregnancy is a time of pregnancy is a very vital event in the life of every woman, and each and every woman when passes through this 9 months or 38 to 40 weeks, it requires a lot of preparation, and sometimes this preparation the female gets a lot of support from the family members, and sometimes she is not at all aware that what type of preparation she should undergo during before the childbirth. And various review literature suggests that if a female is not well prepared, it may result into a negative childbirth experience, which might be deteriorating for her further reproductive health. The objectives of the study is to assess the level of this childbirth preparation among the primary gravida females, their expectation related to their pregnancy, and the fear that they might be having for the childbirth. Operational definition of the study is childbirth preparedness. In this study, it refers to the childbirth planning, knowledge related to the childbirth process and the medical interventions, and the attitude or the perception the female is having related to the childbirth. And this childbirth preparedness will be measured with the childbirth preparedness questionnaire among the primary gravidas who are in 28 to 36 weeks of pregnancy. Childbirth expectation in this study refers to primary gravida women in terms of caregiving environment in the healthcare setting, the labor pain, spousal support and control participation, and medical support as measured by childbirth expectancy questionnaire. Childbirth fear refers to fear among primary gravida in related to childbirth. Primary gravida in this study refers to first-time pregnant women who are in 28 to 36 weeks of pregnancy. Assumptions. Prospective parents expect joyful and safe birthing. Magnitude of self-control during labor is associated with the childbirth expectation. Childbirth experience have pervasive physical and psychological impact on the women's health. Primary gravida will be able to express their childbirth experience, and primary gravida will be willing to share experience frankly and honestly. Methodology. The research approach in the study is quantitative research approach and exploratory. In this study are the primary gravida, as I told earlier, and who are in 28 to 36 weeks of pregnancy. And the sample size is 50. Sampling technique used is randomization, simple randomization technique with snooze method, that is sequentially numbered opaque sealed envelope method. Research setting of the present study is the Community Health Center, Gautam Budh Nagar. Inclusion criteria of the study are all those primary gravida females who are in 28 to 36 weeks of pregnancy, who have registered themselves in the selected community health center and who are up to the age of 35 years willing to take part in the study are included. And exclusion criteria are those women who are having any history of habitual abortion or who are having some complication related to pregnancy. The tools used for the study is socio-demographic and obstetrical characteristic questionnaire. It comprises of 10 questions from the socio-demographic area and 5 questions from the obstetrical characteristics. Tool 2 includes childbirth preparedness questionnaire. This questionnaire was developed by the researcher, and here 40 items were included, and the subsections were questions related to the childbirth plan, then childbirth preparation, knowledge related to the childbirth process, and attitude and perception. Tool 3, childbirth expectancy questionnaire, is a standardized questionnaire which was developed by Beaton et al. In 1991, and this questionnaire is further includes certain subdomains like the careful and the caregiving environment, expectation related to pain, expectation related to the nursing support and all. And tool 4 is Wijma childbirth expectancy questionnaire, which was developed by K. Wijma, and this scale actually measures the pain related to childbirth. Ethical permission was taken from Swami Rama Himalayan University Ethical Clearance Committee, and administrative permission was taken from Chief Medical Officer of Gautam Budh Nagar, Noida. Data analysis. Data is organized under these headings. I will be presenting it in certain tables, like data analysis for socio-demographic and primary and pregnancy characteristics shows that the mean age is 26.3 plus minus 2.05. Most of the females were educated, were having primary education, and husbands of the females were also having primary education of 56.3%. Majority of the females were most of the females were laborer, 45.4%, and most of the females were housewife. Data analysis for family annual income shows that 80% were having the annual income of up to 3 lakh. Marital status, all of the females were married, and most of them they belong to a joint family, and majority of them were Hindu, and most of them were using bike as the mode of transportation from home to community health center. Pregnancy characteristics, the data related to pregnancy characteristics shows that the majority of the females were having a planned pregnancy. That means they have already discussed and planned. It was not an unplanned one. And most of them were having regular antenatal visits. And the gestational age for most of the female was 33.9. Frequency and percentage distribution of primary gravida related to the childbirth preparation shows that 41.8% of the female were having a below average level of knowledge related to childbirth preparation. That means most of them were not aware. Most of them were not aware about the sign and symptoms of labor, about keeping some aid or preparation that they should do before visiting to before labor. That is, it can be a financial preparation, it can be transportation, it can be arrangement of the blood donor or something like that. So these all preparation, this all knowledge was not found among most of the females.
Time is up.
Next is
please wrap it up.
The pregnancy and percentage distribution of primary gravida related to childbirth expectation. It shows that 76.3% of the primary gravidas were having negative childbirth expectation. Domain-wise expectation level, if we see, most of the primary gravidas were having a negative expectation related to the significant other support, nursing support, and pain and coping. Frequency and percentage distribution related to childbirth fear shows that 45.4% of primary gravidas were having a high degree of fear related to labor. Certain studies which are having the similar findings were also done, which was done by Pridal et al., Massoy et al. They have also found the similar findings, which shows a poor childbirth preparation and negative expectations among priming gravida. Implication of the study might be like as my the major objective or the primary outcome of my PhD thesis is that to develop an intervention, a need-based intervention in order to improve the childbirth experience and expectation. So such as that can be the implication of such kind of studies. Then the limitation of the study is that a comparative study can further be done on for priming gravidas and multigravida, and even it can be replicated to a larger sample. My study finally concludes that usually the priming gravidas or the first time pregnant mothers were having a negative expectation, a high fear related to childbirth, and poor preparedness for childbirth. Thank you so much.
Next, I would like to welcome Dr. Sabat Naful Misirial Dalal to present assessment prevalence of diabetes mellitus and awareness regarding prevention of diabetic foot ulcer. Does it supposed to have a sound? Hello? Hello? Hello?
Hello, I'm audible.
Yes, you are audible now. Please proceed.
Okay.
You have 8 minutes.
Okay, thank you so much. I'm Dr. Shabana Jalan, working in King Faisal University as an assistant professor. Let me present about the prevalence of diabetes mellitus and the prevention of diabetic foot ulcer. As we all know that the diabetes mellitus is a disorder in which inadequate insulin secretions from pancreas, which is causing abnormally high blood glucose levels, and in which type 2 diabetes is a very serious condition in that the blood glucose level will be keep on rising if you are not managing or controlling the problem. So here the statistical report were showing that the type 2 diabetes mellitus is very prevalent in global level. Also in Saudi Arabia is in second place with the highest prevalence among the Middle East countries. So this statistical report showing that the diabetes prevalence in the year 2019, it's more than 20% in Saudi Arabia, according to the World Bank report. So diabetic foot is a debilitating condition affecting up to 50% of the patients with both type 1 and type 2 diabetes. So the non-traumatic, this risk of non-traumatic lower limb amputation is 15 times higher in diabetic patients when comparing with the non-diabetic patients. Hence, the researcher realized that the patient education about the correct foot care practice is the cornerstone of the prevention of diabetic foot disease. And also the larger number, that is more than 50% of the diabetic patients were found to have poor knowledge of diabetic foot care. And studies also have shown that only 13.3% of the study participants have good knowledge about the diabetic foot care. So the patients who received good education on the diabetes and the diabetic food care had better knowledge and had favorable attitude toward the diabetic food care. These are some of the evidences from the previous studies. Hence, the study is aimed to determine the prevalence of diabetes mellitus, to find the awareness among the people about the prevention of diabetic food ulcer, and to associate that knowledge level with selected demographic variables. So the statement of the problem is a study to assess the prevalence of diabetes mellitus and awareness regarding prevention of diabetic food ulcer among the people residing in Al-Hasa. So in methodology, the descriptive design-based cross-sectional study was selected as a research design, and the study was conducted to assess the prevalence of diabetes mellitus as well as assess the knowledge level of the prevention of diabetic foot ulcer among the people who visited Al-Otay Mall during the campaign, which is conducted by the King Faisal University. This mall is the people residing in Al-Hasa. This Al-Hasa is in the eastern region of the Kingdom of Saudi Arabia. So here, considering the variables and outcome of the study, a total of 369 people aged from 30 years onwards, including both genders with different educational grades, were included. From them, 62 people with type 2 diabetes were selected by randomization to assess the knowledge about the diabetic foot ulcer. So the data was collected by using the structured questionnaire. The tool includes part one is about demographic information, which included age, gender, education, occupation, nationality, duration of the diabetes mellitus, and the regularity of the visiting the diabetic clinic, and also the source of health information. The second part of the tool is knowledge questionnaire, which has 20 multiple choice questionnaires. These questionnaires were translated in Arabic and also in English. So the ethical consideration, ethical approval was obtained from the Research Ethics Committee of the DSR from the King Faisal University, and also the informed consent obtained from the patients. And also the statistical analysis we used is descriptive and the inferential statistics. So the results were proving that among 369 people surveyed, 126, that is 34.1% were prevalent of type 2 diabetes. And among them, 62 were selected to assess their knowledge level regarding the food care and the diabetic food prevention. So here the age-related status showing that 12% are more than 60 years, and 51 to 60 years, 24% are in the age of 51 to 60 years, and 47% are in the age of 41 to 50 years, and 17% are in the age of 30 to 40 years. And this is about the gender. So among them, 33% are male and 67% are female. So we can see here majority, that is 36% of the people were obtained until higher secondary education, and 9% only were graduate and others. So regarding the duration of illness, 18% within 2 years they have diagnosed with diabetes, and 32% from 3 to 5 years duration, and 28% 6 to 8 years, and 22% were more than 8 years. And here we can see that 33.9% of the people among the from the 62 members, they had poor awareness about the food care, and also 54.8% about they were having average level awareness. 11.3% had adequate awareness. So also the association table showed that there was significant association between the knowledge with the education and also the regular DM clinic visit of the people. That is the P level 0.001. So some of the studies, like a study on attitude and knowledge about the food care among diabetic patients in Riyadh, revealed high percentage surveyed of the population had good knowledge and good practice. Another study on knowledge, attitude, and practice regarding diabetic food care among Saudi and non-Saudi diabetic patient in Al-Garj. That also proved that the population has sufficient knowledge about diabetes. But however, the current study showed that only 11.3% had adequate awareness about the prevention of diabetic food. So I would like to conclude here, based on the survey, the prevalence was very high, and most of the people are not aware of food care and the prevention of diabetic food. And rigorous effort should be taken now, at least by the MOH, to raise the awareness about the diabetic food among the people with the diabetes mellitus to prevent the mortality and morbidity. And also the study is highly needed here, recommending that it's highly needed to create awareness about the food care and their importances, which has really a major impact on the quality of life. So these are some of the references which I added in my study. Thank you so much for listening. Any questions?
Thank you so much. And yeah, now we will be proceeding with our lunch break. And I would like to request everyone to be back at exactly 2:45 India time. See you guys later.
Bye-bye.
Everyone will resume in 5 minutes.
Welcome back, everyone. All right, and now we will proceed with our session 3 about obstetrics, gynecology, and general nursing. And I would like to welcome our session chair, Dr. Shabanatul Misriya, Associate Professor, King Faisal University, Saudi Arabia.
Thank you for welcoming Dr. Joe.
Hello, Dr. Chair. Yep, I'll go ahead and proceed.
Yes.
All right. Now we'll let us welcome our video presentation. First, the video presentation.
One moment, everyone.
Introduction. Postpartum hemorrhage is the leading cause of maternal death in low-income countries and is the primary cause of approximately one-quarter global maternal death. The different cadre of healthcare professionals should be empowered and insensitized to support their communities in their appropriate role and distribution modalities. This will complement efforts to increase the facility delivery rate and serve to link women to the formal health system. Postpartum hemorrhage is a life-threatening situation, and as obstetrician nightmare, it remains a major cause of maternal morbidity and mortality worldwide. It is still an important issue in the developing countries. About 13% of all the deliveries may result in postpartum hemorrhage with a blood loss of more than 1 liter, while life-threatening hemorrhage occurs 1 in every 1,000 delivery. There are 6 lakh maternal deaths reported worldwide every year, and 99% of this occurs in developing countries. Around 25% of all the deaths in developing world are due to postpartum hemorrhage. The prevalence of postpartum hemorrhage in India is 23%. Uterine atony is the most common cause of PPH in about 75 to 90% of the cases. In the developing countries where most birth occurs in the home or in the local clinics, the intervention needed to treat postpartum hemorrhage like emergency referral, obstetric care, blood transfusion, and surgery are simply out of reach for the majority of women. Prevention of PPH began its work by assessing the challenge to the problem statement is a study to evaluate the effectiveness of planned teaching program on knowledge regarding management of postpartum hemorrhage among female health workers in selected CHC in North.
My apologies. The video is not audible. One moment, please. Let me replay that.
Introduction. Postpartum hemorrhage is the leading cause of maternal death in low-income countries and is the primary cause of approximately 1/4 global maternal death. The different cadre of healthcare professionals should be empowered and insensitized to support their communities in their appropriate role and distribution modalities. This will complement efforts to increase the facility delivery rate and serve to link women to the formal health system. Postpartum hemorrhage is a life-threatening situation, and as obstetrician nightmare, it remains a major cause of maternal morbidity and mortality worldwide. It is still an important issue in the developing countries. About 13% of all the deliveries may result in postpartum hemorrhage with a blood loss of more than 1 liter, while life-threatening hemorrhage occurs 1 in every 1,000 delivery. There are 6 lakh maternal deaths reported worldwide every year, and 99% of this occurs in developing countries. Around 25% of all the deaths in developing world are due to postpartum hemorrhage. The prevalence of postpartum hemorrhage in India is 23%. Uterine atony is the most common cause of PPH in about 75 to 90% of the cases. In developing countries where most birth occurs in the home or in the local clinics, the intervention needed to treat postpartum hemorrhage like emergency referral, obstetric care, blood transfusion, and surgery are simply out of reach for the majority of women. Prevention of PPH began its work by assessing the challenge to the effective prevention and treatment of postpartum hemorrhage. Delayed diagnosis and poor management of postpartum hemorrhage are assessed as the main cause for increased mortality and morbidity in the country. The problem statement is a study to evaluate the effectiveness of planned teaching program on knowledge regarding management of postpartum hemorrhage among female health workers in selected CHC in Noida. The objective of this study was to assess the pre-test knowledge of the female health workers regarding management of PPH, evaluate the effectiveness of planned teaching program on knowledge gained by the female health workers regarding the management of PPH. The last objective is to determine the association between pre-test and post-test knowledge score of female health workers with selected demographic variables. Next is the need for the study. Postpartum hemorrhage is one of the most leading cause of maternal mortality and an important cause of serious morbidity. Healthcare professionals, especially nurses, should have an important role in prevention management of postpartum hemorrhage. As an investigator, through her detailed review of literature and clinical experience, it is found that the female health worker have inadequate knowledge in various aspects of PPH. Hence, the investigator felt the need for assessing the female health worker knowledge regarding prevention and management of PPH and to develop an informational booklet and appropriate guidelines on postpartum hemorrhage. This will help to provide efficient knowledge regarding prevention and management of PPH. Operational definitions. Effectiveness. It is referred to the extent to which a PTP developed has achieved the desired result as evidence in terms of gain in knowledge score regarding prevention and management of postpartum hemorrhage as measured by the structured questionnaire. Planned teaching program. It refers to systematically organized teaching strategy for 45 to 60 minutes on management of PPH with various audio-visual aids. Knowledge refer to the level of awareness and understanding of the female health worker regarding management of PPH. Female health worker refer to the specially prepared registered nurse employed in the community health center to safeguard the health of the person in the community, giving care to the sick in their home, promoting health and well-being by teaching families how to keep well and assisting in the program for prevention of disease. Management refers to planning, organizing, leading, and controlling the efforts to prevent the complication in the third stage of labor. It includes active management of third stage of labor and also prevention of PPH. Next is the hypothesis. The mean post-test knowledge score of knowledge on management of PPH will significantly be higher than the mean pre-test score among female health workers. There will be a significant association between pre-test level of knowledge of female health worker with selected demographic variables. There will be a significant association between post-test level of knowledge of female health worker with the selected demographic variables. Assumption are female health worker may have inadequate knowledge regarding management of third stage of labor. The knowledge level of female health worker will be influencing on their practice. Administration of protocol on management of third stage of labor may help to improve the knowledge of female health workers. The limitations of the study are female health workers who are working in the community health center at Noida, female health workers who are willing to participate in the study, female health workers were available during the period of study. Conceptual framework. The conceptual framework for the present study is developed from Pendler's health promotion model. This model is useful to the female health worker as a framework for client assessment. This model expands the principle of the health belief model and states that individuals are likely to engage their behavior to feel better physically, psychologically, socially, and spiritually. So this is the conceptual framework model which is adopted for the study, which is modified from the Pendler's health promotion model. We first have influencing or modifying factors that are the female health worker, under which we have the demographic variables. Next, we have female health workers who are working in the community health center. Cues to action means health education with educational media which we are using for the planned teaching program. Cognitive or perceptual factors which have the planned teaching program. The content which we have is types of PPH, what are the causes, signs and symptoms, active management of third stage of labor, methods of expulsion of the placenta, OCCT, complication of PPH, management of third stage bleeding, and steps of manual removal of the placenta. The last step is participation in the health promotion behavior, which will lead to improved knowledge regarding management of PPH, and then gain knowledge and apply it for the management of women having postpartum hemorrhage. Methodology are research, design, pre-experimental, one group, pre-test, post-test design. Research approach is quantitative and evaluative approach. Setting is at Dadri Gautam Buddha Nagar Community Health Center, Noida. Sample size is 40 female health worker. Sampling technique is purposive sampling technique. Tools are self-administered knowledge question. Schematic presentation of the research design. We have purposive sampling, pre-test, intervention, and then post-test. Development of the tool. The steps involved are preparation of the blueprint, preparation of the final draft, then development of criteria checklist, content validation of the tool, reliability of the tool, and last one is preparation of the final draft. Content validity was taken from the expert. Reliability score was 0.98 and development the tool was found to be reliable. Next is plan for data analysis, in which we have used both descriptive and inferential statistics plus chi-square to find out the association of post-test knowledge score with the selected demographic variables. This is that graph which shows classification of the respondent on the pre-test knowledge level and management of PPH. So here we can see inadequate knowledge, 70% of the respondent are having, 30% have moderate, and adequate knowledge, none of the female health workers are having adequate knowledge. Now, classification of the respondent after the post-test knowledge, we can find that 32.50% have moderate knowledge, 0% has inadequate knowledge, and adequate knowledge we are having 67.50%. That means there is an increase in the knowledge after the planned teaching program. Next is classification of the respondent on knowledge level on management of PPH. So here is a comparison of pre-test and post-test knowledge, inadequate knowledge, moderate and adequate knowledge, as we can see in the graph. Next is overall pre-test and post-test mean knowledge on management of PPH. Pre-test is 35.10, post-test is 85.2, and enhancement of knowledge, 50% enhancement of knowledge after giving the planned teaching program. The data depicts that majority of the respondents, 70% of them, have inadequate knowledge in management of PPH, while 67.5% of them have adequate knowledge during the post-test, and only 30% of them got moderate knowledge during pre-test and 32.5% at the post-test. The statistical test reveals that there is significant enhancement in the knowledge level from pre-test to post-test. There was a significant association of post-test knowledge score with the following variables, that are the age, type of health worker, time in the post, experience, and previous experience of handling postpartum hemorrhage. Conclusion: the study was conducted to assess the effectiveness of the planned teaching program on management of postpartum hemorrhage in the selected CHC at Noida. In this study, pre-experimental one-group pre-test post-test design was used by taking 40 samples through purposive sampling technique. The data was collected by using structured multiple choice question. PTP was developed on the basis of effective audiovisual aids according to their convenient timing and place. The data was interpreted by applying respective statistical methods.
I don't think the representative is here to answer questions.
Yeah, so you can proceed the next.
All right, thank you so much, Dr. Chair. And now, I would like to invite Akansha Tripti Horo, KIIT. The topic is about a comparative study on daily fetal movement count chart and Cardiff count 10 chart in relation to maternal compliance and mother's perception on self-assessment of fetal well-being in the selected tertiary care hospital of Bhubaneswar. Go ahead, please.
Yes, good afternoon, ma'am. Thank you for this opportunity. Is my screen visible? Hello, ma'am?
Hello?
Hello, ma'am. Is my
There,
voice
yeah.
audible?
Yes, you are audible and your screen is coming up. You have 8 minutes. Have it on presentation mode. Go ahead.
Yes, ma'am. Thank you so much. So good afternoon, all the representative there. Myself, Ansha Tripti Horo. My today's for presentation. For that, my guide was Professor Mrs. Kalyani Rath, ma'am, who was HOD of Obstetrics and Gynecology, King's Kid Team to be University. My co-guide was Mrs. Anusha Bera, Associate Professor, King's Kid Team to be University, and myself was from the Department of Obstetrics and Gynecology. My problem statement was a comparative study on daily fetal movement count chart and cardiac count 10 chart in relation to maternal compliance and mother's perception on self-assessment of fetal well-being in the selected tertiary care hospital, Bhubaneswar. Introduction. So as pregnancy is considered as a very precious event in every woman's life, it is filled with happiness, joy, and surprises. Every parent's hope for a healthy baby, but manage it sometimes becomes sorrowful when danger sets in. And at present, as we know that the current infant mortality rate for India in 2021 is 28.771 deaths per 1,000 live births, a 3.61% decline from 2020. The infant mortality rate for India in 2020 was 29.848 deaths per 1,000 live births, a 3.48 decline from 2019. So healthcare providers have made achievements in decreasing poor outcomes of the pregnancy by using newer technologies, procedures for the assessment of fetal well-being. The non-stress test, contraction test, stress test, ultrasound scan, and biophysical profile are accepted screening and diagnostic tools in antenatal care. Yet these procedures are costly, invasive, and carry risks, making them impractical for the use as routine screening tools in low-risk pregnancies. Why do we need, what is the need for the study? So decreased fetal movement has been associated with poor pregnancy outcome, including stillbirth. About 50% of women with stillbirth, they reported that they felt a gradual decrease of fetal movement before intrauterine death. And fetal movement in utero are a movement's expression of fetal well-being. By counting the fetal movement, a mother can therefore monitor the condition of the fetus. Assessment of fetal movement is a non-invasive method of monitoring the well-being of the fetus. And we know that quickening is the first point at which the woman experiences fetal movement in early pregnancy. So it is a significant point in pregnancies for many women in primary gravida. It may be felt from 18 to 22 weeks in multigravida, and multigravida we can see from 16 to 20 weeks. A fetal movement chart records the frequency of the fetal movements and thereby assesses the conditions of the fetus. It is a simple, valuable, effective, reliable, and harmless screening of fetal well-being in low and high-risk pregnancies. Followed by the objectives of my study. First objective is to compare the maternal compliance and maternal perception towards daily fetal movement count chart and cardiac count 10 chart. Second, to find out the correlation between the maternal compliance and perception towards daily fetal movement count chart and cardiac count 10 chart. And third, to determine the association between the selected demographic variable and maternal compliance to daily fetal movement count chart and cardiac count 10 chart. The assumptions for my study was the mother may comply to and record the fetal movement by using any of the two methods, that is either DFMC chart and cardiac count 10 chart, by self-assessment. The methodology. The research approach was quantitative approach. Research design was descriptive design. Duration of the study was 7 months. Study setting is antenatal OPD in KIMS Hospital, Bhubaneswar. Sample was antenatal mother beyond 32 to 37 weeks of gestation attending KIMS Hospital, Bhubaneswar. Sampling technique is non-probability convenience sampling technique. Sample sizes 324 samples, and data collection was questionnaire cum interview method. Data collection tool is a demographic data questionnaire on mother's plans and perception scale for mother's perception. Followed by the tool. The tool was divided into 3 sections. The first section included the demographic variable, which included age, education, status, occupation, income, religion, number of working hours per week, gestational age, normal and high-risk pregnancy, number of antenatal visit, any method to count and keep track of your baby's movement in this pregnancy or previous pregnancies by the mother, and previous knowledge about fetal monitoring. The section B included the questionnaire on mother's perception about fetal movement on chart. In this, the questionnaire, it consists of 10 questions, and each question has 5 possible responses, which is definitely yes, yes, certain, no, definitely no. Categorized as 5, 4, 3, 2, 1, and the mother's perception was graded accordingly. The interpretation was below 23 was poor, if between 23 to 36 was good, and 37 to 58 was very good. The section C included the questionnaire on mother's compliance about fetal movement concept. In this questionnaire the questionnaire consists of 10 questions. It will help to us to know the compliance and the non-compliance of the mother. It was the tools. Then under the pilot study was conducted to test the reliability, the practicability of the tool, and the feasibility of conducting the study. So 10% of the total population was taken, that is 32 samples were selected for the pilot study, and it was conducted for 2 weeks at KIMS PBMH. The selection is mainly based upon the inclusion criteria. Among 32 samples, 16 samples were assigned for DFMC chart and 16 were assigned for the cardiac content chart. The results of the pilot study showed that both DFMC chart and cardiac content chart, in this mothers completed all the days and mothers were showing good risk perception. Followed by how the data collection procedures, which was the data was collected through interview cum questionnaire method and mothers' records. 324 antenatal mothers who met the inclusive criteria were selected for the study. And after collecting the data, the random assignments of subjects was done with for each subject. Half mothers were given cardiac content chart, and the mother who got the DFM chart instructed to record the number of fetal movements perceived by mother 1 hour after food, breakfast, lunch, and dinner. And those who got cardiac content chart were instructed to record the fetal movements for the period of 8 to 12 hours. Both the charts were collected during the next visit and asked the mother to fill up the questionnaire for assessing the mother's perception about fetal movement chart, followed by the analysis and interpretation. So after doing the analysis, as the first objective says, the comparison between the mother's perception and maternal compliance towards cardiac content chart, the value as shown is that the mother's perception of the cardiac count, the mean came was 34.65, the standard deviation was 2.866. Under DFMC, the mean came was 35.48, standard deviation was 3.486. Under that Man-Whitney U-test, the value was 2.341. The p-value which came was 0.019, which was statistically significant. Next objective, comparison of the groups for the maternal compliance score. In this, the cardiac content, and in this, the mean value was 6.70, the standard deviation was 1.103, and under DFMC, 7.25, and standard deviation was 1.752, and the Man-Whitney U-test score was 2.826, which was also statistically significant under the p-value. Followed by the correlation of perception scale, which was for the DFMC group, the perception scale score and the maternal compliance, the correlation value was 0.067. In that, the p-value came was 0.394, which was not significant. And the correlation of perception scale score with maternal compliance for the cardiac group, previously was the DFMC group, this is the cardiac group. Under this, the correlation value for the perception scale score and maternal compliance was 0.042. In that, the p-value came was 0.597, which was also non-significant. So for the correlation objective, the both have came non-significant. Then came the association of maternal compliance. Just a second. So under the associations with the demographic variable, which was my third objective, in this, under the cardiac group, only the last objective was last working hours was not significant. Otherwise, all the objectives according to with the demographic variable was associated, and it was statistically significant with the demographic variable. Okay. Next was, as we can see, the major findings, which, hello?
8 minutes already.
Yeah, just
Please wrap it
I'll
up.
wind up. Yeah. The major findings which we can see here is, out of the 324 antenatal mothers, majority of the mothers used cardiac count 10 chart, and 108 like 66.66% and 69.71% used DFMC chart who come under the age of 26 to 30 years. And under educational status, 69.75% used cardiac count 10 chart, and 53.08% used DFMC chart who were graduate. Majority of the antenatal mothers were homemakers, were 41.97%, who belong to the cardiac content chart, and others belong to the TFMC chart. And in majority, 45.6% belongs to the cardiac content chart, who had the income range of 25 to 30,000, and 38.88% who had the income range of 30 to 25 to 30,000. Then came the religion part. In that, so 77.16, that is the majority of them were Hindus. Then under the section of working hours, 40.12% cardiac count 10 charts which we have used, those mothers were present who were having working hours of the mothers having using the other categories of working hours, and 61.11% using the FMC chart for using working hours, which had no fixed times. And next is your 53.70% who were under the category of 36 to 37 weeks of gestation, 52.46% who were under the a group of 34 for 36 weeks of gestation. These were other major findings, which is 99% of the mothers were belong to the normal pregnancies. Only 1% were having high risk pregnancy. The next is the cardiac count 10 chart. In that, 53.8% of the cardiac group mothers and the 58.02% of the DFMC group mothers, they came during the third trimesters, which was found. And out of the 324 antenatal mothers, 74.69% of the cardiac count 10 chart mothers and 64.81% of DFMC chart mothers were taught about the methods of the fetal count. And under last section, 76.54% of cardiac count 10 charts and the DFMC, that is 80.24%, mothers had no previous knowledge about the charts. Next is the comparison. So in comparison, mother's perception among the
please wrap it up.
Yes, ma'am. So coming to the discussion part, as you can see in the present study, the mean score of the cardiac count 10 chart is 34.65 and standard deviation is 2.86. This was found similar to the other study also, which was done. It is shown in minority respondents. It was done by Valeria Smith in 2014. In that, 62% and 47% of the low risk mothers and 78.51% of high risk mothers were advised respectively. And next, in the second, which is showing the values, which is also related to the next study, which was done by James F. Pearson et al. 2014. And the correlation also in this, which was not found significant, it was also related to one of the study which was done by Singh et al. 2013. The nursing implication, as we can say that for every mothers, the nursing personnel should advise the mother to support, and they should motivate them, and how to do self-assessment should be taught. And the recommendation for the further study would be a comparative study can be conducted between the DFMC chart and cardiac potential in terms of fetal attachment scale. And the limitation as seen was during the time of data collection, some staffs were not cooperative and some barriers were not addressed by the participants. These were my references, and the conclusion was 2 main protocols are used to assess the fetal well-being. The past research have shown that the maternal monitoring of the fetal movement can lead to lower incidence of stillbirth. While comparing the DFMC chart and cardiac count 10 chart, the effectiveness of using DFMC chart for the self-assessment of fetal well-being by the antenatal mothers in relation to the maternal compliance. So conclusion is the DFMC chart was considered more important as compared to the cardiac count 10 chart for the self-assessment. And these were my pictures as during the process. Thank you. Thank you, ma'am. Thank you, sir.
Thank you so much. And Dr. Chair, do you have any questions?
Ms. Akansha, I would like to appreciate your work on the study. Thank you. How did you overcome the limitations when you faced your data collection?
Ma'am, thank you for the question, ma'am. During my study, there was a little complications like it was during the COVID time. So lots of the mothers were not allowing us to physically physically come closer to them. So that was one of the issue that time. We used some of the barriers like making distance and collecting data. That was one of the barriers. And sometimes when we made them understand, when we personally went in front of them to make them understand about the charts and how you can self assess yourself about the decreased fetal movement, that time it was having a problem, but yet it was covered up through our by ma'ams and also the doctors. They helped us a lot in this process. They made them understand that they are helping you to self assess yourself during this COVID time, because it was not possible for every mothers to come to the hospital during this pandemic time.
Okay, thank you, dear.
Thank you,
Dr. Joe, you can continue.
All right, thank you so much. And now I would like to invite our next presenter, Kavita Ramapan, with the topic of the feasibility and practicality of blinding and randomization process of probiotic and supplementation and maternal glycemic level among gestational diabetes mellitus. A feasibility study report. Kavita? Kavita? Oh. Yep, I can see your screen. Please, I cannot hear you yet. Hello? Kavita? We cannot hear you.
Can you hear me now?
Yes, I can hear you now. You have 8 minutes. Have it on presentation mode.
Yeah. Can you see my slides?
Yes.
I will start just now. Very good afternoon to one and all. Thank you for this very great opportunity to share my feasibility study under this expertise team. And I'm Kavita Ramanathan. I have done my PhD as a full-time scholar, and currently I'm working as an associate professor. Now, before even I could unfold the study, I would like to just discuss on the need for the study. How did I choose this topic? Actually, when I went on to search the research thrust area, the main point that I discovered was that from the Diabetes Foundation of India, which showed that 50.9 million people suffer from diabetes, especially in India, and it is likely to increase to 80 million by 2025. And because of this alarming number, India has been termed as diabetes capital. And this really gave me, the researcher, to think about whether we can go on for the diabetes as a research thrust area for my PhD. And now, with that need for the study, when I went in to search for global prevalence of diabetes, to my surprise, I was able to see the prevalence in India increased to 150% from 2000 to almost 2030. And again, I went on to see for the prevalence of diabetes in India, and especially under 4 corners, like if you say North India, South India, East India, and West India, I was able to see that in Chandigarh, North India, we were able to see the highest level of diabetes. And Tamil Nadu in South India stood second place, which is my hometown. And among the population in Tamil Nadu, urban population seems to be again having highest incidence of diabetes, wherein I am residing in urban population. Then that gave me an alarming call, an alert for me to go on for this title of the study, Effect of Maternal Probiotic Supplementation on Glycemic Control and Pregnancy Outcomes among Gestational Diabetes Mellitus, which is going to be a randomized control trial. With that, when I went on to review of literature, to search for literatures that will support my study, which showed a recent meta-analysis on GDM women increased the risk of type 2 diabetes when it is not getting treated at the time of gestational diabetes mellitus. And next, an integrated review that was done by using the literatures that was published from 2000 to 2013 showed that there are various interventions that can be utilized for treating diabetes mellitus. So the common combined intervention that was used was exercise, self-monitoring of blood glucose levels, and counseling and behavioral therapy. And the integrative review finally concluded that with this type of combined interventions, we were able to decrease the maternal blood glucose level and also improve the pregnancy outcomes. Finally, a systematic review that was done in the year 2012 highlighted that some adjuvant therapy can be included along with the combined intervention, and that was the recommended was probiotic use in pregnancy, which could help in improving the maternal blood glucose level. With that, I, as a PhD scholar, started doing a systematic review and meta-analysis, which showed a meta-analysis was done under two main areas. One is on checking the effect of probiotic supplementation upon fasting glucose level, fasting blood glucose level. It showed that probiotic supplementing to the maternal GDM mothers showed there was some beneficial effect in reducing the fasting blood glucose level. At the same time, the same probiotic supplementation for GDM mothers reduced or improved the insulin sensitivity, which means the resistance of insulin that happens during the gestational diabetes mellitus was reduced, and thereby there was improvement in the maternal blood glucose level. With this recent latest meta-analysis and systematic review, the researcher formulated objectives of the study as to determine the effects of maternal probiotic supplementation on maternal glycemic control markers. And my feasibility study objective is to check the practicality of stratification of block randomization that should be included as a study participant in my study. And I also want to check if I have the feasibility and practicality of developing the instrument that I used for this study can be tested or not. And again, I want to really check the acceptance of probiotics among the target population. With this core objectives of my pilot study, I started with the first objective of practicality of stratification of block randomization, where the stratification was carried out to group the mothers under 3 stratification based on their maternal blood glucose level. One is mother with more than 140 milligram per deciliter to 159 milligram per deciliter was stratified as 1 or A. The next is more than 159 milligram per deciliter to 199 milligram per deciliter, a second group or second strata. Third strata were mothers who were having more than 199 milligram per deciliter. And these 3 strata groups were checked or tested during this pilot study, and the mothers were assigned to 3 strata based on the sequence that were generated through computer software in block size software. You can see this is the type of list that was created by using the software, a simple randomizer V1 list that was done in the year 2019. Now, how these groups, the methodology that was followed in my study was, we had 2 groups, group 1 and group 2, wherein the intervention group received routine care with probiotic supplementation in terms of capsule. Group 2 received routine care with placebo as capsule for a day, 1 capsule for almost a month, and this feasibility study was done for 1 month. And now I keep saying about routine care. What does that routine care mean here? Routine care is nothing but the care that is received by any pregnant mother with GDM. In the study setting where I did my study, they were receiving counseling session on diet and physical activity, and this counseling session were given by trained dietitian, and they were taught about the modified diet with educational materials. And during their postnatal period, they used to get reinforcement session on compliance of lifestyle modification such as diet modification and everyday activity as physical activity monitoring. Along with this routine care, the intervention which I gave was probiotic supplementation in the form of capsule that contained Lactobacillus rhamnosus and Lactobacillus reuteri of dose 1 million colony forming unit. And the placebo were given for the mothers who are in the control group. However, I was not knowing since the group is blinded, which contained microcrystalline cellulose. The sample size chosen for this feasibility study was 10% from the sample size. The major study had 92, so totally 12 patients were included in this feasibility study. The methodological strength of this study is the RCT, True Experimental Design, which is considered as gold standard for testing the efficacy of new therapeutic regimen. My study, wherein this probiotic, which is also considered as a type of adjuvant.
8 minutes, please wrap it up.
Yes, I'm going to wind up now. And it is a triple blind study wherein the patient, researcher, and outcome were blinded by using the help of Department of Pharmacy, who were blinding the process of the capsules, and it was kept under lock and key cupboard. And the clarity of the questionnaire was measured since it was developed by the researcher. We want to check whether it is understandable by the participants, and the preliminary questions were related to socio-demographic data, and the next pregnancy outcomes were measured in terms of maternal parameters, and these maternal parameters were all those true factual information that was recorded in the case sheet of the participants. And now the analysis revealed that both the group were almost similar in their baseline characteristics. They didn't differ much, and there were, when we look into the mean differences in the fasting blood glucose level and postprandial blood glucose level between the group 1 and 2, we found there was mild differences in group 2 compared to that of group 1. And we, based on this result, after getting the analysis result, we unblinded the study and identified it was group 2, which was receiving the capsule. Capsule probiotics showed a mild difference in fasting blood glucose level in terms of reduction in blood glucose level, which showed that maybe the probiotic supplementation has got some mild beneficial effect over the blood glucose level. If this effect is going to be for 1 month, we can imagine for 6 months of trial, it will be very good effect. And findings of the feasibility study, finally to conclude, the stratification was very much feasible for first 2 strata, whereas third strata was very difficult. So we were considering whether to include this study for the major study or not. Clarity of the questionnaire was very clear and it was feasible for the major study. And out of 12 patients, 8 mothers really accepted the probiotics immediately, whereas 4 mothers accepted after their discussion with the respective specialist consultants. However, majority of the participants accepted the intervention. Finally, to take-home message here is, results reveal that the present study would be very much feasible for conduction of the major study with adequate support from the respective consultants. And also, the probiotic also revealed certain differences and beneficial effect over the improvement of blood glucose level. With that, I am completing the study. Thank you very much for this opportunity. The forum is open for your discussion. And this is the references which I use for my study. Thank you. Now, I have completed my study. I have completed my presentation.
Thank you so much. Dr. Chair, do you have any questions?
Thank you, Mrs. Kavita Ramanathan, for your neat and clear presentation. And I wish her for main study also. I don't have any question for this.
Thank you very much, ma'am.
Thank you so much. And I would like to invite our next presenter, Ms. Anuradha from Sharda University. The topic is about a study to assess and compare the effectiveness of gamification technique with lecture method in terms of knowledge correlated to antepartum hemorrhage among students of selected nursing schools of Delhi. Anuradha?
Yes, ma'am. Ma'am, the previous presenter need to end this screen sharing.
Oh, yeah, hold on. Yeah, let me handle that. Yep, go ahead, please.
Yes, ma'am.
Good afternoon, everyone. Myself, Miss Anuradha. I have done MSc Nursing from Specialty Obstetrical and Gynecological Nursing. My problem statement is a study to assess and compare the effectiveness of gamification technique with lecture method in terms of knowledge score related to antepartum hemorrhage among students of selected nursing schools of Delhi. First one, to develop plan teaching program using lecture method and bingo game on antepartum hemorrhage. Second is to assess the effectiveness of gamification technique in terms of gain in knowledge score among the students of selected nursing schools of Delhi. Third one is to assess the effectiveness of lecture method in terms of gain in knowledge score among the students of selected nursing schools of Delhi. Fourth is to compare the effectiveness of gamification technique with lecture method in terms of post-test knowledge score among the students of selected nursing schools of Delhi. For this, the operational definitions are: first one, effectiveness. It refers to the achievement of desired outcome regarding antepartum hemorrhage after administration of gamification technique and lecture method as evidenced by increase in post-test knowledge score. Second is knowledge. It refers to the correct response given by the student to the knowledge items in the structured knowledge questionnaire regarding antepartum hemorrhage. Students. It refers to those who are studying in GNM third year in selected nursing schools of Delhi. Gamification technique. It refers to technique of teaching antepartum hemorrhage through bingo game. Lecture method. It refers to method of teaching antepartum hemorrhage through verbal presentation with the help of PowerPoint presentation. Next is hypothesis. Research hypothesis 1, there will be a significant difference between the mean pre-test and post-test knowledge score regarding antepartum hemorrhage among students of selected nursing school with gamification technique as evident from structured knowledge questionnaire at 0.05 level of significance. Research hypothesis 2, there will be a significant difference between the mean pre-test and the post-test knowledge score regarding antepartum hemorrhage among students of selected nursing schools with lecture method as evident from structured knowledge questionnaire at 0.05 level of significance. Research hypothesis 3, there will be a significant difference between the mean post-test knowledge score regarding antepartum hemorrhage of experimental group 1 with gamification technique and experimental group 2 with lecture method among students of selected nursing schools as evident from structured knowledge questionnaire at 0.05 level of significance. Research methodology used in this study is: research approach is quantitative approach. Research design is through experimental research design. Research setting: Holy Family College of Nursing, and second setting used is Apollo School of Nursing. Population: GNM third year students of selected nursing schools of Delhi. Sample: selected GNM third year students of 2 selected nursing schools of Delhi. Sample size: 60 students, 30 students in experimental group 1 and 30 students in experimental group 2. Sampling technique is random sampling technique. Description of the two. It consists of two sections. Section 1 is demographic data, which consists of description of demographic characteristic of student. Section B consists of structured knowledge questionnaire on antepartum hemorrhage. Interpretation of the knowledge score. If the score is less than 16, it is interpreted as poor knowledge. Score between 16 to 18, average knowledge. Score between 19 to 21, good knowledge, and more than 21, very good knowledge. Findings. In section 1, finding was related to description of demographic variable of the selected students. In experimental group 1, total sample size was 30. In experimental group 2 and 2, that is total sample size was 30, again same. Regarding the age in year, majority of the student in experimental group 1, that is 15, which consists of 50% of the student, were in the age group of 21 to 23, and in experimental group 2, majority of the student belong to 18 to 20, that is 15 in numbers. Regarding the educational qualification, in both the group, that is experimental group 1 and experimental group 2, majority of the students have done 10 plus 2. Regarding the previous knowledge about antepartum hemorrhage, majority of the students have not any previous knowledge regarding antepartum hemorrhage. regarding the involvement of giving care to the patient with antepartum hemorrhage. Majority of the students were not involved in giving care to the patient with antepartum hemorrhage. At last, regarding the previous knowledge regarding gamification technique, majority of the student in both the group, that is in experimental group 1 and experimental group 2, doesn't have any previous knowledge regarding gamification technique in teaching. Section 2 deal with the findings related to the effectiveness of gamification technique on antepartum hemorrhage in terms of knowledge score of the selected students. In this table, one shows the mean difference, standard deviation, standard error mean difference, t-value of the pre-test and the post-test knowledge score in experimental group 1 with gamification technique among selecting students. Here N1 is equal to 30. Pre-test mean is 10.3 where post-test mean is 23.23 with the mean difference of 13 and standard error mean difference is 0.73. The calculated t-value is 17.61 where the table value is 2.045 which is less than the calculated t-value. Hence in this the null hypothesis is rejected and research hypothesis 1 was selected. This figure 1 is showing bar diagram showing the percentage distribution of pre-test and the post-test knowledge score in experimental group 1 with gamification technique among selected students. In pre-test, 100% of the student is having poor knowledge, whereas in post-test, 73.34% of the student is having very good knowledge, 13.33% of the student is having good knowledge, 3.33% of the student is having average knowledge, and 10% is having poor knowledge. Section 3 is related to findings of the effectiveness of lecture method on antepartum hemorrhage in terms of knowledge score of the selected student. Here the table 2 represents the mean, mode, mean difference, standard deviation, standard error, mean difference of t-value of pre-test and the post-test knowledge score in experimental group 2 with lecture method among selected students. N2 here is equal to 30. In this pre-test mean is 10.23 where post-test mean is 20.73 with the mean difference of 10.7 and standard error mean difference is 0.89. Here the calculated t-value is 11.96 which is greater than the tabulated t-value that is 2.045. For this research hypothesis 2 was selected and null hypothesis 2 was rejected. This is bar diagram showing the percentage distribution of pre-test and the post-test knowledge score in experimental group 2 with lecture method among selected students. In this pre-test, 96.67% is having poor knowledge and 3.33% of student is having average knowledge, whereas in post-test 46.67 student is having a very good knowledge, 20% of the student is having good knowledge, 23.33% is having average knowledge and 10% of student is having poor knowledge. Section 4 is related to findings which compare the gamification technique with lecture method on antepartum hemorrhage in terms of knowledge score of the selected students. Here the table 3 represents the mean difference, t-value of the pre-test and the post-test score in experimental group 1 with gamification technique and experimental group 2 with lecture method among selected students. Here N1 plus N2 is equal to 60. In experimental group 1, the mean is 10.23 and experimental group 2, the mean is 10.03. The mean difference is 0.2 between both of the group and the t-value is 0.22 in pre-test, but in post-test the mean score in experimental group 1 is 23.33 and for the experimental group 2 the mean is 20.73. The mean difference is 2.5 and the t-value is 2.429 which is again greater than the table value that is 2. This means the research hypothesis 3 is selected and null hypothesis 3 is rejected. This is a bar diagram showing the mean post-test knowledge score in experimental group 1 with gamification technique and experimental group 2 with lecture method. Here the mean in gamification technique is 23.23 which is higher than the mean of lecture method that is 20.73. I can conclude my study that the finding of the study proved that the gamification technique was effective as compared to the lecture method in terms of gain in knowledge score related to antepartum hemorrhage among the students of selected nursing schools of Delhi. Thank you so much for your kind cooperation.
Thank you so much. Do we have Dr. Chair? Do you have any questions?
Yeah, I appreciate Ms. Anuradha for your presentation. I have one question. How could you reduce the bias or control the bias when you are selecting the sample from the same class students?
Actually, the randomization have been used that is randomization have been used only from the sample of the total 50 students, only the 30 students were selected using the probability technique.
Yeah, you are right. But how did you reduce the bias? Because if you are going to use this technique for the 30 students, remaining 20 students, they can dilute the result, right?
Yes, ma'am.
Yeah.
But ma'am, only the 30 students were taken in for the only the 30 out of 50, only the 30 students were selected, and the intervention was given to that only.
Okay. Thank you.
Thank you, ma'am.
All right, thank you so much for that presentation. And I would like to invite our next presentation, Dr. Mira DK, Government College of Women, Trivandrum. The topic is about the study of reproductive health profile and pregnancy outcome of nurses working in South India. I am trying to see your screen. It's still not up. Hello? I cannot hear you.
Hello? Hello?
Yes, can you please make your voice louder? I can see your screen.
Hello?
Please.
Am I audible?
Yes, you are. Have it on presentation mode. You have 8 minutes.
Okay. Is my slides are visible now?
Yes,
Hello?
it is. Please proceed.
Okay. So good afternoon, all. Myself, Dr. Meera DK, Assistant Professor working with the University of Kerala from India. So thank you for this opportunity. As you can see on the screen, the title of my presentation is Study on Reproductive Health Profile and Pregnancy Outcome of nurses working in South India. So in this particular study, I mainly focused on the reproductive health problems and also to study the pregnancy outcome of nurses, of those who are working in the South India. So moving to the introduction, as we know, the nursing profession is a highly demanding profession. At the same time, they are working in an environment where they have to face a lot of occupational hazards in their daily life. So sometimes it may cause harmful to the pregnant nurses. So in addition to that, the pregnant-induced changes can themselves cause discomfort. Pregnant nurses experience various difficulties due to the physical and mental changes during pregnancy, and the clinical working environment did not provide them with adequate support. So by the nature of their job makes them more exhausted during their pregnancy time also. So this study was an attempt to obtain an insight into the reproductive health problems prevalent among them, and also to assure the pregnancy outcome of our nurses who are working in hospital. So here are the objectives: to estimate the reproductive health problems prevalent among nurses, to assure the good and poor pregnancy outcome among them. Moving to the methodology, the area selected for the study was a Trivandrum district of Kerala, which is the southern part of India. It was a cross-sectional comparative study. The sample, only female nurses were taken for the study of age group of 25 to 45 years and who are having minimum 5 years of experience, and those who are working in shift work from the day of joining. So that are included in the, that are considered as an inclusion criteria for the study. And it was a purposely sampling technique. total 500 number of nurses were taken for the study, that is 250 each from government and private hospitals in the rural and urban areas of the Trivandrum district. The tools used were pre-tested schedule. It is used to collect the information regarding the menstrual and reproductive history. Interview method was adopted here. The statistical test implemented were chi-square and the percentage analysis. So here is the sample design of the study. So total number of samples were taken from the hospitals in the Trivandrum, that is from government hospitals and the private hospitals. In the case of government hospital, first we approached the district medical officer. After obtaining the permission from there, they gave a list of hospitals and we approached those hospitals who show willingness to participate. General hospital, taluk hospitals, specialty hospitals were included here. In the case of private hospital, first we drawn out the list of private hospitals and we approached those hospitals with a minimum 100 number of beds. So with the help of, after obtaining the permission from the concerned authority, with the help of ward in charge and nursing superintendent, we made a list of nurses who met our inclusion criteria. So 250 in the case of government hospital, total 250 nurses were taken, that is 125 from rural and urban areas of Trivandrum. For conducting the in-depth study, again 25 each from the rural and urban areas of government hospitals were taken. The same sampling pattern was followed in the case in the private hospitals too. Moving to the result and discussion part. Here are the details of demographic profile of the nurses. So the first graph shows the age details where 1/3 population of nurses from the government sector were belong to 40 to 45 years. In the case of private sector, the half population of nurses were belong to 30 to 35 years. The B graph shows the marital status. 3/4 population of nurses from the both sector were found married. The C graph shows the years of experience. 1/3 population of nurses from the government sector were having a minimum 5 years of experience. In the case of private sector, majority of them belong to 5 to 10 years. And the D graph shows the salary details. 1/3 population of nurses from the government sector were belong to the age salary range between 30,001 to 40,000. In the case of private hospitals, between 20,000 to 30,000. Now the details regarding the reproductive health problems. So here the reproductive health problems were categorized into 5 like infertility, hysterectomy, cancer that include both breast and uterus cancer, menstrual problems that include the irregular periods, early menopause and bleeding problem, and other gynec problems which include fibroids, ovarian cyst and PCOD. So here nearly major part of the participants from the both sector were suffer from the other gynec problem that follows menstrual problems, and the menstrual problem follows the infertility. Now the pregnancy outcome of nurses in the government sector were studied. So it is to check the reproductive health of the nurses with a special reference with the pregnancy outcome. So here the pregnancy outcome has categorized into 2 like a poor and good outcome. The poor outcome included abortion or miscarriages, ectopic pregnancy, C-section, and medical termination of the pregnancy. A normal delivery come under the good outcome. So here the spontaneous abortion and the C-section numbers were more than that of the national average. The same thing is also observed in the private hospitals too. So in both cases, low birth weight babies birth is also reported. We have checked the association between the shift work and the reproductive outcomes, but we couldn't find any positive association in both government and the private hospitals. So I'd like to conclude, the study has identified that the nurses who were working during their pregnancy were exposed to various occupational hazards, and their long working hours too contributed a risk factor, adversely affecting the health of the baby as well as the mother. So the recommendation for the study is there is an urgent need by hospital managements and policymakers to ensure the safety of pregnant women, basic right to avoid undertaking risky tasks, and it is high time that they should be implementing practical maternity protection policies and working guidelines that can safeguard pregnant women. Not only would this protect pregnant nurses and their fetus, but in the long term, these steps are necessary to improve the provision of quality nursing care and to ensure the patient safety. Thank you.
Thank you so much for that presentation. Dr. Chair, do you have any questions?
Yes, Dr. Meera, really it's a very good study, and I wish you to expand the study, and you would like to you have to analyze more about the reproductive issues for the nurses while working. That's it. Thank you.
Thank you, ma'am.
All good, Dr. Chair?
Yes, I finished already.
I'm sorry, should I proceed?
Yeah, you can continue.
Yeah, I would like to invite our next presenter, Lily Mary of Lazarus University of Malaya. The topic is the effect of self-perineal care education via mobile application on knowledge and practice of postpartum women. Yep, I can see your screen, but I cannot hear you.
Madam, previous slide.
Oh. So sorry, so Recamol is available?
Yeah. I can't share my slide because previous slide is still there.
Oh, hold on. Continue, please. All right, have it on presentation mode. You have 8 minutes.
Thank you, madam. Good day for everyone. My research topic is the effect of self-perineal care education, self-PCE via mobile application on knowledge and practice among primipara mothers. Introduction. Proper care of the perineum after childbirth is very important to avoid infection and to speed the healing of the rectal and pelvic muscle. Salga Onka 2020. Using a mobile application to educate mothers on self-perineal care education, self-PCE is a good alternative, especially during the COVID-19 pandemic. Problem statement. According to Jones et al. 2019, the incidence of perineal trauma wound infection ranged from 0.1% to 23.6%, and wound dehiscence from 0.21% to 24%. Lochia, defecation, and micturition can be a source of infection to the episiotomy wound. According to Gadet et al. 2018, mother cared by the closest living relative based on the experience and culture-related taboos. Sometimes it can lead to malpractice. Objective of this study, to assess the effect of self-PCE on mean knowledge score and self-perineal care practice among primipara mothers in the intervention and control group. Number 2, to determine the association between the change of knowledge and practice of self-perineal care among primipara mothers. Literature review. Joseph et al. 2020, Rahayu et al. 2017 reported knowledge of self-perineal care moderate in many studies done in various parts of the world. Pravin et al. 2018 stated that lack of knowledge on self-perineal care leads to complications like puerperal pyrexia, perineal infection, and other infection that affects the genitalia tract. Methodology of this study. This is a quasi-experimental study done at 2 selected tertiary care hospitals at Klang Valley, Malaysia. Duration of the study, September 2019 to May 2020. Sample size, 130 participants using G-Power 3.1 software. Universal sampling was used to include recruit participants into the groups. Ethics obtained from the Medical Research and Ethics Committee, Ministry of Health, Malaysia. Inclusion criteria, primigravida mother, age 18 to 45 years old, early 3rd trimester. Mother without smartphone and newborn hospitalization were excluded from this study. Instrument divided into 3 sections, Section A, Section B, and Section C. Section A includes demographic data. Section B, 16 multiple choice questionnaire with a single correct answer, adapted from Gadet et al. 2018. 1 mark given to the correct answer and 0 for the incorrect answer. The total score ranged from 0 to 16. Section C include a 10-item checklist on perineal care practice, adapted from Gadia et al. 2014. One mark is given to the correct answer, correct steps, and 0 for the steps that were not done. Total score range from 0 to 10. The instrument clarity, content validity, and comprehensiveness of the questionnaire checklist were examined by a panel of 6 obstetric experts. The instrument reliability was assessed in a pilot study with 30 primary gravida mothers. A Cronbach alpha value 0.80 indicated good reliability. Okay, flowchart of the participant enrollment. Total eligible participant is 130, divided into 2 groups, intervention group and control group, with 65 participants in each group. After obtaining the informed consent, pre-test was done to all the mothers in both groups. The control group received routine antenatal care, while the intervention group had access to self-PCE using the mobile application beside routine care. The mother in both groups were followed up until delivery date. After 6 hours of post-childbirth, mother in both groups were given a post-test using the same question. Later, self-PCE was reinforced using mobile application with a hands-on practical session. On day 1, 3, 5, and 7 post-childbirth, the mother in both groups were asked to complete the self-perineal care checklist using the mobile application. The content of self-perineal care education, self-PCE, 10 steps of self-perineal care, benefit of self-perineal care, cis bath, Kegel exercise, balanced diet, sign and symptom of infection, when and how to seek medical attention, checklist on self-perineal care were given to the participant. Characteristic of the participant, total 125, 62 in the intervention group and 63 in the control group. Majority participants who participated in this study are from the Malay ethnicity, and majority of them had secondary school education. The median age for the participant in the intervention groups was 25, minimum 20 and maximum 35 years old. For the control group, the median age was 26, minimum 18 years old and maximum is 42. There are no significant differences in the demographic variable between the intervention and control group as p-value more than 0.05. Pearson chi-square and Mann-Whitney U-test was used for this. Thus, they were homogeneous between intervention and control group. Mean knowledge score in the intervention group and control group. The pair sample t-test showed a significant knowledge improvement in the intervention group with p-value 0.01. But not in the control group where the p-value is 0.430. The significant mean differences in total mean score was 3.11 with standard deviation 2.52. Okay, this is the distribution of correct answers for pre-test and post-test knowledge score. The changes in the response in each of the question measuring knowledge were tested using McNamara tests. They were significant. These are the 16 items in the questionnaire that used for the participant. There was significant improvement in the 13 out of the 16 questions in the intervention group. In comparison, there was significant improvement in only 4 out of 16 items in the control group. All the improvement in the intervention group were the major primary component of self-perineal care education given to the participant. Okay. The effect of self-PC on practice in intervention and control group. The differences in the level of practice were tested using the Mann-Whitney U-test. For all time points, the level of practice was higher in the intervention group with p-value less than 0.01 for day 1, 3, 5, and 7. To assess the association between change in the knowledge and practice of self-perineal care, there was significant association with p-value less than 0.001 between change in knowledge and practice in all 4 days using Spearman correlation tests. Discussion. In this study, perineal care knowledge increases the practice of self-perineal care among primary para mothers in the intervention group. There was significant association between the change in knowledge and practice over the 4 time point post-childbirth, hence self-PC was effective. This study is in line with many previous studies that perineal care teaching improve knowledge which lead to good practice. Ari et al. 2019, Black et al. 2016, and Praveen et al. 2018. However, as best to my knowledge, this is the only study that uses mobile application in the perennial care teaching. Strength of this study: mobile application enhance faster access to healthcare providers, self-empowerment to primary paramothers to take charge of own health.
8 minutes already, please wrap it up.
Remote monitoring possible. Limitation of this study: mother's ability to use the mobile application and internet access. Recommendation: plan in-service training program for midwife. Mother must be informed and guided during antenatal care regarding episiotomy procedure and perineal care. Using mobile application to educate is good option and empower primary gravida mothers to take charge of own health. Conclusion: the self-PCE program via mobile application among primary paramothers effectively improve their knowledge, contributing to good perineal care practice and enhancing individual healthy behavior during postpartum. These are my references. Thank you for listening.
Thank you so much. Madam Chair, do you have any questions?
Yes, thank you for your good presentation, Ms. Limeri. I will ask, I have only one question. How can we make this utilization of this mobile application for even the non-educated, non-literate people?
Okay. For this study, actually, we have inclusion criteria for the mother with the smartphone. Okay, those with the smartphone, normally they know how to use. But however, when I approached the mothers, 2 sessions to enter the mobile application to the mothers were done. And in case I don't get any feedback from them, I will call them for the feedback.
Okay, thank you.
Ma'am, I want to present, ma'am.
Yes, yes, madam.
Right, thank you so much. And now let's proceed. I would like to invite our next presenter, Mrs. Apurana Moharana. The topic is about
Ma'am, e-literacy have a time at 3:45, ma'am, but I did not present.
Your name, please.
E-literacy. E-literacy. Hello. Hello. Hello.
Yes, madam.
I have a time at 3:45, ma'am, but I did not call up.
Oh, yeah, and now I understand. I'm so sorry, but there are still 2 people before your presentation. We are out of time. We are out of time, actually. I apologize. Right, I would like to call on again our next presenter. Mrs. Aparna Moharana. Again, the topic is a study to assess the knowledge on MCH schemes among mother attending OPD of obstetrics.
Thank you, ma'am. Good afternoon to all. Is it audible?
Yes.
But the previous presenter has already...
Yes, hold on. You may share your screen, madam.
Okay, ma'am. Okay. So is it visible, I hope?
Yep, have it in presentation mode, and you have 8 minutes.
Okay, ma'am. Thank you. So I am Mrs. Aparna Maharana, and my co-worker, my co-PI is Mrs. Rasmaranjita Padi. We both are faculty at Kalinga Institute of Nursing Sciences, KIIT DMW University, Odisha, India. The study title is Study to Assess the Knowledge on MCH Schemes among Mothers Attending the OPD of Obstetrics and Gynecology Department of KIMS PBMH Odisha, with a view to develop an information booklet. The study objectives are: first one is to assess the knowledge of selected MCH schemes, that is the maternal and child health schemes, among the mothers, to find out the association between the knowledge on MCH schemes with selected demographic variables And the third objective is to develop an information booklet. So maternal and infant mortality are indicators of health in a country. The well-being of the society is directly connected to the health and survival of the mothers as well as children. Globally, India is one of the developing countries which is having the high maternal and child mortality and morbidity. This mortality can be reduced by simple interventions at primary level of healthcare, and in order to that, the government of India has started the interventions by introducing different maternal and child health programs. These are only the MC schemes in the grassroots level. The methodology is, the research approach is quantitative, design is descriptive survey design, research setting is obstetrics and gynecology OPD of KIMS PBMH Bhubaneswar. The population is the mothers attending the OPD of 1G department of KIMS PBMH Bhubaneswar, Odisha. Sample and sample size, the total number of the study sample was 120 mothers who are 18 to 40 years who are attending the OPD of obstetrics and gynecology department of KIMS PBMH Bhubaneswar. The sampling technique was non-probability convenient sampling technique, and the duration of study was 3 months. The sampling criteria, the inclusion criteria included that the mothers within the age group of 18 to 40 years and the mothers who can only understand Odia language. Exclusion criteria was the mothers who are not willing to participate in the study. The data collection method, the tool was used with the following sessions. One is your section A, that includes the self-structured questionnaire related to demographic variables such as age, parity, mother's education, occupation, and the source of information. Section B included the self-structured questionnaire to assess the knowledge regarding utilization of selected maternal and child health services or schemes. For knowledge assessment, there is a scoring criteria. If the mother is scoring 0 to 11, it will be scored under below average. If they are scoring 12 to 25, that's average, and 26 to 37, that's excellent. Actually, it's a 37 as because the questionnaire included only 37 questions. So prior to data collection, researchers obtained formal permission from the Departmental Research Committee and Institutional Ethics Committee of KIIT Day2 University, Bhubaneswar. Researchers introduced themselves to the samples and established good rapport with them and explained about the purpose of the study and its usefulness. They were assured about confidentiality of the responses, and keeping in mind the ethical aspects of the research, the data was collected after obtaining informed consent of the sample. So data analysis and result, it was presented over the following sections, including the first section, that's the frequency and percentage distribution of samples based on demographic variables. Section 2 includes the distribution of samples based on knowledge, and section 3 depicted the association of level of knowledge with selected demographic variables. Section 1, the first figure shows the cylindrical diagram which shows the percentage distribution of sample based on their age, and it shows that most of the sample out of 120, they were in the age group of 24 to 29 years, and the percentage of sample were 40%. So next figure is the 3D bar diagram which shows the percentage distribution of the sample in terms of their parity, and it shows that maximum of them are primipara and it scores 46.6%. So next figure, the pie diagram which shows the percentage distribution of educational qualification of the samples, and it shows that most of them are under the higher secondary group and it scored 46.6%. The next figure is the bar diagram which shows the percentage distribution of the sample in terms of their occupation, and it shows that 60% of all the sample, they are homemakers, and the remaining 40% were the working mothers. Next, the pie diagram shows the percentage distribution of study sample in terms of sources of information, and it shows that maximum of them, that is 60% of sample, they have got the information from digital media, and whereas remaining 50% they got the information from print media, then 13% from other beneficiaries of this MC schemes, and remaining 12 from ASHA. So in section 2, the table depicts the percentage distribution of level of knowledge on MC schemes, and it shows that out of 120 sample, only 67 of them had average knowledge, that's a 55.8%. 27 of them had good knowledge, and remaining 26 of 120 sample, they had below average knowledge. The section 3 is showing the association of knowledge level with selected demographic variables, and out of all the demographic variables, only the age of the mothers and the sources of information was statistically significant, as the chi-square value was 20.93 and the p-value for age was 0.001, and for the sources of information, chi-value was 18.44 and p-value was 0.005. The remaining demographic variables were not statistically significant. The discussion, the study depicted that only 22.6% of all samples had excellent knowledge on different MSID schemes, whereas the remaining 55.8% had average knowledge and 21.6% had below average knowledge on different MSID schemes. So the conclusion is that based on the study findings, it's ensured that though a significant number of MSID schemes are introduced and implemented by the government of India, still the beneficiaries are not adequately aware about the same. And to overcome that, we had our information booklet and we have distributed to the mothers after their knowledge scoring. So this all are the references. Thank you.
Thank you so much for that presentation. Dr. Cherry, do you have any questions?
Yes, thank you, Mrs. Saparna, for your well presentation. Here, I would like to ask, some of the samples in your study were until the primary education. So, how you will make the
Yes, ma'am. Actually, we did this self-structured questionnaire for the knowledge because here the local language is Odia, and we are having the questionnaire in Odia language.
Okay. Okay, thank you.
Thank you, ma'am. Thank you. Thank you all for patience listening.
Okay, Dr. Joe, you can continue. Dr. Joe?
Yep, thank you so much. And now I would like to invite the next presenter, Mrs. Prativa Ray. The topic is about an observational study on self-efficiency, health literacy, and knowledge level of admitted cervical cancer patients.
Good afternoon, ma'am.
Hi, good afternoon. Please
Am I
share
audible?
your... Yes, you
my slide
are.
is visible.
Not yet.
Now it's visible, ma'am.
Not yet. It's not sharing. Can you please double check?
Now it's visible.
Nope, it's not.
It's visible, ma'am.
No, it's not. Do you need more time?
1 minute, ma'am. 1 minute, ma'am.
You just click the button share screen.
Okay, ma'am. Okay.
Yes, and after clicking on share screen, make sure to click on the window that you want to share before there it's coming up. Have it on presentation mode and you have 8 minutes. Proceed.
Okay, ma'am. Thank you, ma'am. Good evening, ma'am. I'm Pratibha Rai, tutor, Kalinga Institute of Nursing Sciences, Department of Community Health Nursing, KIIT, deemed to be University. My co-author are Mrs. Soumya Sonalika, Assistant Professor, and Mrs. Truptirekha Swami, Assistant Professor, Kalinga Institute of Nursing Sciences, KIIT, deemed to be University. My project title was as an observational study, self-efficacy, health literacy, and knowledge level of admitted cervical cancer patients, Bhubaneswar, Odisha. So the objective of the study to assess self-efficacy level, health literacy level, and the knowledge among cervical cancer patients on cervical cancer. Second one, to determine the relationship between general self-efficacy level and knowledge regarding cervical cancer among the cervical cancer patient. Third one, to find out the association between self-efficacy level with selected demographic variable, and to determine the association between health literacy level with selected socio-demographic variables. So hypothesis of my study, there was a significant relationship between general self-efficacy level and the knowledge among cervical cancer patients on cervical cancer. H2, there was a significant association between health literacy level with their selected demographic variables. So in methodology, research designed a hospital-based observational study. Then research approach, that is quantitative approach. Setting, in the selected setting for the study was Hemalata Cancer Hospital and Sports Cancer Hospital and Broaden Memorial KIMS Bhubaneswar. This setting was selected on the basis of convenience, feasibility, and practicability for the conducting the study. The sample size is 100. The sampling technique is convenient non-probability sampling technique. And the tool for the study, there is 4 sections. Section A, that is socio-demographic data. Section B, self-structured questionnaire. Section C, modified RALM scale. Section D, modified general self-efficacy scale. And the data were analyzed by descriptive and inferential statistics. Selection criteria, inclusion criteria, that is cervical cancer patients within the age group of 15 to 65 years, those were able to read, write, and understand the Odia or English language, and the patients who were willing to participate in this study were excluded the cancer patient attending OPD. We are used the tools in this study. First tool one.
Sorry for the interruption. Can you?
Yeah, your slide is not moving.
Yeah, the slide is not moving.
Ma'am, now it is moved.
No, it's not. When you click on share screen, please make sure to choose the entire screen window. You will see there. Oh, there you go. I think you need to manually move it. Proceed, please.
Ma'am, now it's visible?
Yes, it is visible, but it's not moving.
What happened?
Hello?
Yes, ma'am.
Go ahead, please.
Okay, ma'am. Second tool consists modified RLN scale for assess the health literacy level with cervical cancer patients.
Madam, can you please maximize the window? Make it big.
It's visible now, ma'am.
It is visible, but you minimized it.
I already maximized, ma'am.
All right, go ahead. Please proceed.
Okay, ma'am. Okay. Tool 3 consists modified general self-efficacy scale to assess the health efficacy level among cervical cancer patients. So data collection procedure, prior permission was taken from the research committee, IEC committee, and the authorities of the 3 cancer hospital, and the informed consent was obtained from the participant. The participant was given self-structured questionnaire on socio-demographic data, the health literacy level, and the self-efficacy level. Analysis and interpretation of the data. Section 1, that is frequency and percentage distribution of the demographic variable. In the column diagram, that's showing majority 57% of the participant. One minute, ma'am. Screen the visible hold, madam. Majority 57% cervical cancer patients were Hindu, and according to the marital status, maximum 51% cervical cancer patients were married, and the minority, that is 17% cervical cancer patients were unmarried. According to the educational status, majority 45% cervical cancer patients were primary level of education, and according to the her resident, majority 53% cervical cancer patients were belong to the urban area, and the minority 47% cervical cancer patients belong to the rural area. In the column diagram, majority of the cervical cancer patients, that is 57%, were belong to the nuclear family, and according to the occupational status or occupational data, majority 39% housewife or housemaker were suffered with cervical cancer. According to the number of children, maximum 42% cervical cancer patients were those have one child, and the source of information, that is majority 47% cervical cancer patients were getting information through the TV and the radio. Through the cylindrical diagram, it's showing the majority 38% cervical cancer patients were getting married, got married during the age between 15 to 20 years of age, and in the cylindrical diagram, majority the family history, a cervical cancer patient, maximum 40% of the mother had cervical cancer patient. The family history plays a major role in the cervical cancer. Maximum cervical cancer patient belong to the stage 2 cancer. Section 2, that is relationship between general self-efficacy scale and the level of knowledge. Here, general self-efficacy scale we categorize like poor self-efficacy level, average self-efficacy level, and the good self-efficacy level. And the knowledge were categorized like inadequate knowledge, moderate adequate knowledge, and adequate knowledge. Here, in the relationship between, there is R value 0.64, which indicate there is a significant relationship between self-efficacy and the knowledge level of cervical cancer patient. Section 3, association between self-efficacy and selected socio-demographic variables. Here, the hypothesis is tested at 0.05 level of significance. Here, the result revealed that there is a significant association between residents with their self-efficacy score at 5% level of significance with obtained chi-square value, that is 9.839. Here, there is no significant association with the other socio-demographic variable like age, education, source of information, stage of cancer. In section 4, here association between socio-demographic variable and the health literacy level score of the cervical cancer patient regarding cervical cancer, there is no significant association between health literacy with age, religion, education, residence, occupation, and the source of information.
8 minutes. Please wrap it up.
The result of the study, in this study, 35% of the cervical cancer patients belong to 31 to 46 years, and 37% were suffering stage 2 conditions. 37 number of patients were found to be self-efficient, and 42.42% had health literacy level of, that is the grade is 4 to 7, and 45% participant had moderate adequate knowledge, and R value is 0.64, that indicate a significant relationship between self-efficacy level and the knowledge on cervical cancer. The chi-square test to find out association of self-efficacy with selected demographic variable, that is p value 0.043, and the RELA median score was 42 of the participant. Conclusion in my study, knowledge on health education toward patient self-care will assist with the implementation of effective treatment and improve the health literacy. And recommendation of my study, a similar study can be repeated by taking large sample to generalize the findings. A comparative study may be conducted in rural and urban area. A similar study can be undertaken by utilizing other domain like prevalence of cervical cancer. Thank you, ma'am.
Thank you so much for that presentation. And Dr. Chair, do you have any questions?
No, I don't have any question.
Right, and now let's proceed with our next presenter.
Thank you, ma'am. Thank you, ma'am.
Miss Isela Rasi?
Yes, ma'am.
Yes, it's your turn. The topic is about
you cannot share the screen, it's coming.
I'm sorry?
Yes, yes, ma'am. I'm sharing. You are visible, ma'am. You are getting it? My screen.
Yes, it is. Have it on presentation mode and you have 8 minutes.
Yes, yes. Thank you for me given opportunity to present in this platform. I am Edila Rassi, Associate Professor, PhD College, and working at Subdegree College of Nursing, Bangalore. And my study is a study to assess the
have it on presentation mode, please.
nurses regarding safety measures adopted by nurses while administering drugs in elderly in a selected community area at Bangalore. Are you getting my screen and voice, ma'am?
Yes, we do, but it's not on presentation mode or slideshow.
Oh, you wanted present.
Go ahead, please.
Introduction: ensuring safe and effective administration of medication to elderly is an important component of nursing care. This document provides guidelines for nurses to administer medication safely and effectively in most practice settings. And objectives of the study: to assess the existing knowledge on safe drug administration to elderly, to assess the existing knowledge regarding dose calculation of drugs in elderly, to assess the existing knowledge regarding and overuse and misuse of drugs in elderly. Need for the study: part of the challenge in understanding the impact of nursing in medication administration is the need for the research that clearly differentiate this administration of medication in elderly. The physiological changes in elderly person may influence to develop more complication while using drugs. So nurses need to get adequate knowledge while administering the drugs to elderly. Methodology here and research approaches: descriptive research and research design, descriptive explorative design, setting ESIC hospital staff quarters and population, nurses working in the ESIC hospital who are fulfilled the inclusion criteria, technique, non-probability convenient sampling technique, and sample sizes 30 staff nurses, and collection of data, assess the knowledge of nurses, knowledges of nurses through structured knowledge questionnaire based on pharmacokinetics, pharmacodynamics, dose calculation, and overuse and misuse of drugs by self-reporting. Here with the findings of the study, comparing my demographic data of this, female nurses are having adequate knowledge of 56.6% of them living at, male nurses were 43.3%, and the experience in geriatric, there were 90% of them not having, only 10% of people are having a more experience, and the elderly adult in families, those who are living in their unit, the 20% of them like comparing older adult in families, 80% of living in that fortress. And here level of knowledge according to knowledge frequency percentage, and more adequate level is 40% of them having adequate knowledge and 60% of them having moderate level, and no one is having adequate knowledge levels. Conclusion of my study: the study provides evidence of health promotion and nurses should improve their knowledge level on safety measures while administering the drug. We hope that this study will be useful in practice setting to improve the knowledge on safe drug administration to elderly and to look forward to our participation in the healthcare setting. My recommendation and take-away messages: the study findings highlighted the fact that nurses look knowledge in this area under the study, and thus the need for an information booklet was justified. This study highlighted the need for intense training for the nurses to improve the quality of care and decrease the cost of care and to promote the good health. Thus, there is need to do the further studies on the safe administration of drug in elderly. Thank you. Thank you.
Thank you so much. Dr. Chair, do you have any questions?
Mrs. Elirasi, you have presented well, but we didn't see any of your slides. So I'm sorry to say that.
Yes, ma'am. Okay. Ma'am, any doubt?
No, I don't have any doubt because I didn't see the slides well. And I will tell you one more thing. Nowadays, to prevent the medication error, we have automated medication machines. Everything is available. So you have to update with the technology also. Okay, thank you so much. Thank you.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
All right, thank you so much. I would like to invite our next presenter, Professor Sioli Sen Sumandeep, Nursing College, India. The topic is effectiveness of magnesium sulfate fomentation versus potato juice application on phlebitis among sick children between 1 to 3 years old receiving parental medicine in the pediatric ward of selected hospitals of West Bengal, India. Shioli Sen, Professor Shioli Sen. I can see you, but you're on mute. Can you unmute yourself? Shioli Sen? There you go. Yes, I can see your screen, but I cannot hear you. Hello?
Am I audible, ma'am?
Yes, you are. Thank you so much. And please have your presentation on slideshow, and you have 8 minutes. Proceed.
Okay. Thank you, ma'am, for giving me the opportunity to present in this platform. Myself, Professor Shioli Sen, belongs to the pediatric department, going to do my research paper presentation. Before I come to the topic, let me introduce first regarding the intravenous infusion. It means introduction of large amount of fluid into the body via veins. Now, over 80% of all children entering hospital to receive IV therapy, but these can lead to life-threatening conditions like thrombosis, embolism, and infection. And at the same time, the incidence of peripheral vein extravasation has been reported to range from 0.1% to 6.5%. Routine IV site observation by the phlebitis severity measurement scale could reduce the incidence and severity of phlebitis. And phlebitis is the inflammation of the innermost wall of the veins. It affects 27% to 70% of all patients receiving IV therapy. So keeping this in view, the research problem statement is a quasi-experimental study on effectiveness of magnesium sulfate fermentation versus potato juice application on phlebitis among the children between 1 to 3 years receiving parental medicine in the pediatric ward of selected hospitals of Kolkata, West Bengal. The purpose of the study is to explore the occurrence of phlebitis with selected variable as well as management of phlebitis by potato juice application and magnesium sulfate fermentation as a comparativeness for knowing the effectiveness between them. Objectives of the study: to determine the severity of phlebitis among the sick children measured by phlebitis measurement chart. Second one, to determine the effect of magnesium sulfate fermentation on the phlebitis. Third, to assess the effectiveness of potato juice on phlebitis. Fourth, to assess the effectiveness between magnesium sulfate fermentation and potato juice application on phlebitis in sick children. The variables of the study are: independent variable is magnesium sulfate fermentation and potato juice application. Dependent variable was phlebitis in terms of pain, edema, erythema, palpable venous cord, and streak formation. And extraneous variables were age of the child, type of IV fluid infusion, duration of IV cannulation, and type of IV medication. The hypotheses were tested at 0.05 level of significance. The first hypothesis is there will be a significant difference in the reduction of mean phlebitis assessment score in experimental group 1 after the application of magnesium sulfate fermentation at 0.05 level of significance. Hypothesis 2, there will be a significant difference in the reduction of mean phlebitis assessment score in experimental group 2 after the application of potato juice application at 0.05 level of significance. Hypothesis 3, the amount of reduction is significantly higher among children receiving potato juice than receiving magnesium sulfate. The conceptual framework was developed, was based on Ludkin von Bartonleffe input-output process model. And this model is stating that in the input, we have done demographic variable, the children with 1 to 3 years of age in pediatric ward with intravenous cannula, and followed by which magnesium sulfate and potato juice has been applied for experimental group 1 and 2 respectively. In the process, we had assessment of selected variables like date of insertion of IV cannula, type of medicine, date and time of developing phlebitis, and date and time of changing IV cannula. Followed by which assessment before application has been done to check the pain, erythema, edema, palpable venous cord, presence or absence of streak formation, assessed by phlebitis grading scale and by phlebitis measurement scale chart. Now followed by which in experimental group 1 application of magnesium sulfate fermentation is given. In experimental group 2 application of potato juice has been given, and through which the output we are going to do the in experimental group 1 assessment of phlebitis, followed by which we are going to check these all symptoms or the clinical features of phlebitis like pain, erythema, edema, palpable venous cord, presence or absence of streak formation, and followed by which again in experimental group 2 also the same thing, assessment of phlebitis we are going to do after doing this potato juice application. Now from this we are going to check whether in experimental group reduction of phlebitis has taken place, yes, or there is no change. Same way in case of experimental group 2 also reduction of phlebitis has taken place or no change. Now, the delimitations of the study were children in the age group of 1 to 3 years having phlebitis, those who are getting IV medication, those who are conscious, those who have phlebitis, and patients willing to participate in the study. The research methodology were research approach, quasi-experimental, research design was time series design, setting of the study, pediatric ward of National Medical College Hospital, Kolkata, population of the study were children from 1 to 3 years of age, sampling technique was purposive sampling technique, and sample were 1 to 3 years children with phlebitis in the pediatric ward, and sample size was 50. The symbolic representation of the research study was, as it is a time series study, so in experimental group 1, we have 0, O and X. So O stands for observations of phlebitis at 0 hour, 12 hour, 24 hour, 36 hour, 48 hours, 60 hours, and 72 hours respectively, whereas X1 is the treatment with magnesium sulfate fermentation at 0 hours, 12 hour, 24 hours, 36 hours, 48 hours, and 60 hours respectively. Same way in experimental group 2 also, X2, in the same duration, we are going to do the treatment with potato juice. So this is the 0 to 60 hours at 12 hours interval. The same schematic diagram has been represented here again. And the research tool were tool number 1, A and B. A was structured interview schedule for obtaining demographic data. B was interview schedule on selected variables. Type of tool validation was done was content validity. Tool 2 was phlebitis grading scale. Content validity was done, and the reliability was 0.95. Tool 3 was phlebitis measurement chart. Content validity was 0.2. Tool levels the Institution Nurses Society standard practice, and the key has here as grade 0 no symptoms, grade 1 pain, grade and or pain at access site or edema formation, injury and discharge, drainage. Whereas measurement scale, it was adopted from the standard scale based on Institution Nurses Society's home Baker facial expression.
Hello? Are you still there? Did we lose her? Professor Shen?
Dr. I think you can continue the next presentation.
All right. Hold on. Let me stop. All right. All right. And next, I would like to invite our next presenter. It's a video presentation by Kavita Makad about opportunities and challenges in medical tourism. It's a perspective of value chain in India.
Warm greetings to one and all present here at the conference. This is Dr. Kavita, Dean School of Business, Calgutias University, India, presenting on the topic Opportunities and Challenges in Medical Tourism, a Perspective of Value Chain in India. An increasing pace of globalization has led to very effective and efficient markets, wherein people are focusing on their needs and wants, and healthcare industry is one of those, wherein due to the high degree of price discrimination and rising health costs, the medical tourism has popped up, wherein which is nothing but it's a situation wherein people may have to seek treatment options in other countries, reasons varying from accessibility to cost effectiveness to quality of services. Looking at the global view right from, this particular chart depicts a situation right from 2014 to a projection 2025. All these countries depicted here, Costa Rica, Mexico, India, Thailand, Malaysia, and Singapore, show a substantial increase in the years. Now, looking at the global market, there are, of course, a good number of countries who are good at particular procedures and a particular expertise. But however, the overall ranking on the medical tourism index shows that Canada is ranks from #1, Singapore, second is Singapore, Japan, Spain, United Kingdom, Dubai, Costa Rica, Israel, Abu Dhabi, and India. So India ranks among the top 10. Most of the drivers of this medical travel, why these destinations have become is majorly because of a combination of these factors, or any one of these factors, like affordability, availability, quality healthcare, no long waiting queues or no long waiting periods, and privacy, and of course the efficiency that they promise. Right. So India as a destination of medical tourism, it's become very popular, majorly because of, definitely, of course, because of the expertise, the procedures that it is good at, like, say, for example, most of these very complex surgeries like multi-organ transplant, hip transplant, cardiac care, cosmetic surgeries, and so on, so forth. Indian doctors are very good at that. And apart from the medical visa policy, which has been designed and executed in India, it allows the patients to stay here for 60 days, and it also allows their family members to get them as medical attendants. The medical costs here are pretty reasonable, and it costs almost a fifth of what it costs in Western countries. Looking at India's ranking, the overall ranking at various dimensions, of course, the global ranking, India ranks among the top 10 countries. And as far as the destination environment is concerned, it ranks 21. Medical tourism industry of India ranks the 6th, it stands 6th. Quality of facilities and services, India ranks 6th in that. So when it comes to the composition of the healthcare sector, most of it is almost 71% is dependent on the business of hospitals, and then 13% of it from the pharmacy, and following are the equipment, medical insurance, and the diagnostic part of it. The reasons for why medical tourism in India has become very popular is, one is, the major point is, of course, the expertise. Apart from that, high savings, no waiting list, high quality treatment, world-class facilities which are available at various hospitals at India, access to the latest technology, best of the best surgeons available here, the customer care, and the travel opportunities that most of these patients have. A comparative advantage that India has when it compares to the rest of the world is the pricing. And in the pricing, India offers most of these complex surgeries at very reasonable prices. Having said this, of course, not compromising on the quality, giving the best of the best services and facilities to the patients. This is only possible because of these number of hospitals that India has spread across, the north and east and western and southern region of India, which are located mainly in metros and of course in few of the other cities also. So India has around 12 JCI approved and 20 more hospitals which are NABH approved, accredited, which by itself guarantees the quality of the services provided there. The foreign tourist arrival for the medical purpose as such, the top 10 countries from where the patients fly to India to get the treatment is Bangladesh, Iraq, Maldives, Afghanistan, Oman, Yemen, Sudan, Kenya, Nigeria, and Tanzania. Apart from this, India does get patients from the Western countries as well and the most advanced countries as well, mainly for the cosmetic surgeries and so and so. But looking at this particular data here, which ranges from 2017, 18, 19, and 2020, we see that Bangladesh is getting the major share here. Wherein almost 50 more than 50% of the patients are flying from Bangladesh. Now, this is the data which specifically highlights those patients who are coming based on medical visa. And however, it ignores those patients who come on tourist visa and yet get the medical treatment here in India. A few of the marketing strategies that have worked very well for Indian hospitals to get these international patients or vice versa, send their doctors across to the other countries to provide the services is through, of course, the patient referral, the digital marketing. Doctors themselves are the best way of marketing, and medical camps, surgical camps, insurance companies, advertisement by the host country, newspapers, and information centers abroad, wherein most of these approved hospitals have their marketing wing in various other countries, NGO operating in the host countries. And many of these hospitals rely on the tie-ups with the corporate hospitals abroad, Ministry of Health, in the host country, and major employers and the corporates and trade facilitators. Now, trade facilitators are one who play a major role in kind of taking forward this business activity. However, there are a few of the challenges which the medical tourism faces more so in India is the transport and connectivity, lack of coordination between the ancillary industries like airlines, hospitals, hotels and hospitals, and the public sanitation, the perception, basically it's a perception that, generally the international patients have the mind block that, India is, doesn't really have so much of hygiene standards, right? So, and few of those other challenges are related to the policies, and uniform pricing policy, of course, is one of those challenges. And insurance policies, health infrastructure as such, and health, accessibility basically, between the private and the public systems. Now, the value chain, if we look at, having spoken about the challenges, one of those major challenges that we see in a value chain is the trade facilitators and the policy-related aspects. Now, to understand the value chain, let's start how actually with the flow of the medical tourism. Basically, initially the patients inquire about the treatment. So there is an inquiry which is received, and then there is an interactive session which is arranged with the patient through a Skype or a con call. The patient makes a decision of, depending upon his discussion over the Skype and the con call, the patient decides whether he has to travel for the treatment. Once he decides, yes, he is going to go, then the invitation letter from the hospital is sent to the respective embassy and processing of the visa, and for processing the visa. Now here there are few bottlenecks, which are like, they cause a lot of delay in the paperwork. On the arrival of the patient and the caretaker, consultation is done. During the consultation, the patient is educated well with his possible treatment and procedures that he requires. Then the patient makes a decision. Once he makes the decision, he gets the admissions through a single window admission process in most of these hospitals, and post-investigation evaluation process and expert opinion. There is, a patient would be suggested for an MRI test or any of those scans or tests wherein, or a diagnostic test, wherein the reports are generated, of course, and the patient makes the decision on opting these services. With his approval, these diagnostic tests, and then the procedure happens, and then the patients, after a required time, they are discharged from the hospital. Once they get discharged from the hospital in the post-recovery, the patients are made to stay in the quality hotels, which are basically wherein the hospitals have a tie-up with these hotels. And of course, there would be a follow-up consultation. Once follow-up consultation at the hospital, and the following consultation would be happening majorly through the telephone and email. Now, this is one more bottleneck that is generally seen. So the dilemma that is faced in the flow or the value chain here is making the right choice of the doctor, hospital, or treatment. So here the patients who are located in various countries need to be actually aware of what is available in an Indian market. Trade facilitators may play a major role, however, they need to be guiding the patients as well. Visa and delay in the paperwork, insurance, and follow-up. Now these are the dilemmas. So then what is that which is a need of the hour? The need of the hour here, in order to make this particular sector contribute more and more to the economic growth of the country. Registration of the trade facilitators is a must, so which means that they need to register with the Indian government, and they should be more authentic when they facilitate the patients, when they guide the patients. And apart from that, there need to be a medical conclave which need to be developed for the foreign patients. Development of special wellness tourism zones is something which the Indian government is already focusing on, and shortly we may definitely see a few good ones which would be identified, few good regions which would be identified as the wellness tourism zones. Capacity building, wherein India has to look into more and more number of doctors and supporting staff. An online medical value tourism portal also is something which is highly required for to facilitate the business that happens in the healthcare sector, especially the medical tourism. So this was from my side. Thank you so much for hearing me, and in case of any questions, queries, do please write to me, and this is my email ID and the telephone number. Thank you so much.
Thank you so much for that presentation. I'm not sure if she's here to cater questions. All right, Dr. Chair, we will proceed. All right. Next, I would like to welcome our presenter, Mrs. Madhurina D, Hindu Mission College of Nursing, India. The topic is about a web-based descriptive survey to assess the attitude towards online classes during COVID-19 pandemic lockdown among student nurses in Hindu Mission School and College of Nursing. Madhurima? Hello? Madhurima?
Yeah, can you hear me now, ma'am?
Okay, yes, I can definitely hear you. Go ahead and share your screen.
For a long time, I was trying to unmute myself. Thank you. Thank you. At last, you made me to unmute. Thank you. Let me share my screen.
Yep, go ahead.
Yeah, is my screen visible?
It's coming up.
One
Yeah,
second.
it's there. Please.
Yeah,
Yes, please have it on presentation mode. You have 8 minutes.
Now, can you see it now as a slideshow?
Go ahead.
Yes. So, warm greetings to all the members of the forum and the judges. So, the paper today, which I'm going to present, is a web-based descriptive survey to assess the attitude towards online classes during COVID-19 pandemic lockdown among student nurses in Hindu Mission School and College of Nursing. So we all know that COVID-19 has deeply affected the global livestock, and it has imposed various effects on the learning opportunities of students across the world. And various digital apps has extended their support, which has made the transformation of traditional classroom teaching to the online classes. And it was proved that about 25 to 60% more that the students can learn when they learn through online in comparison of 8 to 18% in the traditional classroom. But at the same time, the learner's attitude and acceptance towards the information technology has to be to assess is very important factor. So globally, the international organizations like UNESCO and United Nations have declared that the COVID-19 pandemic has disturbed almost about 129 to 190 countries, which has directly or indirectly switched the education system to the online. And in India, Ministry of Human Resource Department, that is MHRD, has emphasized on e-learning with the tagline as "Let COVID-19 not stop your learning." In our state, Tamil Nadu, the Tamil Nadu Nurses and Midwives Council had took an effort to promote the online education to the nursing students under the affiliated colleges. So with the base of these things, Hindu Mission College, our institution, was also forced to transform our traditional classroom teaching to an online classes. And as a part of curriculum evaluation, the investigators made the study with the objectives to assess the attitude towards online classes during COVID-19 pandemic lockdown among student nurses, and to associate the level of attitude towards online classes during the COVID-19 pandemic. The null hypothesis framed was there is no significant association between the level of attitude towards online classes among the student nurses with the selected demographic variables. Operational definitions of the study. Assess refers to the activity of finding the attitude of student nurses. Attitude refers to the self-values of thought and beliefs regarding the online classes, which was measured using a 5-point Likert scale developed by the investigators. Online classes in this study refers to the theory and practical classes lectured by the teachers through the Google Meet app for the nursing students. Student nurses in this study refers to the BSc Nursing 2nd, 3rd, and 4th year and DGNM 2nd and 3rd year who have attended the online classes during the COVID-19 lockdown. These were the few studies which I have reviewed, and I have presented very few of those literature here. And the study was approached using a quantitative approach using a web-based descriptive survey design. The research variable is attitude towards the online classes, and the demographic variables includes age, education, father's education, mother's education, monthly income, previous knowledge on computers, place of living, and duration of attending the online classes per day. The study setting was Hindu Mission College of Nursing and Hindu Mission School of Nursing. Target population includes the students studying BSc Nursing and DGNM. And accessible population was students studying in BSc 2nd, 3rd, and 4th year, DGNM 2nd and 3rd year. Sample included in the study was BSc Nursing 2nd, 3rd, 4th of Hindu Mission College of Nursing and DGNM 2nd and 3rd year of Hindu Mission School of Nursing. The study was conducted in the first week of May 2021 with a 100 sample size. The sample were selected using a non-probability convenient sampling. Nursing students who were attending the regular online classes during the pandemic lockdown and nursing students who were willing to participate in the study were included for the study, and nursing students who were not available at the time of data collection has been excluded. The tool consists of two sections. Section A consists of the demographic details of the demographic variables of the participant, which was explained already. And section B consists of a 5-point Likert scale with total of 20 items, out of which 10 items are positive items and 10 negative items. So the total 12 items consisted on the learning outcome, 5 items on the physio-psychosocial aspects of the students, and 3 items on the technology adaptation was developed by the investigators. The scoring interpretation, the statement, each item has to be marked by the student under 5 categories like very strongly agree, agree, disagree, and strongly disagree. The positive statements will be marked as 5, 4, 3, 2, 1 respectively, and negative statements will be marked vice versa. The maximum total score of the tool was 100, and 70 to 100, the score between 70 to 100 is considered as good or highly satisfactory attitude. 35 to 69 is considered as moderate or satisfactory attitude. 0 to 34 is considered as poor or unsatisfactory attitude. The tool was validated by the experts of the research committee of the institution, and pilot study was conducted, and the reliability of the tool was found using a test-retest method, and the R values was found to be 0.75. The study was proposed under the institutional ethics committee and got approval, and before conducting the study, the participants were informed about the study and informed consent was obtained. The method of data collection, the tool was converted into the Google Forms, and the link was sent to the participants through the WhatsApp groups created by the investigators, and participants were asked to fill the form and submit within half an hour of the time. The technical errors were addressed when required. Data analysis, the mean frequency.
Please wrap it up. Time is up.
And percentage were used to describe the study, and chi-square test was used to show the inferential statistics. So this is a major percentage distribution of the demographic variables. That is 36% were in the 20 years of age, and 54% of the total participants were using the online were in the online classes for about 5 to 6 hours per day. So the results of the study showed that 2% of the participants had good attitude, and 97% had moderate attitude, and 1% had poor attitude, and none of the demographic variable has been found associated with the level of attitude. So the present study has been supported with the similar studies which was done by Rocky Gaur et al. And Dikti Koirala. Limitations of the study was found to be the study was done only in a single setting with just 100 samples, so hence generalization could not be possible. So the recommendations, it can be the study can be done in the multi-centered multiple areas. It can be done for ensure the generalization, and the similar studies like issues and needs during the online classes can be focused. So to conclude with, the further investigations on the needs and the betterment of the online classes has to be done. So these were the few references. Thank you. Stop sharing.
Thank you so much for that presentation. Dr. Chair, do you have any questions?
No, you can proceed.
All right,
Thank
and
thank you.
Yep, let me go on your next presenter. Rose, may I invite Rose Benter or Louis, Dr. K. Bituko, University of Nairobi, Kenya. It's the prevalence and factors associated with burnout among nurses in sub-county public hospitals, a case of Homa Bay County, Kenya. Hello? Yep, go ahead, please. I can't hear you. Hello?
Good afternoon, good evening. Are you able to hear me, ma'am?
Yes, I can hear you now. Thank you so much. Yes, go ahead and share your screen, please. Hi, Rose Benter, welcome.
Thank you. So, my name is Rose Benter, a PhD student at the University of Nairobi. I have two supervisors, Dr. Lucy Bitok and Dr. Miriam Wagoro. I'm here to present my part of my PhD project on prevalence and factors associated with burnout among nurses in sub-county public hospitals, a case study of Homa Bay County, Kenya. This is the outline of my presentation. In the background of the study, healthcare professionals and most of the nurses have a high risk of burnout. The World Health Organization declared burnout as a mental health problem. Burnout is defined as a condition associated with many symptoms characterized by three aspects, including emotional exhaustion, depersonalization, and reduced personal accomplishment in individuals involved in people's work of some kind. There's paucity of research evidence on prevalence and factors associated with burnout among nurses in the sub-county public hospitals in Homa Bay County. This study aims to bridge this gap. I had 4 objectives for the study: to examine the magnitude of burnout among nurses in this setting, to assess socio-demographic factors associated with burnout, to determine professional factors associated with burnout among nurses, and to establish individual factors related to burnout among nurses. The methodology of this study, research approach is quantitative. The design is cross-sectional study. The variables, the independent variables were demographic, professional, and individual factors. The dependent variable was the burnout-related dimensions, which are 3, including emotional exhaustion, depersonalization, and personal accomplishment. The duration of the study was 2 months for data collection, and the study is going on till now. The study settings were 3 county sub-county hospitals, including Rachonyo North, Rachonyo South, and Suba sub-county hospitals, with a sample size of 80 nurses. I allocated the sample proportionately based on the number of nurses per strata, that's the hospitals, and then conducted simple random sampling using computer-based programs. The nurses were randomly selected after a proportionate calculation of the sample. Inclusion criteria were nurses who have worked for 1 year and more, and exclusion are those nurses who were not willing to participate and those who are working in the critical care units. In the data collection procedure, we had data collection tools, included self-administered questionnaire, including 4 parts. That is socio-demographic characteristics, part 2, professional, part 3, individual factors, and then part 4 had the much large burnout inventory, which is made of 22 items, including 9 items for emotional exhaustion, 5 items for depersonalization, and 8 items for personal accomplishment. I used descriptive and inferential statistics, and data collection followed ethical approval from Kenyatta National Hospital and University of Nairobi ERC and the National Research Ethics Committee called NACOSTI. This is how scores were interpreted for the much large burnout inventory. And these are the findings of the study. So the findings of the study followed the factors which were considered in the study. And the key ones included that the female were the majority, that is 75%. Most of the nurses were between 25 to 35 years. And for the professional factors, majority of the nurses were diploma prepared nurses, with 4 nurses only who had a bachelor degree in nursing. Only 14 nurses were able to attain trainings, to be able to attend training within 1 year. And we had a significant number of 12 nurses representing 17.6, working for 50 hours and above. Also in individual factors, majority of the nurses had high self-worth, and some of them, that is 44.2%, perceived a sense of insecurity in their job. In the magnitude of burnout, which is the key finding for this study, in this setup, burnout was prevalent at moderate levels, and the magnitude for emotional exhaustion, we had high scores of 63.2, having high scores in emotional exhaustion. We had 70.6% having high scores in depersonalization, and then we had 92.6% perceiving that they had high personal accomplishment. In the relationships between the dimensions of burnout and on the factors which were postulated in this study, we found that there was no significant, statistical significant relationship between gender, age, and emotional exhaustion, whereas in marital status, there was a significant relationship with EE. And also on the professional factors, there was no any significant factor among the professional factors in as related to emotional exhaustion. Individual characteristics in relation to emotional exhaustion, there were two factors which were significant. That included the feeling of insecurity in the job and perceived external control in one's job. And in the relationship between individual characteristics and depersonalization, which is another dimension of burnout, Fisher's exact test showed that neither gender, age, and marital status were related to depersonalization. And the professional factors, none of the factors, again, including qualification, attendance of further formal courses, designation, years of practice, hours of work per week, and preference for any shift, none of them had significant association with the personalization. There was significant relationship found between feeling of insecurity in one's job and perceived external control among nurses in the sub-county hospital. The other factors, which were individual factors, did not have any significant relationships. In the last dimension of burnout, which we were postulating the relationship between socio-demographic factors and the personal accomplishment, and none of the socio-demographic factors was associated with personal accomplishment. Looking at the professional factors and personal accomplishment, there was a significant relationship between hours of work per week and personal accomplishment. All the other factors, professional factors, were not significantly related. And in the relationship between individual characteristics and PA, there was no any significant association between PA and any of the individual factors. In the discussion of this study, the main thing that was coming out is that the gender, age, and marital status were not significantly related to personal accomplishment. But it contradicted a study which was conducted in China, which was suggesting that there was a significant relationship between personal accomplishment, gender, age, as well as marital status. And these differences may be explained by the context of the study and the cultures of the Chinese people compared to that of the Africans. And also, in my study, we found that there was high emotional exhaustion, high depersonalization, and high personal accomplishment. So whereas the nurses felt that they were very emotionally drained and they had negative, their persons changed, they were dispersonalized, but they could still perceive that the accomplishment in their current job was high. This does not corroborate the other findings which were found in previous studies. For example, in US and in Brazil, there was high EE, high DP, but there was low personal accomplishment. That also agrees with the study which was conducted in Venezuela. So this contradicts our finding, and maybe how to explain this, it could be that the Africans have higher resilience and they have some characteristics that make them have hardiness when they're doing their work, and so despite the high emotional exhaustion and depersonalization, they still feel that they are able to achieve much. The limitation of this study is that all the subjects were selected from public hospitals in the county, and so generalizability may be limited only to these settings. The implication for the study is for the nursing administration: one, the managers should modify significant factors such as job security, perceived external control, and the hours of nurses' work each week. In addition, they should be able to develop relevant guidelines for preventing burnout. Individual-based interventions considering one's personal factors such as resilience, hardiness will be considered while
please wrap it up
for burnout. And then this study, in terms of research, it could be replicated to other setups, and also an qualitative inquiry could be conducted to get more insight on the factors related to burnout. In conclusion, in the current study, a majority of the nurses experienced high EE, high DP, and high PA in these hospitals. Therefore, modifying factors such as job security, perceived external control, and the hours of work each week would be helpful to reduce burnout among these nurses, and also developing relevant guidelines for preventing burnout would also be helpful. These were my references. Thanks, ma'am, for the opportunity, and thanks everyone for listening to me. That's the end of my presentation. Thank you. Any questions? Ma'am?
Any questions from our chair? All right, it seems none. Thank you so much for that presentation, Roslenter. Thank you so much. And now I would like to invite Mahalashmi M. Kamashi Memorial Hospital, India. The topic is about the effectiveness of relaxation techniques to reduce the stress among senior citizens residing at old age home. Mahalashmi. Mahalashmi. All right, let's go ahead and proceed with our next presenter then. Seema Rani, Jamia Hamdard, Deemed to be University, India. The topic is descriptive study to assess the anxiety and identify coping strategies related to COVID-19 pandemic among student nurses. Seema? Seema? Seema Rani?
Ma'am, please unmute.
I'm sorry?
Please unmute me.
Yes, I can hear you. Go ahead and share your screen, please, and you have 8 minutes.
Okay. Okay. Am I audible and my slides are visible?
Yes, go ahead.
Okay. Thank you very much, organizers. This is a great opportunity for me to interact with such an international community, my co-professionals. Greetings from India and from myself. I'm going to present my study, a descriptive study to assess the anxiety and identify the coping strategies related to COVID-19 pandemic among student nurses. There were other co-investigators with me, but I'm going to present it. We all know that pandemic has caused lots of concern among the entire society, and students are also not untouched, especially so when they are health professionals, they are nurses, and they have been affected in more than one ways. Like they have started with from offline to online mode of teaching learning has started. Parents might have lost the job, distance education, loss of personal touch, loss of friends. So investigators thought of taking up the area, and because of the temporary school closures, another anxiety concern was there. I'm sorry, you have to bear with my bad throat, everyone. And globally, 90% of the world's student population was affected due to this pandemic. And so in this background, and I believe personally, all the investigators believe that good mental health is absolutely fundamental and it's absolutely necessary for overall health, and anxiety being one of the important component of mental health. And so we thought, like in clinical practice also, they need if they're anxious, student nurses are anxious, then they will lose confidence, they might commit mistakes which might cause further damage to the human lives. And there were other concerns. They could not go out because of the lockdowns in India. And there were many studies that I came across which address the issues and challenges in higher education system, also related to anxiety in nurses, but specific to student nurses. We thought that we will take up this study. So this study was initiated with these two objectives, as the statement suggests. Methodology adopted was a quantitative approach. Descriptive survey design was chosen, and population was student nurses. And for the current study, 300 UG students from a selected college of nursing in India was there. Purposive sampling technique was adopted, and to collect the data, primary data, a self-structured questionnaire and a 4-point Likert scale was used in the form of Google form, and the data was collected during during the months of May and June 2021. When we tried and tested the tool, so it took around 20 minutes on an average for each subject to complete the questionnaire, and data was analyzed employing descriptive statistics. Prior to starting the tool giving data, they were asked to give the consent online. Delimitation of the study was that it was delimited to the subjects who had access to smartphones, who were internet users, and who could comprehend English. Okay. So age in years, as the students were all undergraduate students, and in India, like there are two programs in UG, that is diploma and degree. So all the students from all the sections from all across the course, they were taken up, and the age was like 17 to 25 years, and most of them were in the age group of 20 to 22 years. 71% of them were females. They were all Indians. Most of them were Indians, and most of them lived in urban areas. Okay. So as I said, they spread all across. So this is the spreadsheet of from where the sample came. So this section comprised of the anxiety. There were many standardized tools, but still we preferred to choose the self-structured questionnaire because we thought it will be area specific, it will be community specific, and culture specific as well. So there were very little items that were taken up, that were included in this study, like in internet facilities, although 33% did not have good internet facility, and 86% thought, 87% thought that online classes were not enough to gain the knowledge, that caused anxiety in them, and they also were worried that semester would be delayed. So because a delay in the semester would translate into the delay in earning for the family, for themselves. So that also caused anxiety, and students wanted, 84% of them wanted to resume the clinical posting, although it was not allowed during that time. And when asked that how many of them, their family members were suspected with COVID-19, so around half of them said that they were diagnosed, the family was, friends or family was diagnosed or confirmed with COVID-19, and 32% good chunk of the sample, good chunk of the subjects, they said that they had given care to the family members or friends at home during this pandemic. And 37% of them expressed that their family members had lost the job during this period. Okay. And they had to take care of the community. They had the job as provider. So 13 or 14% of them thought that they had taken up the job, and they were not satisfied. Most of them were not satisfied with their daily routine, and they became more irritable. Like good 73% said that they became more irritable during this period. And they were always preoccupied with the idea of contracting.
Please wrap it up.
Half of them said that they were preoccupied with the idea of contracting COVID-19, and they also had suffered with the slight symptoms. Then they, out of anxiety, they followed the news related to this. Like most of them, like around half of them said yes, and 1/3 of them said sometimes they follow the news. Because social media also caused anxiety in them. Then when asked that would they like to contribute as a health worker in this pandemic time, as there was an acute shortage, health professionals were falling sick. So 48% of them expressed yes, they would like to, or good 40% said that they are not sure whether they would like to work as health workers. The news of losing somebody in the family also caused anxiety in them, and 26% of them themselves were suspected with or finally confirmed diagnosed with COVID-19. And out of them, around 90% of them were managed at home, and 10% had to be hospitalized. So we can well understand if one person in the entire batch gets hospitalized, the others get anxious. So this was quite a horrifying number. And then they were asked that do they miss in-person interaction with the peer during this period? They said very much yes, and only 24% said that it does not matter to them, and another 24% said that they were helpless. They felt helpless. They didn't know what to do. Then
thank you so much.
Yeah, but no. Then regarding the anxiety levels, when we saw that what is the anxiety level among the students in total.
Please do wrap it up. It's
yes.
over time.
Okay, so 86% of them fell in the group of moderate anxiety levels. When came so which is a big number, although severe anxiety level was expressed in 0.4%. That is, and the reason when we found out because one of them had lost the father in the family, so it was really sad. So that caused more anxiety in them. Then the coping strategies which they adopted was varying, because some of them avoided, some of them learned to live with the situation, some of them were okay with the situation. Then they started helping others, humanitarian grounds, so they started helping others, or they adopted some other, like other people were sick in the community, so they started cooking for them, procuring medicines for them. And when these results were compared with other studies, so these results were not in complete agreement with other studies, but they were in partial agreement, or they were more or less supported by other studies when it came to anxiety. And they were also in partial or total agreement with the studies related to the coping strategies. And these are the implications. So we just thought that nurse educators have to take lessons from the students' feedback about anxiety, and online classes as well, and hybrid mode of learning and teaching may become a new normal for the institutions, but it leads to drastic occurrences which further progress towards anxiety, and nurse administrators have to be prepared for addressing the issue. More in-depth research studies need to be taken in this area. So to conclude, student nurses are part of society and very much affected by the pandemic. However, during pandemic, majority of the student nurses have moderate level of anxiety, and they adopt various strategies to cope with the anxiety. These are the references, and thank you all.
Thank you so much for that presentation.
Thank you.
Dr. Chair, do you have any questions? All right, seems none, then let's go ahead and proceed with our next.
Okay, thank you very much.
Center. All right, I would like to invite Mina Ja to present the paper about the study of ethnomedicinal plants to replace paracetamol. Hi, you're on mute. Hi. Hello? Yeah, but still you're on mute. Yeah, I'm sorry, but you're on mute still. Please, hold on. Is it on our end? Hold on. Can you try it now?
Yes.
All right, perfect. Hello.
Namaste.
All right, good job. Yes, go ahead and share it. There you go. Please have it on presentation mode. And Mrs. Nina, you have 8 minutes.
Yes. So very good evening, one and all, and warm greetings to everyone. And I want to share my screen. Please allow me, because one screen is already there, so it is not allowing me to share. Please allow me. Hello. Hello, ma'am. Please allow me to share my screen. Hello. Am I audible? Yes. Can you see my screen now? Hello, everyone. Good evening. Am I audible? So, ma'am, am I audible?
Hello? You're still on mute? Can you try it again?
Okay. Hello, everyone. Am I audible now?
Yes, go ahead, please.
Okay. And can you see my screen, please? Can you see it? Yes?
Yes, go ahead, please.
Okay. Very good evening, one and all, and warm greetings from Meena Jha. And I'm researcher, Department of Biotechnology from Lincoln University College, Malaysia. And the topic of my today's presentation is study of ethnomedicinal plants to replace paracetamol. So nowadays, we all are popping up for paracetamol for any little diseases. So now the taking points presentation framework is abstract, introduction, literature review, methodology, experiments, results, and obviously conclusion. So this is the abstract, and we can see that all living organisms require food, water, light, everything. But we all are nowadays mostly getting dependent on synthetic medications. Paracetamol is most widely available drug used worldwide. So, but however, the study shows that during the course of time, prolonged use and prolonged exposure of these medicines may lead to toxicity of liver and all. So plants are greatest source of giving us all the benefits. Apart from oxygen, we get fruit, medicine, furnitures, everything. So in this paper, various ethnomedicinal plants like lemongrass, mint, galoy, everything were discussed. And total participants, we have done the questionnaire methods. The main theme of this paper is to create awareness among new generation about more usages of plant products like rhizomes, roots, leaves, branches, flowers, and fruits. Because for every little pains and fevers, we are just popping up the medicines. So why not go to Mother Nature? So the main thing is to create awareness among Generation Z. What our grandparents were telling that, so nowadays people are all forgetting. So the main thing is I want to create more awareness among my adolescents, my students, and new generation. So this is the introduction that health is the most necessary aspect of our life. And due to various reasons we get ill. So acetaminophen was first uses, and due to action of bacteria, temperature, and killing microbes and bacteria. But the need of the hour is to create more awareness through documentation of traditional wealth of treating distinguished diseases by using medicinal plants, ethnomedicinal plants, the Mother Nature. So the main study is this. And by doing literature review, we come to know that we have lot of bioactive compounds in the plant kingdom, which can be used to formulate new therapeutics. For example, the discovery of anti-malarial drug, artemisinin, is used for obtaining sweet wormwood, a medicinal plant. So curative herbs are used as substitute for acetaminophen, that means paracetamol, for curing fever, aches, pains, and other ailments. So the main reason is that plant-based medications have antibacterial, anti-cancer, anti-inflammatory properties. So eradication of causes of diseases like infection, lack of nourishment, genetic abnormalities, doing regular exercises, active participation in outdoor games, and avoiding sedentary lifestyle, we can ward off many diseases. So health is the greatest wealth. So now, after literature review, let me tell you about the methodology and data collection. So Uttarakhand people, the online survey were done because of pandemic time. We cannot meet to them, but telephonically and by framing 50 objective questions through Google Form, through online WhatsApp, and through other email. We also telephonically asked to medicos regarding the usages and prescriptions of painkillers. So all respondents enthusiastically participated and the data was corrected and it was being analyzed. So this is the graph and pie chart which helps us to say that many people still believe that grandmother's technology, that use of using cold sponge when we are having fever, that can also reduce body temperature. And most of the people, you just see 47.4%, they are not knowing even the IUPAC nomenclature of paracetamol. So whatever the medicine chemist is giving, they are just popping up without acknowledging the harmful and the prolonged effects of the paracetamol. So these are the very common medicinal plants which we are growing by our own hands, like tulsi, curry leaves. It is Mother Tulsi, that is the basil, holy basil. We are doing prayers, offering prayers. It is giving us a lot of medicinal value. It is helpful for curing cough and other things. Then Sadabahar, it can even cure diabetes. The research studies say, when we do literature review, we find there are so many plants and trees and leaves and flowers and fruits. They are so useful for curing so many diseases. But our new generation is not aware of that. So it is our duty that we should make them aware that this is the thing. So now the result and discussion. So all the herbs and ethnomedicinal plants are having important bioactive compounds and they have immense potential to overcome paracetamol longer exposure toxicity because they have significant biological compounds. So people living in tribal, forest and rural areas are using plant parts since long. Even our Ayurveda, especially in Indian culture, Ayurveda literature, Charak Samhita, these things are mentioned that how plants are useful. So we must, in order to overcome the long-term consequences and to minimize the toxicity, we must conserve our treasure. We should do more extensive afforestation. We should avoid overgrazing and sustainable developmental approach should be followed to encounter the challenges. So these are the references through which I have taken certain things, and now my time is also very. So Dr. APJ Abdul Kalam used to say, without your involvement, you cannot succeed, and with your involvement, you cannot fail. So I took a lot of initiative. I searched and I experimented on the plant products, and I formulated for curing simple aches and pains. If I drink milk with turmeric and adding ginger, that is really beneficial for curing pains and aches. So thank you so much for your
Thank you so much. Thank you so much, Mrs. Mina Ja, for that very precise and informative presentation. I really do appreciate that. Yep, and yeah, let's go ahead and proceed with our next presenter, Mrs. Sanjukta Dixit, a comparative study in caregiver burden among caregivers of cancer and mentally ill patients.
Thank you so much. Thank you.
Thank you.
All the queries are welcome. Thank you, madam, and thank you everybody for listening so beautifully.
Thank you so much. Stay smiling.
Thank you, ma'am.
Hi, Sanjukta. You cannot unmute. Hold on. Right, go ahead, unmute, please. Oh, sorry. Go ahead.
Hello.
Yes.
Good evening, ma'am.
Hi, good evening.
Am I
Please. Yes, you are. Please go ahead and share your screen, and you have 8 minutes.
Okay. Thank you, ma'am. Good evening, everyone. Myself, Sanjukta Dixit, and I am going to present my paper. Welcome you all to my paper presentation. The title of my study is A Comparative Study to assess caregiver burden among caregivers of mentally ill and physically ill patients availing outpatient services at selected tertiary care hospitals in Bhubaneswar, Odisha. The objectives of my study are to assess the level of caregiver burden among caregivers of mentally ill and physically ill patients, to compare the level of caregiver burden among caregivers of mentally ill and physically ill patients, to determine the association of caregiver burden with selected demographic variables of mentally ill and physically ill patients. Introduction. Diseases have become nowadays a part of human life. However, some diseases like mental illness and cancer cause wide-scale morbidity and make a person dependent on others. However, progression of such diseases will more stress on the family members involved in the process of caregiving. A caregiver is a person who fulfills all needs of the diseased individual. A full-time caregiver has to give up all his personal habits, leisure time, neglect his own health, ignore other family members, undergo financial constraints, and in extreme cases, leave his job to be with the patient. Various factors are responsible for enhancing stress of the caregiver and hence make the caregiver vulnerable to various mental and physical problems. So the caregiver burden refers to the strain or load borne by a person who cares for a chronically ill, disabled, or elderly family member. The present study intends to explore the degree of caregiver burden prevalent among caregivers of mentally ill and cancer patients and the factors associated to it. So my hypothesis there will be significant difference between the caregiver burden scores of mentally ill and physically ill patients at 0.05 level of significance. Second hypothesis is there will be significant association between caregiver burden and selected demographic variables of mentally ill and physically ill patients at 0.05 level of significance. Methodology. The research approach is quantitative research approach. Design is descriptive. Settings of my study included psychiatric OPD and oncology OPD of PBMH KIMS Bhubaneswar, Odisha. Duration of data collection was from October to December 2019. The samples of my study included caregivers having a score of caregiver burden more than 21 as assessed by a Jared burden inventory and fulfilling the inclusion criteria. Sampling technique was purposive sampling and the sample size was 128. It included mentally ill patients 70 and physically ill patients 58. Sampling criteria, the inclusion criteria included caregivers who were living and caring the patient for more than 1 year, who were key caregivers, who were present on the day of data collection and gave consent to participate in the study. However, the study excluded those caregivers who were being hired by the client or client family and were diagnosed with mental illnesses previously. So the tools used for my study were socio-demographic proforma to assess the socio-demographic variables and Jared burden interview to assess the caregiver burden of the caregivers, and the method adopted was paper pencil method. Data analysis, data was analyzed through 3 sections. Section 1, it included the collection of frequency and percentage collection of the study variables. So the table 1, it shows the frequency and percentage distribution of study variables. Out of 70 mentally ill persons, 44% belong to 45 to 59 years of age, whereas 49% among physically ill patients belong to 30 to 44 years of age. However, 60% of mentally ill patients were female, whereas in physically ill, 64 patients were female. And on the basis of area of living, 52% people belong to rural area among mentally ill patients, whereas for physically ill patients, 66% of caregivers belong to urban area. Then duration of disease, 45% of caregivers of mentally ill patient had their attendant or the patient suffering from the disease less than 5 years, whereas for physically ill patient, 44% of the caregivers had the patient suffering from the disease more than 10 years. Duration of caregiving, 44% of the mentally ill patient, the caregivers of the mentally ill patient were providing care for more than 10 years, whereas for physically ill patient, 57% of the samples were providing care for 5 to 10 years. And marital status, in both the cases, in both the groups, 88% majority of the samples were married. Section 2, it included the comparison of caregiver burden scores among the caregivers of mentally ill and physically ill patients. So among mentally ill patients, 64% had severe caregiver burden, whereas 16% had mild caregiver burden, whereas in case of physically ill patient, 52% had moderate caregiver burden and 18% had severe caregiver burden. Next, test of significance with respect to caregiver burden score, it came out that there existed a statistically significant difference among the caregiver burden between mentally ill patient and the physically ill patient, as the p-value was 0.048, and the p-value was considered less than 0.05 as the significance, as the center for significance. Then section 3, association of socio-demographic variables. So it was found that age, gender, marital status, and duration of illness were found to be significantly associated with caregiver burden of mentally ill patients, whereas family type and family income were found to be associated with a caregiver burden of physically ill patients at p-value less than equal to 0.05. A discussion, a comparative study conducted previously by Anukant Mittal, Shali Ganesh, Sabnis, and Brushalis in 2015 to assess caregiver burden of 200 caregivers of medical versus psychiatric patients, conducted by taking 100 from each group from the psychiatric department as well as medicine department of tertiary municipal medical college, revealed that from the medicine department, 64% were females, whereas 36% were males, and from the psychiatric department, 62% of the caregivers were females, whereas 38% were males. Severe caregiver burden was reported in 26% caregivers of medical patient and 70% of psychiatric patients, and statistically significant difference was found in the caregiver burden score among the two groups. The present study, the findings of the present study are very much similar to the study depicted above, which revealed that
Please wrap it up. 8 minutes already.
was found in 64% of caregivers of mentally patient and 18% of physically ill patients. And statistical significant difference was present in caregiver burden scores of both the groups. So limitations of this study are small sample size, non-randomized samples, limited time period, and caregivers of all categories of mental ill, whereas cancer patients were taken, for which the findings cannot be generalized as a whole. Implications, policies for launching stress reduction programs for the caregivers can be started in the hospital. And recommendations are similar type of studies can be conducted on caregivers of hospitalized, mentally ill and physically ill patients, among caregivers of various other types of mentally ill patients, and also to assess coping strategy, quality of life, and emotional intelligence of caregivers. So the conclusion of my study is that,
please wrap it up.
Burden due to caregiving is more caregivers of mentally ill patients and compared to caregivers of cancer patients. As the caregiver burden increases, it results in frustration, poor functioning that affects personal and occupational domains. So these are my references, and thank you very much for giving me this opportunity.
Thank you so much for your presentation. And now let's go ahead and invite our last presenter for this technical session, Ms. Thivya, Satyabama College of Nursing, Effectiveness of Peer Education, Interventions and Knowledge Regarding Dengue. Hi, Ms. Thivya. Oh, the mute, one moment. All right, can you unmute yourself, please? Perfect. Go ahead. I still can't hear you. We cannot hear you. You are unmuted, but we cannot hear you. Is it just me, or can you hear her? Yep, we can't hear you. Can you hear her?
Yes, good evening to one and all present here. Myself, Divya, Associate Professor, working in Satyabama College of Nursing, Satyabama Institute of Science and Technology, Chennai. So I am the Principal Investigator and co-authors, Dr. L. Lakshmi D, Ms. Bhuneshwari, Associate Professor, Ms. Nancy, and Ms. Nandini, all are working as a faculty. So the title of the study we are selected is to assess the effectiveness of peer education interventions on knowledge regarding dengue fever among adults in selected areas, Kanchipuram district, Tamil Nadu. So coming to the background, dengue infection is generally considered to be a pediatric disease, but is currently a growing problem in adults throughout the tropics. So half of the world's population is now at risk. There is an estimation of 100 to 400 million infections each year. So according to European Center for Disease Prevention and Control in 2021, this Indian country is affecting around 60112, but half of the world's population is now at risk. So there is an estimated 100 to 400 million infections each year. The combined effect of COVID-19 and the dengue infections epidemics is causing potentially resulting in devastating consequences for the populations at risk. So we selected the peer education intervention as a widely used method and generally a low-cost intervention in conveying information in natural settings, whereas target groups are located. So the objectives of the study is to assess the existing knowledge on dengue fever among the adults, to evaluate the effectiveness of peer education intervention on knowledge of dengue fever among adults, and to associate the post-test knowledge on dengue fever among adults with the selected demographic variables. So statement of objectives are the effectiveness, that is assessing the usefulness of intervention to promote the knowledge of dengue fever. Peer education intervention is conveying information in natural settings where target groups are located, and knowledge of dengue fever, that is causes, risk factors, signs and symptoms, diagnosis, treatment and prevention of dengue fever. Then adults between the age group of 18 to 45 years who were selected for the study. So coming to methodology, a research approach is evaluative approach, and research design is quasi-experimental research design, that is one group pretest and post-test design. Setting of the study is selected rural areas, Kanchipuram district, Tamil Nadu, and sample size is 60, and sampling technique is a random sampling technique. So the data collection methods, the duration is from 27/9/21 to 29/10/21. So semi-structured interview schedule was used as a knowledge on dengue fever. Here we selected 5 adult educators were taught about the dengue fever, and they in turn taught to the other adults under the supervision of the investigator. So post-test for each samples was collected on the 7th day of intervention for each adults. So study instrument, it contains section A and section B. Section A contains the demographic variables like age, sex, educational qualification, living area, type of house, monthly family income, source of information on prevention of dengue fever. And section B is a knowledge questionnaire related to dengue fever, such as causes, mode of transmission, signs and symptoms, management and prevention. So here it is the intervention. We conducted pre-test for all the samples. We are making intervention by using AV8s like flashcards, video assisted teaching program. So each intern 5 samples we taught. They in turn taught the other samples. So the post-test was conducted on the 7th day of intervention. So coming to the results, in the pre-test all the adults are having the inadequate knowledge. All 60 samples comes under the inadequate knowledge. And the second objective is the overall post-test mean value knowledge score is 23.61 with a standard deviation of 2.98, which was more than the pre-test mean value 7.81 with a standard deviation of 2.78. This shows that the peer education was effective. There was no significant association between the post-test knowledge level with all other demographic variables what we selected. So by concluding, the study helps to improve the knowledge, especially through peer education intervention. It is an effective intervention to promote the knowledge on dengue fever. And like this, practical health education programs should be organized. It gives more benefits and exposure about the effective practice as dengue fever prevention. Thank you so much for the
Thank you so much for your presentation. Very precise. Thank you so much. And yes, Dr. Chair. Thank you so much, everyone. I would like to congratulate all the presenters who presented today. Thank you so much for your time and your research of imparting to all our viewers. And now that concludes our conference, the Asia Pacific Conference on Nursing Science and Healthcare, December 1 to December 2, this year 2021. And all certificates and updates and all feedback link and everything will be sent to you via email within 5 to 7 days. So please, yeah, take a look at your email once in a while on your registered email. And I would like also to thank all our honorable dignitaries, our keynote speakers. Thank you so much, guys, for imparting your time with us. And once again, this concludes our conference today. This is your host, Jojo Mehay. Have a great day, everyone. Good night.